Family history includes consanguinity, unexplained deaths, recurrent family deaths. Birth details include gestational age, delivery complications, whether the baby has cried immediately after birth or not. Symptom onset is very important because the day of onset of seizures also defines some etiology. So symptom onset is very important, whether it is early, less than 72 hours, or it is late. And the treatment response is also important, whether what medications have been tried, what doses. The red flags for IEM includes history of increased fetal movements in utero. So that may be important for non-ketotic hyperglycemia, parental consanguinity, unexplained neonatal deaths in the family, deterioration after a period of normal period, seizures related to feeding and abnormal odor. Physical examination, we should see for dysmorphic features, signs of any sepsis, torch, neurocutaneous markers, tone examination, and ophthalmologic findings as well. Biochemical investigations includes basic metabolites that I've already talked. ABG is very important because that will give about information, lactate, acidosis. Infection markers are important, just like any other baby. Metabolic screening also includes glucose, ammonia, ketones, pyruvate, and specialized tests should be sent whenever we are thinking etiologies beyond normal causes. For example, if glycine is high, it will be non-ketotic hyperglycemia. Serine low, it points towards the serine biosynthetic defects. If uric acid is low, it points towards molybdenum cofactor deficiency. Uric acid is a very simple test that can be done in any clinic, in any ICU, and that is a very important clue for molybdenum cofactor deficiency, and the report is also available immediately. Homocysteine high points towards MTHFR deficiency, and plasma fatty acids high points towards the peroxisomal disorders. Branched chain amino acids high points towards the maple syrup urine disease. CSF analysis is very important. Apart from the standard test, specialized test can be sent for glycine levels for non-ketotic hyperglycemia, and CSF and blood glucose ratio is important to rule out GLUT1 transporter defects. Brain imaging is important. For the immediate causes, we can do bedside ultrasound, IVH, we can see echogenicity, we can see for cerebral edema as well, we can see for some structural malformations as well, like corpus callosum agenesis is there, or posterior fossa, some defects are there. We can see for USG. For MRI, HI, developmental defects, IM patterns, some patterns are specific to MRI, like cystic encephalopathy. Early cystic encephalopathy is important for sulfite oxidase deficiency. MRA and MRV, they are important to rule out stroke and vascular malformations, and MRS is a signature for metabolic signature. So if we talk about MRI patterns in IEM, then pyridoxine deficiency can have white matter abnormalities, corpus callosum changes, and hemorrhage. Biotinidase deficiency can have abnormalities of Plick sign, corpus callosum, and corona radiata. Non-ketotic hyperglycemia can have dysplastic corpus callosum, lack of Plick myelination. Molybdenum cofactor deficiency can have white matter changes with cystic evolution, a very close mimicker for HIE, but it will be early. Zellweger syndrome can present like lenticulostriate, vasculopathy, polymicrogyria, and germanolytic cyst. They're not 100% findings, but they do give a clue towards the IEM. The transient metabolic disorders should always be kept in mind. The first thing that we should think is not something very rare. The first thing that should come into our mind is something common. So we need to rule out sepsis, we need to rule out basic screens, we need to rule out hypoglycemia. If we are treating all the things and we did not do the blood sugar test, then it will be refractory. It will present as refractory. Kernicterus can also lead to seizures. In MRI, it will present as increased T1 signal intensity in globus pallidus and kernicterus, and in hypoglycemia, it will present as prominent occipital abnormalities on MRI. And if we talk about EEG and AEG, then if facilities are available, we should do EEG. And when to do EEG? As early as you can. There is no timeline then when we should do EEG. It should be done as early as possible. We can repeat EEG once the baby has stabilized to know whether the seizures are ongoing or not, what is the response to the treatment. But if EEG is normal, it doesn't mean that baby is not having seizures. EEG will only detect the cortical activity. EEG may miss the subcortical and the deep seizure activity. So EEG is a gold standard for diagnosis. That is important. And if we have in our setup, that is a very good thing. For genetic testing options, because everything cannot be detected through the things we have already discussed, like IM panels, urinary GCMS, extended metabolic panels, we need to send clinical whole exome sequencing sometimes for mitochondrial DNA, for mitochondrial disorders. Targeted panels are also available these days, like epilepsy-specific gene panels. Specific genetic tests are available for specific disorders, like SCN1A analysis is available for Dravet syndrome, STXBP1 deletion or duplication for epileptic encephalopathy, and epileptic encephalopathy gene panel is also available. So when things are not going as expected, genetic tests should also be kept in mind. They may not be available immediately, but definitely it will help in the further counseling for the parents. Talking about the treatment, so we know that the first line for the neonatal seizures, we will be giving phenobarbital, then second line maybe levetiracetam and phenytoin. Third line will be given as a midazolam infusion. So if I talk about seizures algorithm, what we have learned, first is stabilization or airway, breathing and circulation, glucose, calcium, early EEG if possible. Identify the reversible causes like hypoglycemia, like hypocalcemia. There should be zero delay in the first dose. We should use second AED if it persists even after using the maximum dose of the first anti-epileptic. Refractory seizures, drug 1 failed, drug 2 failed, then we need to consider infusion of the midazolam. We need to evaluate for metabolic causes simultaneously, but we should not delay the treatment meanwhile. So phenobarbital, it is 20 mg per kg, then followed by 10 mg per kg. Some again they give a loading of 10 mg per kg if it is needed, and the response has been shown to be around 50%. For levetiracetam, the second drug, it is around 40 to 60 mg per kg of loading, and then we can go up to the maintenance of 62 mg, 80 mg per kg. For phenytoin, it is 20 mg per kg and 10 mg per kg if needed. Very important is adequate dosing is essential before calling it refractory. Suppose the baby is still seizing after phenobarbital, after levetiracetam, and there is no control, we need to add infusion. We need to add midazolam infusion. We can think of lidocaine infusion, especially in the HI babies, and thiopental or ketamine also can be thought of as a last resort. Pyridoxine trial is very important. When seizures, they are not being controlled at any point, then we should think of vitamins, we should think of metabolic cocktail. Pyridoxine trial can be given for refractory seizures, 100 mg IV trial, and apart from that, metabolic cocktail like pyridoxal 5-phosphate, biotin, folinic acid trial, and magnesium, calcium, carnitine, vitamin B1, and vitamin B6 can be added while we are waiting for an investigations. We should not delay in the treatment. We should not delay in the escalation. We should treat as early as possible. Now, for our case, what happened next? Adequate doses were given, but the baby was continuously having seizures. We started midazolam infusion and EG improved after 1 hour. So seizures were controlled, and meanwhile all the workup that was thought of, that was sent. So EG, initially this EG was showing burst suppression pattern, and this EG that came to continuous voltage. A word about fosmanogine versus phenobarbital. Recent study in the Child Journal of Neurology that compared efficacy as first-line treatment for both. Both were equally effective for acute seizure control, but fosmanogine showed better neurodevelopmental outcomes at 18 to 24 months. So phenobarbital is sometimes thought of as a neurodevelopmental is a concern for the phenobarbital. Levetiracetam is a new drug that is being used as a second line of management most of the times at most of the centers in India, and it is having minimal hepatic metabolism, minimal protein binding. Drug level monitoring is not needed like in phenobarbital. We need to see sometimes the levels of the phenobarbital, and it has an excellent safety profile, and IV and oral forms are available. It is said to be neuroprotective and anti-apoptotic in animal studies as well. NeoLIV-2 recent trial, the key finding was that phenobarbital was more effective than levetiracetam in controlling the neonatal seizures. So the first line of drug effectively remains the phenobarbital. If we talk about midazolam versus lidocaine, lidocaine showed better response as second line compared to midazolam, and lidocaine was more effective in reducing seizure burden. But it has narrow therapeutic window, potential for arrhythmia, hypotension, and seizures at high doses. So it should be used with caution. Topiramate is another drug, and currently it is being evaluated as a neuroprotective agent in HIE rather than as an anti-epileptic. Trials are going on. Other options are so many, but they are not proved. The trials are going on. Immunotherapy and keto has also been thought of, like methylprednisolone pulses, IVIG, plasmapheresis, ketogenic therapy, and gene-specific therapy that is evolving. Methylprednisolone pulses can be used for some autoimmune causes of epilepsy.
Dr. Priyanka, I think we'll have to wrap up.
Okay, yes, ma'am. It is almost the last slide. For ketogenic diet in neonates, the benefits are improved seizure control. Actually, my phone is only ringing. Yeah, please. Improved seizure control and increased alertness. These are some neonatal epilepsy syndromes with the day of onset. These are precision therapies for sodium channelopathies, for KCM mutations, for SLC13A5. If it is there, then the specific therapies can be initiated. So key takeaways for the presentation today will be refractory seizures need rapid escalation, dose correctly and don't wait. Think metabolic and vitamin responsive etiologies early. EEG is a friend of ours. It is not a luxury. So try for an EEG machine in your NICU. Every minute saved is equal to every neuron saved. This is a QR code that you can scan to have the seizure management algorithm. That's it. I think cases I have put, but there is no time. If anybody wants to answer, so anybody can answer for this. Very easy. A neonate with seizures and rapid cystic encephalopathy, which metabolic emergency must be ruled out within 24 hours. We just talked about cystic encephalopathy, a close mimicker of HIE. Anybody would like to answer this? NKH, sulfite oxidase deficiency, pyridoxine dependency, or maple syrup urine disease? Okay. So it is sulfite oxidase deficiency that rapidly evolves into the cystic encephalopathy very early. Thank you.
Thank you, Dr. Priyanka, for your excellent elaboration on neonatal seizures. Are there any questions? Maybe we could take one question from the audience. So if there are none, sorry.
You have mentioned that levetiracetam FDA approved only more than 1 month, but every NICU using levetiracetam.
Yes, sir.
And all over country.
Yes.
So what is the take point for that?
Most of the drugs that have been studied in neonates Basically, we are using in neonates as well. So it is because it is having an excellent safety profile, no minimal hepatic metabolism. So it is safe to use. Studies have shown that it is safe to use even in neonates. So many studies have been done on neonates and levetiracetam. So we did not find any side effects for this. So that's why we can use. Like phenobarbital is having so many problems also. Still we are using because it is efficacious. So the point is the seizure control is very important. And levetiracetam itself is not having any side effects. So many studies have not found any side effects. So that's why levetiracetam can be used. We have not used, sir. We have not used. Only theoretical purpose I can say I have written. But actually what we do is phenobarbital, then we go for levetiracetam, and then we go for phenytoin. After that we start midazolam infusion, and then we go for the metabolic cocktail, vitamins and metabolic cocktails. So lidocaine usually we do not use, sir. Ma'am, if ma'am has used, she can tell her experience.
Same here. I think we have also not used lignocaine. Although I think the WHO's seizure recommendation does recommend lignocaine as a second line drug over phenytoin and levetiracetam.
Yes, ma'am.
So, as a
Not as a neuroprotective, sir. We have used topiramate in refractory seizures only. After we have seen failure of the first 3 or 4 drugs, topiramate does get added on, usually by our pediatric neurologist, but not as a neuroprotective measure. I mean, at least in clinical domain. But I think there are again a lot of studies coming up about its utilization for neuroprotection.
Okay, thank you.
Thank you, Dr. Priyanka. I'll hand over back to the Hall C managers for the next session.
Thank you, ma'am, for an elaborate session. Ma'am, I request Dr. Aparna, ma'am, to hand over a memento to Priyanka, ma'am.
Next presentation.
Our next session is regarding the neuroimaging. It is a very important and very interesting session. It's going like a debate. Please everyone stay here. Now I request the next topic will be neuroimaging at the finish line, MRI versus ultrasound in preterms. The session will be going like 2 lectures followed by a debate. Initially, the first session is the speakers are Dr. Vanati Hemant Kumar and Dr. Aparna Madam. Dr. Priyanka Gupta will be chairing this session. Now I request Dr. Vanati Madam to start the session.
Alim is supposed to be there, sir. Okay, sir. He's there. He's Dr. Alim. Okay. We could not able to contact him.
Sorry, sir. There is a change in the chairperson. Dr. Halim sir is available. So, sir will be chairing this session. Sir. Thanks.
We could not able to contact him, sir. Okay, sir. He was downstairs.
Good morning. The delegates, thank you for coming in time and starting. And we are having my name is Dr. Alim. I'm one of the neonatologists from Singapore. And we have a good session today. Will be an interesting debate. We are having the first debate on cranial ultrasound versus MRI at term equivalent age. Our speakers are Dr. Aparna and Dr. Vanati Vijay Kumar. A brief introduction about Dr. Vanati. She's a senior consultant and HOD of neonatology in Kanji Kamakodi Child's Trust Hospital in Chennai. And Dr. Aparna is neonatologist and senior consultant at KIMS KM's Cuddles at Kondapur, Hyderabad. So without further ado, I will ask the speakers to start the debate session. Thank you.
So very good morning, and at the outset, I thank Dr. Abdul for this kind introduction. And we're going to discuss and debate over something which is, I think, something that we all closely relate to. It is about the ideal imaging modality of choice for the detection, for the diagnosis, and evaluation of preterm brain injury. So why are we having this debate today? You know, this is because we all recognize that. Can I have the slide changing control? So we all know that the identification of preterm brain injury is extremely vital so that we can initiate appropriate neuroprotective modalities and can help the family understand the prognostication. And in some challenges like post-hemorrhagic ventricular dilatation, it may also make the case for appropriate medical and surgical intervention. No, the next presentation. NS.
Use the arrow here. Can you use the arrow here, maybe?
No, it's still not yet come to the PPT. Okay. So choosing the right modality affects the speed, safety, and the cost of the evaluation, and hence this discussion. So neurosonogram, as we all know, is a continuous real-time imaging modality that helps us to detect overt preterm brain injury and also its evolution. It's not only safe because it does not require sedation, it doesn't require the baby to be transported to the MRI center, and it is also inexpensive bedside tool that is readily available by the baby's bedside as an ideal tool for frequent and sequential monitoring as well. So it's not just a one snapshot imaging of brain injury, but it also helps us to provide a sequential understanding of the way the preterm injury evolves. And now with the advent of high resolution convex probes, 5 to 10 megahertz probes and linear probes of 10 to 20 megahertz, these probes help us to enhance the detection of subtle white matter injuries which were earlier not readily visible with cranial ultrasounds. And serial NSG can dramatically improve the diagnostic reliability, especially with cystic PVL, and can play a key role in the monitoring of brain growth, which in turn helps us to understand the neurodevelopmental outcomes. So while talking about the diagnostic imaging modalities, let me talk about three important domains in preterm brain injury in particular. First will be intraventricular hemorrhage or germinal matrix hemorrhages, which we all are worried about in the first few days, first week of life. Number two, complications of IVH like post-hemorrhagic ventricular dilatation or PVHI. And thirdly, about preterm white matter brain injury. So let us look at these two modalities in these three primary domains or conditions. So when we talk about IVH, so IVH obviously cranial ultrasound is excellent for detecting all the grades of IVH. We have the Volpe's and the Papilli's classification of different grades that you're all aware. Now, IVH, as you all know, is an early phenomenon. 50% of IVH hemorrhages occur by the first 24 hours, and neurosonogram is extremely sensitive for picking up these early grades of intraventricular hemorrhages. And this is a stage where the baby may not be shifted for MRA because it's just not feasible. The baby is too small and sick. And so early detection, 50% by 6 hours, 16% by the first 1 hour of a bleed is possible with a neurosonogram. Serial monitoring is something that is feasible because early bedside scans can be done and multiple scans can be repeated in the first week. And the timing of injury can be more accurately assessed by the neurosonogram, and sometimes we see early complications, very devastating complications like early onset post-hemorrhagic ventricular dilatation by us as early as 24 hours of a large bleed, and this is also something that a cranial ultrasound can help us detect. And with the advent of posterior fontanelle images, not only the anterior fontanelle, the posterior fontanelle images, the detection of grade 2 to grade 4 IVH is better, and we may argue that probably the only gray area is the detection of temporal lobe hemorrhages, which might be slightly difficult with the neurosonogram. But even in this domain, the sensitivity is fairly good at around 60%. So with the neurosonogram, for the first condition that we deal with often, which is IVH, I would like to say that we are able to see early bleeds, and IVH is known to occur early. We are able to see it often, sequential, so that we can follow up the bleeds that have happened early. And this is very vital for us to secure the outcomes. The second important condition that we do imaging for is for complications of IVH, like post-hemorrhagic ventricular dilatation or PVHI. Now, PHVD develops usually 1 to 2 weeks after IVH, and neurosonogram offers excellent diagnostic diameters or dimensions, like the anterior horn width, the TOD or thalamo-occipital diameter. Then we all know about the utility of ventricular index. So we use the Levine's index or the ventricular index for serial monitoring of these complications like post-hemorrhagic hydrocephalus. And these can be plotted against normative charts like what we can see here to understand whether the baby falls into a safe zone or a zone where the baby needs constant monitoring and SOS referral to a neurosurgeon, and into the red zone where the baby is clearly having a Levine's index, a ventricular index, which is more than 97 centile plus 4 mm, where the baby clearly needs intervention, either in the form of repeated lumbar punctures or in the form of neurosurgical interventions. Coming to the third domain where we often use imaging, which is preterm white matter injury. Here I'm very sure that my other speaker is going to talk to you about the superior sensitivity of MRI in detecting the subtle forms, that is a diffuse white matter gliosis form of periventricular white matter injury. But having said that, serial cranial ultrasounds detects even the non-cystic white matter echogenicity pretty early. And of course, the cystic PVL, which is the most dreaded form of PVL, which of course has become increasingly rarer now in preterm infants, has a very high correlation with cerebral palsy. This can take up to 3 to 4 weeks to appear and can be easily missed on the term equivalent imaging or the term equivalent MRI that is often done after 40 weeks of corrected age. And likewise, extensive cystic PVL can develop in 2 to 3 weeks and may disappear by the term equivalent imaging. So if you do an MRI at 40 weeks equivalent imaging, it is possible that some cysts that had evolved and had disappeared by 40 weeks could be missed, and hence the correlation for this with the long-term neurodevelopment can also be missed. So white matter injury often develops after the first week and needs repeated cranial ultrasounds, and this is where cranial ultrasound fares better because you have the advantage of sequential imaging. And we often now understand that complications like sepsis, necrotizing enterocolitis can also be associated with late onset cystic PVL. Again, cranial ultrasound has the advantage of being repeated often because it's bedside, it is safe, doesn't need sedation, it is easy to perform. Sometimes you may have viral infections that can predispose to late onset white matter injury. Again, this can be picked up with serial repeat cranial ultrasounds. So MRI is a snapshot, is a one-time imaging, whereas cranial ultrasound can be repeated and helps us in detecting evolving white matter injury. And I would strongly argue that the strength of the neurosonogram is that it is a bedside tool, readily accessible for defining brain injury and following its evolution, even in the sickest and smallest high-risk preterm infants, particularly in the first few days of life. Now, if you talk about IVH, you all know that 90% of bleeds would happen within the first 7 days. And this is a time that the baby can't even be shifted for an MRI and usually is too sick for that. So these changes can only be picked up if you have a sequential and repeated cranial ultrasound that is being performed bedside. Now, not only in the detection of these 3 major pathologies, IVH, post-hemorrhagic ventricular dilatation, and preterm brain white matter injury, but also we have now data to show that sequential cranial ultrasound to detect parameters like the corpus callosum length, the cerebellar diameter, corpus callosum size, subarachnoid space, vermis height, all these dimensions or structural imaging can also be used as an ongoing bedside monitoring for structural brain development, and studies have shown that corpus callosum length, CC fastigium have not only correlation with better cognitive outcomes and also improved motor function in the long term. So we also have the advantage of sequential studies of structural brain imaging that gives us trajectories that can be used for prediction of the long-term neurodevelopmental outcomes. So serial cranial ultrasound data provides prognostic data. It identifies the lower grades of IVH early, and even low grade of IVH, grade 1, grade 2, may also have some correlation with later school age cognitive difficulties, and it helps us to track complications like post-hemorrhagic ventricular dilatation. We already know there are various indices like TOD, VI, Levine's index, which help us to follow up these post-hemorrhagic hydrocephalus, help us to predict optimally the need for shunt placement and neurosurgical intervention. And it helps us to define the location of PVHI, which is another complication of IVH. And based on whether this is frontal or parietal, you can get an idea of about the long-term risk of CP that it carries. The use of additional imaging using the mastoid window has also helped cranial ultrasound to detect clinically important cerebellar hemorrhages better. And I would like to focus on this particular study that was published in European Journal of Pediatrics in 2019. So this was one study that came across as interesting because, it compared term equivalent ultrasound, term equivalent age MRI and serial ultrasounds, not only to look at the brain injury, but also to look at long-term outcomes, which is what we are primarily concerned with. So the authors actually graded the injury based on ultrasound and based on MRI into grade 1, grade 2 and grade 3. And what was interesting was that the severe term equivalent ultrasound injury, that is severe injury or grade 3 injury on ultrasound, predicted severe MRI injury with a 100% positive predictive value. So whomever had severe injury with ultrasound also had severe injury with MRI. And on the other hand, having a normal or mild term equivalent cranial ultrasound strongly predicted normal MRI. So it also had excellent negative predictive value when you didn't have moderate or severe injury on ultrasound, that we are very likely to find a normal MRI. And did it help in prediction of neurodevelopmental outcomes? Unfortunately, both MRI and cranial ultrasound at term equivalent age did not have good prediction or good prognostic value for predicting long-term injury overall in terms of sensitivity, specificity, and in terms of the area under the diagnostic curve. But severe injury on cranial ultrasound did predict abnormal neurodevelopment perfectly. So whomever had the ultrasound abnormalities of severe grade had a 100% positive predictive value for abnormal neurodevelopmental outcome. But the converse was not true, both with ultrasound and with MRI. And even performing regression analysis for other additional clinical risk factors did not necessarily add any predictive value of MRI over the cranial ultrasound. So given all these relative disadvantages, the higher cost, the need for sedation, safety concerns, the need for the baby to be shifted for MRI, what are we actually achieving by doing an MRI is a question that we need to understand. So this was another RCT that looked at the parental anxiety scores by performing MRI and versus ultrasound. So the parents were blinded to the other investigation. So they were only revealed the investigation of that group in which they were randomized to. Although it was seen that performing MRI did reduce parental anxiety slightly more than the cranial ultrasound, it again did not have any impact on the child's quality of life. Additionally, the MRI increased the cost of treatment by around 315 pounds more per infant, and this was the confidence interval, with no demonstrated change in the management or in the clinical outcomes. So I would like to conclude by summarizing some of the international guidelines, and this is from the Canadian Pediatric Society. So they do agree that MRI does have good predictive values, especially when performed at term corrected age, but it is not recommended at this time given the limited accessibility and expertise. The only place where they really recommend a term equivalent age MRI is when there is severe injury or moderate to severe anomaly detected on head ultrasound, that is grade 3 or grade 4 IVH or PVL. And this is my last slide. Similar guidelines coming from the American Academy of Pediatrics. And now if MRI needs to be performed, they recommend a non-sedated, feed and wrap MRI. In fact, this is one of the 5 interventions that the AAP suggests that parents and perinatal physicians should question ourselves before offering to our parents. So I would like to rest my case, Chairperson, with my argument that the cranial ultrasound is safer, It predicts long-term outcomes as well as a term equivalent MRI. It does not involve sedation. It offers the important advantage of sequential imaging because we know a lot of preterm brain injury, especially related to IVH and its complications, and early cystic PBL may be lost when we do imaging only at term equivalent age, which is the only thing possible with MRI being a snapshot imaging. And of course, it is cost effective with a country like India, which has its own varied cost dynamics. Thank you for the time, and we'll be happy to take questions at the end.
Thank you, Dr. Aparna. We heard that cranial ultrasound is easy to do and then cost effective, and then it can as good as MRI in predicting the outcomes. So we will listen to Dr. Vanati what she has got advantages of MRI.
So good morning to everybody gathered here. So we're all set for the stage to say probably MR is probably the choice. So let us see whether I can wrap a few points probably in favor of MRI. I know it's the most easiest one, nice to do, and the best to do bedside is always a neurosonogram. But let's take the concept of the day, that is, it is at the finish line. It matters who does it very correctly and probably optimally. So why actually do we need the MRI? What's the purpose? Is there any rationale? Do we have anything to say that MRI is the ideal one? Let's understand that basically all these preterms with evolving IVF and outcomes, it's necessary that probably we may have to identify whether they go through a set of things that will probably cause two important changes in the preterm brain. One, because of dysmaturation, and second, because of all the external environment that we do. Are they predisposed to any kind of injury? So we are moving away from studies in histopathology of these preterm brains to what we see right away as an image with neuropathology with addendum of radiology. So we wish to do what we actually want to do nice to make these preterm babies grow better with quality. We want to restore the brain at the earlier age in case we are able to identify anything defective. So that's the purpose. As we all take the first year's Hippocratic Oath, we always want to do certain things. We do not want to harm. And definitely, is MRI safe is the most important question which Madam has already put up, but not so very unsafe, as we understand that equivalent to an ultrasound, it does not cause any ionizing radiation, and there is not. There are changes that have come up in many Western countries where they have MRI compatible incubators. Not yet so in Indian scenario, but still it could be possible and evolving with AEGs and hypothermia machines coming up. Probably this could also be the future. We have to combat few important major risks definitively, and we have a complete practice guidelines and standard protocols in workplace so that we can ensure there is no hypothermia, there is no accidental extubation in case we are shifting from the NICU. Most often term equivalent MRIs can be done as OPD, so we have to ensure proper airway securing, and feed and wrap technique is also practiced as most units when they come as OPD. So possibly the risk of safety can be avoided if we take a standardized protocol. Is it useful at all? Useful at all for us to understand combating all these risks? Probably yes. Let's understand what we understand by this term, optimal acquisition. Optimal acquisition in English term which says make use of all the potent, useful things in everything and optimize to every patient. So it cannot be done on a 1:1 care. It has to be individualized, as Madam has already pointed out, in very select scenarios, and idealness is always best taken upon from that. These are the four major core sequences that we do in an MRI, T1, T2, and susceptibility weighted imaging, DWI, and some additional advanced anisotropy is also available. The first three are most optimal. So what do these images probably do? They help us to identify overt brain injuries. They detect white matter injury missed often, probably in an ultrasound, and evaluate brain growth and maturation, and better assessment of deep gray matter, and probably end up in better parental counseling and guiding them to have better quality of life. These are the sections which in each area which this MRI is going to tell us. This is the essentials that it would do. So this is the picture of each of the MRIs which we commonly do. It's a normal MRI which shows the T1, T2 and DWA MRI. All of them are usually assesses term equivalent age, which is between somewhere 36 to 42 weeks of age. And definitely identifying subtle abnormalities in gray matter, white matter, periventricular hemorrhagic, in fact I'll be narrating all of them, would probably add little more information to make quality of these babies' lives better. Are we precise in diagnosis? Are we overrating them? Are we diagnosing too much in these MRIs? Probably not. So what we ideally wish to do here is to identify early cystic PVL changes meta in a more three-dimensional manner. As I already told, white matter injuries associated with this PVL can be picked up, and cerebellar hemorrhage and posterior fossa lesions are better picked up. This is our in-house patient who revealed an ultrasound cranium on routine screening a posterior fossa cyst, arachnoid cyst, which was just about a dot in the scan, but later we identified it was obstructing the entire brainstem. So this helped us to identify this. We went ahead and did the MRI at an earlier age in this baby to lease the extent of this lesion, and we could prognosticate and identify that these babies need followed up earlier. So this is where probably MRI would add little larger score as compared to an ultrasound. And that is why we say it's probably precise. This is a comparative picture, as already Madam has already put up this. So this shows a PVHI and the associated white matter injury, which is addendum in your MRI. Again, this helps us to make a precise diagnosis, helps us to guide our neuroprotective strategies better. Are we accurate? They are not interchangeable terms. Accuracy is better off with MRI detecting gray matter injuries. And also, we can also estimate what exactly is the cerebellar or cerebral volume. This more goes in favor for research and probably the future to understand how the preterm brain grows better than term brain at term equivalent age. So, as I already pointed out, myelination patterns are better detected, brain volumes are better detected, and gyrification index is also better detected. This is going to have a long-term impact in cognitive and behavioral issues in these babies. So this is going to guide us our future therapy as well. So having said it's precise, useful, accurate, can it be used as predictive tool? So definitely yes. So white matter injury is definitely predictive of CP and motor delay, probably at 2 years. Most often even an abnormal MRI with probable neurorestorative strategies can give a good quality outcome as well. So it does both. And then the specific findings which signal issues here are going to be those which correlate mainly with motor delay and cognitive changes. So this is a picture of comparative 4 major etiologies which are pathologies that we commonly see. A post-ventricular hemorrhagic infarct, a PVL, and a white matter plaque, as Madam has already suggested and shown, our negative predictive values are definitely better. Although serial ultrasounds pick up early, it is that TEA image which guides to the final diagnosis, and probably specificity and negative predictive value are better with MRI, including gray matter defects and posterior fossa lesions. So, what is the prognostic value? Having said this, it predicts CP better, cognitive and language delay better with gray matter abnormalities, global brain abnormality score, there is a KDIGO score, I have not gone into the details for want of time. And this helps us to understand that the family counseling becomes much easier. More importantly, we are able to plan the neurodevelopmental follow-up timings and intervene early, designing the intervention program, and then determine your resource allocation. Having said this, I would also say that it is very, very important that the clinical examination and scoring comes first in either of the two before we decide what neurorestorative programs we are going to do at term equivalent age. So is it a necessity? So need and utility probably drives us to a necessity, and probably it's a necessity so that you can, as I already told, for these reasons could be considered at term equivalent age, although we have to individualize on patient to patient basis. This sums up probably the need for MRI at finish line. It has got a best predictor, a better predictor. It evaluates brain growth and maturation. It detects white matter injury more subtly and precisely. A better evaluation of posterior fossa lesions and more accurate, and probably do have some research value for future benefits. So this is probably an MRI Ikigai which you can take home if you think it's really necessary, useful and harmless, which we need to decide in more precise manner and accurately, and we have to prognosticate for better neurorestorative strategies, probably opt for MRI in that neonate at term equivalent age. Thank you.
Thank you, Dr. Vanati. It was a really nice wrap-up of summarized of how MRI can be useful. So I have a couple of questions for the speakers. Dr. Aparna mentioned that the cranial ultrasound is, there is no doubt that cranial ultrasound is useful in early screening. especially screening for IVH and serial monitoring of IVH and then post-hemorrhagic hydrocephalus. But a lot of people are talking about even early MRI is superior to early cranial ultrasound. And you mentioned that MRI may need a sedation and as well as the moving the baby. Now MRI machines are more sophisticated, cost is coming down, and even the MRI units which can be placed inside the NICU in the room is available. It's a very small, and then you don't have to worry about the magnet safety and all. We can just push the baby to the room and then get an MRI done and then bring baby back without moving the baby to the diagnostic radiology departments. So given this, and the cost is also coming down, given these considerations, always MRI being a superior imaging, whether that there is a role for even it can be done potentially serially in the future. So that one thing. Second is ultrasound is sometimes operator dependent. You need a high resolution equipment and you need a good probes and good equipment, and sometimes it can miss if the operator is not carefully looking for minute lesions, especially the punctate cerebellar hemorrhages, posterior fossa lesions, like what Dr. Vanathy mentioned. So given that fact, early, yes, neurosonography is useful for prognostication. Do you think MRI has got any advantages over cranial ultrasound?
So certainly, I mean, as we saw in the study that was published in European Journal of Pediatrics 2019 that I had also mentioned too, and I think Dr. Vanathy also showed studies showing prognostic ability coming in better with the subtle white matter injury. The point here is most of the serious grades of brain injury that have the excellent correlation with subsequent poor neurological outcomes are fairly reliably picked up even in a cranial ultrasound, is what most studies come back and tell. We do have subtle markers of even diffuse white matter gliosis in the form of asymmetric ventriculomegaly because of ex-vacuum dilatation. We are able to pick up subtle hyperechogenicity, which is kind of an equivalent to the MRA diagnosed diffuse extremely high intense signals as what they refer to, or white matter hyperintensity. So this also correlates well with the cranial ultrasound diagnosed increased hyperechogenicity, which is even better detectable now with the better probes. We have high frequency linear probes, etc., and higher frequency convex probes also available, mastoid views. So the question really is why to opt for an imaging that involves a certain degree of not just cost, but also certain practical implications. But of course, it's always welcome that we are able to get MRI at more reasonable costing and more practical.
So what we are hearing is if there is a abnormality significant enough to detect by cranial ultrasound, it can be detected by MRI as well. Yeah, thank you. Thanks for the point. And Dr. Vanathy, what one single advantage you see that MRI is actually clearly superior to CT, in terms of management, clinical management?
Most of our in-house management, critical ultrasound is the key. But then towards the end, when we see discharge these babies as 36 or 40 weeks of post-conceptional age or PMA, what we have to answer is how these babies are going to fare in their 2-year, 3-year or 5-year period. So routine conventional MRI is only going to increase the anxiety. But then if a detailed neurological assessment is going to pick up subtle features of abnormal tone or anything else, then definitely these babies will benefit with MRI, because a lot of studies and also information has come up how a detailed assessment and routine neurodevelopmental follow-up of these babies have made a huge change in their long-term impact, especially at school-going age, sir. So I would suggest that probably that is the addendum, combating the risks of safety, which is probably can be ensured, and cost.
Thank you.
Thank you.
Thank you very much. Nicely summarized. If you mentioned about the Canadian guidelines or American guidelines, that's about 2019, 2020. If you look at another paper, 2021, written by Terry Hinders, Linda Dearies, and even J.J. Olpe, who are the pioneers in the neonatal neurology, they actually questions that statements, whether it is actually, whether we are, stopping the innovation or research or advancing knowledge by just saying no to MRI. And what they claim is actually CT and MRI is actually complementary rather than exclusive. You do, sorry, not CT, cranial ultrasound and MRI. Cranial ultrasound has got early, detection of IVH is a good role. and we can monitor serially, and then we can also look for post-hemorrhagic hydrocephalus. But towards the end, maybe at the term equivalent age, an MRI may be recommended, especially in the high-risk infants, less than 28 weeks typically, and also the babies even more than 28 weeks who has got a complicated neonatal course. Why? Because a negative MRI, if the MRI is completely normal, it has got a very good predictive value of completely excluding that gives probably a reassurance to the patients. And then at least even though some subtle positive findings increases the anxiety, so there is a balance. So I think we should look at even though mutually exclusive, we should look at, yes, early cranial ultrasound should be a routine to monitor the IVH and then the neurological status, and maybe in high risk infants, in selected infants, we may consider MRI at term equivalent age. Yeah, that's probably how I would conclude. Thank you.
Thank you, sir.
Thank you, ma'am. Thank you, sir. Sir, now I request Dr. Abdul Alim, sir, to hand over mementos to Aparna madam and Vanati madam. Sir. Now I request Aparna madam and Vanti madam to hand over memento to our chairperson, Abdul Alam, sir. Fine. Four chairs. Next interesting topic is cooling with clarity. This will be a panel discussion moderated by Dr. Shalini Tripathi ma'am, and the panelists sir Jagdish Prasad Sahu sir, Gaurav Gupta sir, Gaurav Agarwal sir, and Omkar Kandewal sir. Dr. Shalini Tripathi madam will be the moderator for this session.
AC off here, ma'am, actually, but it will take 15 minutes time.
We are all being cooled. स्लाइड्स यहाँ पर भी दिख जाएंगे. Turn on. So a very good morning everyone. I am Dr. Shalini Tripathi and we are going to start a very, very interesting session, and that is basically the cooling with clarity, the 2025 perspective on neonatal hypothermia. And I would like to first tell you about the panel. I have named all these four young guys the cool panel, and in fact we are all being cooled also with the air conditioner, so everything is going well in time. So we have, I'm Dr. Shalini and I'm working in NICU KGMU Lucknow from UP, and we have our panelist Dr. Jagdish Prasad Sahu, and he is additional professor in Department of Neonatology, AIIMS Bhubaneswar. Then we have next Dr. Gaurav Agarwal, and Dr. Gaurav Agarwal presently is working as a consultant neonatologist at Kailash Hospital, Greater Noida, and he's also had done the fellowships in I think Canada, and Okay. So the other two people, okay, their CV is not there. Okay. So Dr. Omkar can introduce. Yeah.
Hello. I am Dr. Omkar Khandwal. I am a professor head pediatrics in Medical College Raipur, just a site in Chhattisgarh. And I have been practicing neonatology since last 20 years.
Okay.
I'm Dr. Gaurav Gupta, consultant neonatologist, working at a private hospital, and I've trained in Australia. So therapeutic hypothermia is really dear to me.
Okay, so we have a vast representation of the whole of the India in this panel. So we all know that the burden of hypoxic ischemic encephalopathy in LMICs is huge, and India contributes to 1/4 of the global neonatal deaths. And asphyxia is actually contributing 1/5 of all those deaths. If we see the HIE, the prevalence of HIE is 1 to 3 per 1,000 newborn babies born in developed, but it is 20 times higher in low middle income countries. And especially the state from which I belong, Uttar Pradesh, still struggling a lot with perinatal asphyxia and HIE. Especially in the peripheral part, the babies are born and then they're transported back to the centers and they're in a very bad shape, although the things are changing. But we are evolving. So we really, and there are heterogeneity in all the states. There are few states, there is no asphyxia at all in India. There are few states like us, there is a large number of babies are born, and we are having large number of neurodevelopmental delays, all those post-asphyxiated babies in the follow-up clinics. So then we are going to discuss all those perspectives with this panel right here. So the first question to Dr. Jagdish, can you please summarize the key clinical trials in the last 10 years on therapeutic hypothermia for HIE?
So good morning, everyone. So before 2005, actually, the management of perinatal asphyxia was mostly supportive. That is maintaining the temperature, air, breathing circulation, maintaining normoxemia, avoiding hypoxia, hyperaxemia, avoiding hypocarbia, hypercarbia, control of the seizures. But there was a lot of changes after the landmark 5-6 studies from 2005 to 2010. So the studies I have shown, so they have gone for the selective head cooling or the whole body cooling. But most of these 6 studies were in the high income countries, and they are the landmark studies. And in the Cochrane review, what they have found that the death or disability at 18 to 22 months is better, and the number needed to treat is almost 7. So that's why there is a huge hype of therapeutic hypothermia for us to practice in the low medium income countries actually. And there are a lot of studies in India or the low income countries regarding therapeutic hypothermia after this 2013 meta-analysis. So again, so there are different methods they have used. So the ideal one is definitely the servo control one, that is using either a tachotherm machine or by the blanketer machine. But in Indian setup, because of the very high cost, non-availability, so alternatives has been tried, like the gel packs. Even I have seen water bottles, cold water bottles, ice packs, they have been used. Then the studies from the CMC Buller with the phase contrast material and the Mida cradle, they have all used. And they are all showing some amount of benefit for our babies also. But in 2021, the publications by the Helix trial, that is hypothermia in the low and medium income countries by Thile et al. So what they have done, so almost 206 babies they have done in India, Sri Lanka and Bangladesh. So the ultimate outcome, they have shown that it actually increases the mortality. So that's why again there was a huge debate whether to continue, not continue. We'll discuss that.
So as far as the initial part of the trials were from the high income countries, they are very homogeneous trials. And they were done on fully automated devices, same kind of babies, same kind of setups. And they standardized this treatment because they found a whole soul in outcome differences and very good results. But then the trials from Indian perspective, they have started the different kinds of devices, whole body cooling, selective, automated, semi-automated, and different types of centers also, tertiary level, secondary level, level 4. So then the outcomes may not be that, and then finally the Helix trial. So this trial actually was a very sensational kind of trial which gave a verdict to the low middle income countries, and the people got really fired that why can't the LMIC people cool the babies, and then it created a kind of controversy. So Dr. Omkar, can you just discuss the Helix trial and its implications for LMIC?
Good morning to you all. In fact, in 2021, when Helix trial came, everybody from low LMICs, they become agitated that initially what we were getting that cooling is going to benefit our HI babies. But the Helix trial, it in all sense, it says for every 10 neonates which you are going to save, one additional newborn death would happen. So that is one of the very important things, that the primary outcomes to death or moderate severe disability was increased, mortality was increased, the disability was increased, though there was protection for decrease in cerebral palsy. So for every 10 deaths, you have one cerebral palsy which you are able to avert. So, and the methodology was quite accurate, but there were things which should have been happen. They did not. The data was not as per it should have happened. In fact, when we do a subgroup analysis, we need to have inborn as well as outborn equal. There should have been no difference. Center-wise death rate, there should have been no difference. The AGA and SGA, there should have been no difference. And sepsis versus no sepsis, there should have been no difference. But what the Helix trial, they had differences in those things. There were majority of outborn, about 70% of enrolled neonates were from outborn areas. The time of injuries, it was very much prolonged injuries. And what we are here finding is that despite all these things, the ultimate outcome was the death before discharge was in fact increased. In about 36% cases, the mortality has increased. So we need to think about where this Helix trial has gone wrong and what are our take-home messages from Helix trial, how we can incorporate those findings in our scenarios.
Yes, very rightly said. That's very important to know that the trial was done in such a way nobody can question anything in that trial. It was done in a very nice way. But the babies which were coming to those centers, they were not in that shape. They were initially so bad, they were so moribund, already a lot of damage has happened. So we have to take home CPAP, there is no pressures were maintained. And then of course, hypothermia alone is insufficient without high quality intensive care. Only you are doing hypothermia, there is no high quality intensive care, supportive care given to the baby will die. So eventually, and the third is high prevalence of comorbidities in our areas, like in the low resource, there is perinatal infections, sepsis, IUGR, and all these reduce the protective effect which is always there in the high income countries. Infection combined with cooling always worsens the outcome. So we have to really decide. And the personnel, how many nurses they are looking after that baby. One baby is to nurse ratio should be required. So that is a staffing shortage. One paper has come up. Challenges with the diagnostic, which is called as misclassification. You have selected a baby which which should be cooled. Like AEG is not there. There is electrical seizures. Early selection of baby is not happening, and you have selected a baby which has already had a CPR in the labor room. So that baby is selected, and the baby which is like a milder and real appropriate one, the moderate electrical seizures and looking otherwise well, he should have selected. So the inappropriate classification and environment and logistics I've already told. So the next question now to Dr. Gaurav. What are the ILCOR and NNF guidelines on therapeutic hypothermia?
So they are the two parent bodies which are really the guiding, organizations. So ILCOR has made it as a standard of care in high-income countries to cool babies for babies with moderate to severe encephalopathy. Whereas for LMIC countries, for moderate to severe hypoxic ischemic encephalopathy in LMICs with term and more than 37 weeks, therapeutic hypothermia can be considered if all other paraphernalias are fulfilled, which includes the place, person, paraphernalia, and the protocols. So it's a weak recommendation, low certainty evidence.
So all paraphernalia has to be well before starting. That is a very key point. Yes.
And it's not recommended for late preterm infants, and defined protocols consistence which are used in the known RCTs have to be followed. Whole body cooling for 32 with temperature range of 32 34 degrees for 72 hours with rewarming over 4 to 6 hours is required. And therapeutic hypothermia without close monitoring, defined protocols, and comprehensive care may cause harm.
So this line is very, very important. You don't have any protocols, SOPs for everything in therapeutic hypothermia and no care, it will actually harm the baby. And we should have to do, in the current era of medico-legal, we should do no harm to the babies. So what are the NNF guidelines?
So, once NNF saw the HELIX trial, everybody was scratching their head. Why? Because the physiology between LMIC and high-income countries is going to be the same. If surfactant works in high-income countries, it should be working in low-income countries, which it does. So what was the problem? Why the beneficial effect was not seen? So they were scratching their head, and they did a meta-analysis, and this is what they had to come up. They were able. This is what the HELIX trial had said: the increased mortality and death at discharge was higher, and there was no difference in combined outcome of death and disability at 18 months of age. So, in fact, they had the statement was very discouraging, was saying that HELIX trial said that it should not be attempted in LMIC countries. So, they analyzed, the NNF working group sat down somewhere in 2021 after the outlet was there, and they published this in October of 2021. So they were looking at 24 RCTs, 7 were from high-income countries and 17 from low-middle-income countries. So they were essentially looking whether it is actually working or not. And if it is not working in low-middle-income countries, what was the reason for it? Was there any subset of babies? And how could we improve? So what they found was that from the 7 RCTs in high-income countries, as everybody said, it is standard of treatment. For LMIC countries, the difference was essentially because of lot of heterogeneity in cord pH, extramural babies or the outborn babies, temperature at admission, severity of hypoxic ischemic encephalopathy, and other potential effects which included other care or newborn care, other points in newborn care. Next slide, please.
Yes.
So I would briefly go on this. So this is what they could find. This is a forest plot which says that the combined outcome of death before outcome of death before discharge was less in both high-income countries and LMICs, although the effect were more pronounced in high-income countries. But there was a lot of heterogeneity. So in this forest plot, they said that it is definitely useful in babies with an admission cord pH less than 7. And whereas the effects were doubtful in the studies where the cord pH was more than 7 or the cord pH was not there. So cord pH or an blood gas, preferably an arterial blood gas, should be done in asphyxiated babies thinking of cooling within 1 hour of life. So the next thing which was very important was outborn babies had higher chances of morbidity and mortality, or the effect of therapeutic hypothermia was less seen in outborn babies, especially in LMIC countries. which was the case with Helix trial. So they had more outborn or extramural babies. Next slide, please. And the other important thing was normothermia or thermia at the or temperature at the time of admission to intensive care unit or prior to commencing therapeutic hypothermia. So babies with normal or euthermic range prior to starting treatment or at the time of admission, the extramural babies or even the inborn babies had a much better outcome than the babies who were hypothermic with temperature less than 36. So this is one of all the things, this is also one very important factor which needs to be looked after. Next slide, please. And this slide shows that higher, as ma'am was highlighting, higher the severity of HIE, higher is going to be the proportion of death or disability. So the next question is to...
So then after learning from all those things from the Helix trials, my next question to Dr. Gaurav Agarwal, what are the indications for cooling according to the NNF position statement, and what are the contraindications?
Yeah, good morning everyone. So as per the NNF guidelines, the therapeutic hypothermia should be offered to neonates with gestational age above 36 weeks, and it should be within 6 hours of age with at least admission temperature of 36 to 37.4 degrees centigrade. But along with that, if they fulfill all of the following criteria, the blood gas, arterial blood gas PI should be less than 7 or base excess more than 16 on cord or arterial blood gas within 1 hour. And along with that, ABGAR score of less than 5 at 10 minutes of life, or there is a history of positive pressure ventilation of more than 10 minutes, and history of any acute perinatal event, but not limited to abruption, uterine rupture, and cord prolapse. And along with that, there should be evidence of moderate to severe encephalopathy by doing the neurological examination by modified Sarnat score, so that quickly we can understand whether the baby is fitting in level 2 or level 3 HIE grading. And which neonate should not receive hypothermia, like those who are moribund, having major congenital or genetic problems, having severe coagulopathy. There is evidence of severe coagulopathy. IUGR babies, those who are restricted growth. Also, if the ultrasound is showing intracranial hemorrhage or there is severe head trauma. And also, above all of the above, there is insufficient evidence of the benefit of hypothermia above 6 hours of age.
So it is very important that out of these 4, all these should be fulfilled, and there should be a checklist that every time the baby is taken into for the cooling, all those points should be yes. And then severe IUGR, less than 3rd centile on the growth charts, makes it a less optimum candidate for cooling. So the next question to Dr. Omkar, what are the minimum infrastructure for a center that can offer cooling?
In fact, all those centers, those who are not able to handle babies at par with level 3 or level 4, they should not be offering therapeutic hypothermia. In fact, there is one arbitrary criteria that when your HIE babies, survival of your as such perinatal asphyxia babies, survival is more than 80%, then only you should be offering therapeutic hypothermia in your settings, because at
your
that
level
point
of
of time,
care is that
level of care is as that, so that your nursing staff is trained, your team is handling shock, your team is handling, you have facilities for ABG. In fact, the ABG is the point that you need to have ABG at the delivery point also, so that you should be able to classify them accordingly, so that you can have a better decision making of whether to offer them hypothermia.
One very important thing is that many centers, even the tertiary medical colleges, are not still doing the cord blood ABGs. So it should be a mandatory practice, because many times what happens, that ABGAR can be very dicey situation, and cord blood is a very objective criteria, especially in the medico-legal era, when you have some quarrels with your gynecologist also. In your perinatology meet, the fights happen. So it's a very safeguarding thing in that all those perspective. Once we have started doing the cord blood in all the babies which are born in our institute, many things have been, the baby is born at 6.9 and the lady is saying why the baby has not gone. So there may be some intrapartum issues, the delay in cesarean or anything that can be thought of. So it's very important. It's a very, very important. Many people are doing ventilation for quite long, but the cord pH is not being done. So please start doing cord pH. And if somehow it is missed, the baby's ABG can also be done within 1 hour. So that is a very important message. Yes.
In fact, and the next important thing is that there should be facilities for informed written consent, because this is going to go a long way about explaining the parent about the neuro disability they might have happen. So, and they should have a good plan for follow up. The early neuro developmental follow up facility should be there. So a comprehensive neonatal setup with at least level 3 or 4 should be there.
Yes. So consent is very, very important. Telling the parent that, yeah, this is not a Ramban, or it is 100% thing that it will be magical, something magical will happen. But then you can tell in the proportions and all that in the local language to be signed by the parents. So the next question to the Dr. Gaurav Gupta: what was the protocol for the therapeutic hypothermia in HIE?
I think we come to the most important part. So as we discussed, place, person, protocol, paraphernalia. So protocol is very important. There are essentially three phases of induction, active cooling phase, and rewarming phase. The initial phase has to be within 30 to 60 minutes. Once we decide that we are going to do it, and the target range temperature of core body should be 33 to 34. Active cooling phase lasts for 72 hours, and we tend to maintain temperature in the same core body temperature in 33 to 34 degrees Celsius, which is measured by a rectal temperature or an esophageal temperature, but we do normally use a rectal temperature. Reforming phase is after we complete 72 hours, we rewarm over a period of 6 to 12 hours. That is very, very important. And to get back from 33.5 to 36.5. These temperature ranges and these time intervals have to be diligently followed if we are doing therapeutic hypothermia, because if we go out, we are doing more harm. Primum non nocere, do no harm. So this is a servo-controlled active cooling device. Goes by, there are a lot of people, there are a lot of machines running in the market. So I picked up one of them, which is Neocon, which is, I'm being vocal for local. It is an indigenously produced. So it has a device which has, we set the temperature, then there are probes, and then there is a mattress, and then there are there's a water-based cooling system. Some have alcohol-based cooling system, which is attached to the pipes from the main body, goes to the mattress, and it's a servo-controlled technique. It is actively cooling the baby by using the water gel. We place them on a warmer. The warmer needs to be turned off, and all the monitoring needs to be done.
So what do you think? Somebody want to start schooling and want to buy a machine. So he should be using the phase changing material or fully automated device. What is your advice?
So the next was phase changing device. So now essentially there are two things which come into this. There's a difference in price. The phase this mattress or the phase changing mattress is around 2.5 to 3 lakhs, whereas the active cooling machine, the prices have come down. The indigenous one has come down to 7 to 8 lakhs. So the problem with phase changing mattresses, it requires very intense nursing. There are very high chances that you can go in a skewed direction, and then you're going to do more harm. So if you are going to do phase change material cooling, your nursing care has to be top notch, cannot go haywire. But if you can manage, or if you can afford to do a active cooling device, please go for it. The nursing input becomes a little less.
Yeah. Even I am using in our center the Blanket Troll 3, which is a whole body cooling. Although one nurse is there, but then I will always advise for a fully automated, because otherwise the tight control, narrow control of the temperature cannot be possible. Okay.
So as said, once we start, how do I start? I need to get a signed informed consent. That is the most important part. We need to give them clear information, what evidence is available, what are the risks, what are the benefit, and what are the potential harms. And it has to come from the parents and the family members. So same time, once they say yes, we prepare this cooling system for operation, set the blanket temperature to 33.5, and place the infant of warmer in supine position with entire head and body resting on the cooling blanket. Next slide, please. So monitoring and document the infant's pre-cooling vital signs. Monitoring is very, very important. So if arterial lines or central lines are required, please secure them while the baby is being inducted into the cooling system. Insert a rectal probe 2 to 3 centimeter inside the infant's rectum and secure the outer edge to the inner side of the thigh of the baby and set it on auto control mode like a servo control. So bedside monitoring. So these are all the parameters. A pulse ox is not going to be sufficient in such a scenario. We need to have a multi-para monitor which gives us at least heart rate, respiratory rate, the ECG, saturations, temperature, and these are all the vitals which need to be monitored 1 hourly for day 1, day 2, day 3. Neurological monitoring by any scale you use. Maybe it be Sarnat or Sarnat, 12 hourly comprehensively has to be done. Urine output, if you can just do it by weighing the diaper, fair enough, otherwise put in a catheter. ECG is very important because there can be some ST segment changes. Amplitude integrated EEG, if you have, it's always going to be a boom because you can always know where the prognosis is, whether it is going from bus suppression to the normal voltage or it is going to isoelectric. So some cases we may consider discontinuing treatment or redirecting treatment.
Actually, I think amplitude integrated EEG is to be there. It is a must. And when you are buying the cooling machine, it is good to buy both the things together. And both the things, I think the costs are also going down as we are advancing and the more centers are starting cooling. The amplitude integrated EEG is also mandatory because the proper appropriate selection, it will occur, and the babies, the moderate HIE, which are really going to benefit, you can detect. And this happens in our center also.
I think at the moment, EEG machine is costlier than the therapeutic hypothermia machine.
Yeah.
Yes. So
15 lakh here.
So pain monitoring has to be done with any scale, any validated tool which your staff is confident in. Documentation, monitoring of ventilatory circuits, central catheters, and avoid hospital-acquired infections. Labs, equally important. This is what is the frequency we need to do: blood sugars, blood gases, renal functions, electrolytes, coagulation, liver functions, complete hemogram, and a neurosonogram. So the frequency has been written there, and then you can individualize this to your local protocol, to your local system, how it fits you well. Neurosonogram is helpful, a bedside neurosonogram, especially looking at the resistance. Earlier, FFP is only required if there is active bleeding or your PT or is above the indicators, because there are age-specific PTI cutoffs for transfusing FFP that has to be strictly followed. So withdrawal of therapy, as we were discussing, if you note that there is evolution down the hill, if you're going to severe HI with a brain death like isoelectric or low energy potentials, we may consider redirection of therapy. Or if we get parents on board and who are saying that, considering what the scenario is, we would like to withdraw. So rewarming is an equally important and critical phase. It has to be done over a period of 4 to 6 hours. Early rewarming is harmful, and you are going to skew your benefits, whatever you have done of therapeutic hypothermia. So, when the infant's core temperature reaches 36.5, remove the patient from the cooling blanket, restart your warmer, and document the infant's temperature with a skin probe, and then you can continue your care.
Yeah.
So complications, we need to be very off. Cardiovascular complications like rhythm disorders can be seen, shock can be seen, or there could be spuriously increased oxygen requirement, respiratory system hypoxemic respiratory failure, DIC bleeding can be there, electrolyte imbalance, delayed gastric emptying, and sepsis because of altered leukocyte function.
So very strict monitoring. So it's very important to dedicate one nurse and off the shift of the most important and experienced nurse, I will say. And once we started cooling, it was scary also. And because if the baby dies, it is a negative booster for everyone. So then we asked the best nurse in every shift to look after that baby and to pick up the complications early. So
neuroimaging is beneficial. Bedside ultrasonography, I've already said. MRI, preferably by day 7 to day 10 of age. We looked at how good diffusion weighted images and MR spectroscopy can be, and that is as good. Even if for non-cool babies, we do an MRI. So that is as far as neuroimaging, and long-term follow-up is very, very important. As far as India is concerned, there are a lot of centers which are doing, especially the tertiary level and academic institutions, they are considering setting up national registry so that we can always counter.
Yes, so we have already discussed these 4 Ps because we are short of time. So challenges in the resource limited setting. For example, in KGMU, I would not say it is a best center in UP, but then it is still a public sector. So sepsis, DIC, so in between sometimes there is a bleeding, we have to abandon the procedure. Sometimes the babies are not so much responsive because the babies are usually severe HI. So then the response is not good, it is very less motivating. And then the attendants may ask for LAMA intermittently in 12 hours after that, 2-3 babies, they went LAMA. And high burden of comorbidities, one person, one nurse, how to do it, sometimes the nurses are less, and infrastructure, especially the transport incubators. When the baby is being transported from the delivery to the NICU, the temperature has to be normal at that point. So that part becomes. So Dr. Gaurav, how can we provide equity and access to cooling, identification of HI, referral mechanism, and safety in peripheral centers?
Yeah, so coming to the equity, I feel like equity is very important so that every eligible newborn should receive cooling. So early identification of HI in peripheral centers. So what can be done? So screening of all high risk babies from the inclusion criteria that we have already discussed, and along with that complete neurological examination by either Sarnat score or Thompson score. And then if there is a feature of all the HIE, then they can document that and inform the center, NNF accredited center for cooling, so that baby can be transported to that center within 6-hour window. So referral mechanism is also very important. So there should be a hub spoke model so that peripheral hospital should inform either the facility based newborn care and all SNCUs, and then the NICU with the cooling, so that they can inform early and the baby can be transported by the safe neonatal transport. And in the peripheries, there should be a safety that is also important. Like they should have some idea or some training for the passive cooling, but like overcooling and hypothermia should be avoided. They should stabilize the baby by stabilization of temperature, airway, monitoring the sugars, and then transport the baby with the proper safety metrics. Coming to the system level, what can be done in the system, so that there should be a training workshops for the medical officers, RMOs, as well as the nurses at the peripheral centers, as well as there should be the simulation workshops for the HIE, so that they should identify and estimate the HIE grading.
So that checklist can be found, but on the way the baby has to be given optimum management. There is nothing like on the way the baby will be cooled. The baby has to be cooled in that center in a well managed, everything SOP is there. You can't do ki on the way the baby is being cooled, the baby will reach and had a CPR in the NICU. So Dr. Jagdish, what are the researchers which found therapeutic hypothermia beyond standard guideline?
So, what the thought was, if we because the therapeutic hypothermia is going to decrease the cerebral metabolism, so people have thought if you can decrease the cooling to less than 33, what is recommended, then maybe it may be more neuroprotective or may help the babies who are severely asphyxiated. So there is a deeper cooling and longer cooling also with that concept. So the outcome was actually not much different. Rather, the babies who are cooled to 32 degree, they have shown more risk of hypotension, more cardiovascular issues. So that's why still it is not recommended. Then another thing, because outborn babies, we may not be able to receive the baby within first 6 hours of life. So whether we can cool these babies beyond 6 hours of life, because most of our units, they depend upon the outborn babies from SNCU that being reported. But again, the studies have shown it is effective. There is almost 65% probability of 2% less death in this group of babies at 18 to 22 months. But again, still early to say. Then for mild HI, again, it is a very controversial, so should not be tried.
In fact,
and
what
for
happens,
the late preterm also,
in fact, in the NNF's position statement, they have written, for example, you're following a baby, the baby is sick, but then he improves. Like you're just making everything, and a resident calls, and that's it. Baby started crying, ma'am, and we are going to start feeding. So you have to abandon. I mean, if he is shifted to mild and looks fine, so he can. Now you can make a decision that I'm not going to cool.
Yes, ma'am. Same thing we have done just 2 days back in our NICU.
Yeah.
In the night, the baby was, as we say, 6.8 cot pace minus 18, 19 base excess. But in the morning, 9 o'clock, we started cooling around 3 o'clock, 4 o'clock. 9 o'clock when I came for the rounds, baby was aggressively wants feed. So I have to stop the cooling at that point of time.
Okay. So we have end with that. I think the message has gone well. The NNF position statement has to follow. Just one key message for the audience, please.
Ma'am, I'll just strictly again go for, in our Indian setup, it's always best to go for the basics, maintaining the normal metabolic milieu, avoiding hypoxia, avoiding hypocarbia when we are ventilating. These are more dangerous. Maintaining normal sugar in the normal range, treating the seizures. So where we are not treating all seizures. We are only treating maximum clinical seizures in our setup. Age is not available.
The electrical seizures also.
We have to focus more on that part rather than starting cooling.
First strengthen that basic infrastructure, and then of course upgrade.
Then once we are established, then probably we can go for the next step.
Yeah, Dr. Omkar.
In fact, at this juncture, we also need to focus that we need to strengthen our antenatal care, because there where it all starts, and the Helix trial also says due to poor antenatal care, it all goes bad. So antenatal care need to be strengthened. It should come from our side. And while we are cooling, we need to follow the NNF recommendations. That is a
very important thing. Yes.
So from my end, I would say it is doable in LMICs. The evidence says it is doable, but with all the prerequisites and the person, place, protocol, and paraphernalia. And we need to do it in a proper manner. Otherwise, don't do it.
So every patient is individual thing has to be seen. All those things, yes, no. And then all inclusion, on exclusion when you have done, then you will start. So appropriate selection is very, very important. Otherwise, the outcomes will be bad.
Yeah, so my take-home message is like strengthening of peripheries is very important, so that they can identify, screen, and refer the baby early, so that the baby can be cool as soon as possible in a good condition.
So that's a kind of dream come true. Hub and spoke of the cooling. The centers are the hub is cooling, and the periphery is identifying by AEG in place, and the SNCUs maybe, and then referring the babies quickly, maintaining the normothermia, etc., and then to cool in the centers. Thank you very much for the patience listening.
Thank you, ma'am. Such a wonderful panel discussion. Now I request Dr. Shalini. Are there any questions?
My suggestion is that the NNF should make a video for the parents, so that the parents should know what the cooling is, how it is done, and what are the implications and what are the precautions that the parents should understand. Because when the patient comes in the nursery, he say, "Mera bachcha to mara hua hai. Why you are keeping it here?"
बोले मेरे को तो तुम निकाल के दिखाओ कि ये बच्चा जिंदा है, then it's really very difficult to convince the parent at that conjecture that your baby is all right. So it is really very difficult to convince, and every day we have to do the consent also. So these points should be noted down, and I think a small video for parents should be made by the NNF. That is my suggestion.
That is a very good suggestion, sir. So, yes, sure. I will convey that.
I'm from Silchar Medical College in Assam, Dr. Jagdish must be knowing India. Actually, we are doing the hub and spoke model. We have been provided with 10 miracle adults, and from last 2 years we have been doing. But the issue is mostly in the outbound unit, where from the periphery, by the time the baby is received, it is 5 to 6 hours are gone. So what we have started after consulting Dr. Shah, that the peripheral units, we have advised to keep the temperature at 33 to 34 degrees Celsius in the warmer, because they don't have the cooling, or once they have identified this HI2. HI3 we are not doing, of course, because the prognosis is too good.
It says that passive cooling or like
Is a big
switching
no.
off the warmer in the centers where you're not properly trained or you're not cooling. So that is not being recommended, because maybe you are very experienced, but the person who is actually catering the baby will do more harm. So
A low admission temperature in a center which is doing therapeutic hypothermia at arrival is a poor prognostic marker for long-term outcome.
That's
So
why there is a criteria also.
yes.
The temperature has to be at admission 36 to 37.
So you need to be in euthermic
At the time.
until unless you have, because then it becomes an altogether different domain. You need to have a strict protocol for your neonatal transport, which has to be evidence based and has to be proper guidelines based before we practice that. At the moment, as far as therapeutic hypothermia and NNF position statement is, it is therapeutic hypothermia in a center which is doing all this.
And
We're
sir,
not
I would
talking
like
about
to say, like
transport.
you said, moribund baby, it's better not to cool.
Not
In the
to do.
first 3 babies, we had very low, sometimes a baby is born in the ambulance, all that. So with the bad babies in the first 2-3 babies, all the 3 babies expired. So I got ki what is going to happen? I mean, it will create a problem, and I was so then I talked to many people, and they say just select good babies. And then I started PPHN and all that. I'm not selecting, and it is very rightly written. Don't select those babies. Just give them that care. Otherwise, the parents will always have a कि कुछ ना कुछ फायदा हो जाएगा. तो वो फिर प्रॉब्लम हो जाती है. एकदम moribund बच्चा पड़ा है. It's better not to.
In inborns too, we have got excellent results.
Yeah.
At least the
Inborn,
seizures, inborns, because
I
we
think
got
inborn
it.
is
But for
always-
the outborn, it's birth
You
aspects.
don't know what is the situation. The baby is not booked. Antenatal visits का क्या हुआ है, तो फिर बहुत मुश्किल है.
In outbound, I think we should strengthen our system. Like as you are
It
saying,
is very difficult. Even the pediatricians said that they know of it, but how to reduce it? It is the parental aspect.
That's very important. कि वो NNF का एक video, and then the referral mechanism, maybe awareness in the
Yes.
peripheral areas to send fast.
an early identification referral, like sometime by the air ambulance as well. Like when I was in Canada, we used to transport with the helicopter.
Canada में possible है यार, यहाँ तो ambulance.
Like we have to improve that way, like our air ambulance, so that we will reach in the time, so that we have to like educate them at least within 6 hours, and the baby or all like the vitals should be stabilized and the temperature should be good. Yeah.
Thank you.
Now I request Dr. Shalini Tripathi ma'am to hand over mementos to our panelists. First to Dr. Jagdish Prasad Sahu sir.
We have already covered.
Actually. Next moment to Dr. Omkar Kandewala sir. Dr. Gaurav Gupta sir. And Dr. Gaurav Agarwal sir. My dear panelists, please hand over memento to Dr. Shalini Tripathi ma'am for chairing such a wonderful session. And thank you, madam and sir. So our next session will be in Hall A. That will be oration and followed by plenary. So please everyone join us at Hall A. And here next session will be on neuroprotective strategies at 1:30 p.m.
or just a rescue dose of antenatal steroids and not to repeat it. Now, there were studies done in low middle income resource settings, and they didn't find it to be all that useful, and there was a tendency to be harmful. So just giving the antenatal steroid injection, dexamethasone, which is commonly used, is not enough. Mother need to be properly taken care of. Other aspects of antenatal care is important. World Health Organization is doing action, trials even with a lower dose. We need to wait for the trials and follow up to be completed. This antenatal steroid success in babies, very premature babies, has been used outside the recommendation of 23 to 34 weeks into late preterm babies. This is the US study, but they found there was a high incidence of hypoglycemia. 25% had hypoglycemia, which can result in neurodevelopmental delay. Even some obstetricians used it before elective cesarean section in order to prevent admission. What they found was only transient tachypnea of the newborn, was reduced. RDS in a term infant is very rare. There were no short-term problems at 2 years, but long-term, these children, they were not doing well in the school. So this is not encouraged. This is a study from Finland based on their experience from a database of about 670,000 singleton children, and they were followed up to 8 years of age. And what they found was if the antenatal steroid was given up to 34 weeks, they found it late outcome was okay. So short as well as late outcomes were beneficial. On the other hand, 35 weeks and above and term infants, they found neuropsychiatric problems were on the increase. You can see the gap. This is the one not exposed, whereas antenatal steroids were given. As the child increases in age, neuropsychiatric problems like attention deficit hyperactivity disorder, autistic spectrum disorder were on the increase. So better to avoid antenatal steroids in late preterm as well as term infants because of the long-term issues. Not only that, in 34 weeks and below, the numbers needed to treat are not much. As the gestation decreases, numbers needed to treat to prevent one death. For example, 20, I couldn't show the pointer, 26 or 25 weeks in the logarithmic scale of only 10, 34 weeks up to 34 babies to be treated to have benefit. Whereas in early term and late preterm, you need to treat hundreds of mothers to have beneficial effects in one baby. So a number of mothers are exposed unnecessarily to antenatal steroids, so it should be avoided. The other strategy is magnesium sulfate. 4 large trials, about 4,500 infants. On follow-up, they found combined death or cerebral palsy were reduced. Cerebral palsy and motor dysfunction were also statistically significantly reduced. The recommendation to give 4 grams IV slow infusion over half an hour, followed by 1 gram per hour to a maximum of 24 hours, or until or if the baby is delivered earlier, of course, it needs to be stopped. and very good evidence before 32 weeks. Even 4 hours of exposure of the fetus to antenatal steroids has been shown to be beneficial. This is the hospital where I come from Singapore, about 12,000 deliveries. And I would like to touch upon prevention. You know, we need to work on the prevention rather than therapeutic treatment alone. At one stage in the 50s, Singapore, this hospital where there was a number of deliveries up to 36,000, it's in the Guinness Book of Records, they were called eclampsia capital. 340 eclampsia cases per 100,000. Various strategies were used. Rapid delivery and use of magnesium sulfate for severe preeclampsia, treatment of severe preeclampsia early and so forth, and brought down the incidence to 7 per 100,000 by 2004. So this is doable. And then in 1997, we introduced the code system, code green for crash cesarean section. When the mother who is monitored commonly, the tracing show type 2 depressions, immediately code green is activated by the nurse. And the duty neonatologist, resuscitation nurse, obstetrician, and anesthetist who stay in the hospital rush to the spot, and the mother is moved across the same level is the operation room, and the baby is delivered immediately by urgent cesarean section. And so it was brought down from half an hour in many hospitals, this happened, to 17 minutes. Then they wanted to improve further, so from 15 minutes they brought it down to about 8 minutes. So on an average now, about within 10 minutes, the fetus is delivered when there is asphyxia. Now that brought down the severe asphyxia and asphyxial related death substantially. So HAE incidence is rare, only 0.9 per 1,000 live births. So HAE can be prevented. So one need to work on that. As we all know, the current management is the cooling, but for term infants and late preterm infants, resuscitation with air has been recommended. Avoid hypoglycemia as well as hyperglycemia, they are harmful. And hyperthermia need to be avoided because hyperthermia worsens the HAE outcome. Cool the baby by 3 to 4 degrees. Moderate hypothermia is recommended rather than deep hypothermia. We aim for 33.5 to 36.5 as early as possible within 6 hours. They have studied increasing the depth of hypothermia, increasing the duration to 5 days. They were not beneficial, in fact may be harmful. Little evidence that total body cooling is better than selective head cooling, so we follow the total body cooling. And number of trials, it became a standard of care by 2013 based on 11 randomized controlled trials. You look at it, numbers needed to treat only 7 in order to reduce 1 death or disability, and number needed to treat was 8 in order to reduce major neurodevelopmental disability. And if the baby is properly monitored, the side effects are rare. Now, cooling reduces the morbidity on an average only by about 25 to 30%. There are added therapies, needed. Number of added therapies have been tried, but not by large trials. And recent, study that's going on is the stem cell therapy from the umbilical cord blood. And erythropoietin has number of neuroprotective benefits. It is an antioxidant. It regulates the genes involved in apoptosis, and the susceptibility to glutamate toxicity is reduces inflammation. And small studies showed beneficial effects. So we participated in an Australian-led trial called PN study, preventing the adverse effects of neonatal HIE with erythropoietin in addition to therapeutic hypothermia. So 35 weeks and above with moderate or severe HIE, and one group given erythropoietin 1000 units per kilo in the first 7 days. The other group was given placebo, normal saline, in addition to hypothermia, which is the standard of care. The 2-year follow-up of this blinded study has been, completed. We expected benefits, but unfortunately, between the arms, no added benefits. I think altogether there were about 300 babies, but we were a little bit disappointed, but that's the truth. Adding erythropoietin didn't help. So never believe in small-scale studies and start treatments. Now in preterm infants, I don't have much time. What I want to show that this is the neurodevelopmental, follow-up of the babies below 32 weeks, below 1215 grams. Follow-up at our hospital at 2 years of age, 5 and 8 years. As you can see, neurodevelopmental delay was about 8%. And cognitive delay was about 4%, at 5 years, 5%, and cerebral palsy, about 4%. Hearing impairment, severe hearing impairment or hearing impairment needing hearing aids was about 1.5%. None of the babies had legal blindness. So these are, comparable to reputable Western centers. So in our Asian neonatal units, we are able to bring down neonatal neurodevelopmental morbidity. Now, general neuroprotective measures are often ignored. They are very important. Nutrition with breastfeeding with of mother's own milk, family-centered care, kangaroo mother care, they need not be stressed much. Developmental care, the baby should not be frequently disturbed, so the nurses need to control the sleep cycles and positioning the baby, minimal handling, alleviating pain. And at our neonatal ICU, there is an artificial ear. If anyone talks if anyone talks loudly, above 55 decibels, it goes into yellow and red. So it needs to be avoided. Babies need quiet time, and this has been shown to be beneficial. Premature babies who are ventilated avoid hypocarbia. Below 35 degrees has been shown to increase cystic PBL and also hearing problems, apart from BPD. Now, brain injury, particularly severe brain injury, periventricular locomalacia, and encephalopathy of prematurity, they are harmful to the brain. This is the grade 4 hemorrhage, cystic PBL. It does happen. And chorioamnionitis, both clinical and histological chorioamnionitis, increase the risk of cerebral palsy. We wanted to bring down the severe IVH, which was about 8% in our very low birth weight babies, severe IVH grade 3 as well as grade 4, and cystic PVL. A number of strategies, I haven't put it here. We prevented hypothermia. Hypothermia on admission to the ICU was about 60%. And that predisposes. So we prevented, and then the antenatal steroids, neutral head position of the baby, introduced magnesium sulfate in 2013, and delayed cord clamping, and prophylactic prevention of IVH in mothers who have not received antenatal steroids. We use low dose indomethacin, 3 doses, treatment of PDA. All these measures brought down the severe IVH rates to 2% from 8%. So this is possible. Now, CAP trial, use of caffeine was initially postulated that it may be harmful, may increase the neurodevelopmental problem and make the babies hyperactive. So they studied, from Canada, multi-center trial, 1,000 per arm. One group caffeine, the other group placebo. What they found out 2 years was BPD decreased significantly, and the drug therapy for PDA decreased, surgical closure for PDA also decreased. And on follow-up, at 2 years, they found the cerebral palsy rate is decreased by about 6%, highly significant. And death or disability also decreased, cognitive delay and mental retardation decreased. They followed up at 5 and 11 years of age, and they found it to be beneficial. And caffeine is less expensive, seems to protect the brain. So we use, caffeine for all babies. I'm sure you will be practicing admitted to NICU less than 32 weeks. And so we tell the residents, before you have the coffee, if it's night, make sure that the baby gets the caffeine as well. Now, lastly, the PROTECT trial. What is the role of pentoxifylline? They needed 1,200 babies in order to reach a valid conclusion. This trial is from Western Australia, Perth, and between 23 to 28 weeks, suspected sepsis or proven sepsis or necrotizing enterocolitis. And after consent, they were randomized. Pentoxifylline is a xanthine, derivative, phosphodiesterase inhibitor, reduces the TNF production and also reduces the interleukin levels, harmful interleukin 1 and 10, but protects the 6 and 8, which are beneficial. So this is anti-inflammatory. Smaller trials shown to be beneficial, including reducing the BPD rates. And this again grouped two groups. One group standard treatment, other group is the pentoxifylline during the first 6 days. And blinded trial, this has been completed. We were part of this study and waiting for the report. Most likely end of next year the report will be available, and till then we need to patiently wait. So the take home message is invest on preventive strategies. One can reduce perinatal asphyxia, HIE, and severe IVH and PVL. And quality improvement initiatives are very important. Non-pharmacological general measures like family-centered care should not be ignored. Avoid antenatal steroids above 34 weeks because of the harmful effects. And antenatal magnesium sulfate need to be introduced below 32 weeks. Therapeutic hypothermia, 35 weeks and above, not below 35 weeks. Add-on therapies, we need to wait on more trials. They are studying melatonin as well. Avoid hypocarbia in ventilated babies. Use early IV caffeine below 32 weeks in infants. And take care of the mother as well as the baby, and the returns will be great. Thank you very much for your kind attention. Yeah.
Thank you, sir. It was great presentation, especially this one that those highlighted about many OGCNs actually tend to give steroids, antenatal steroids, just to avoid NICU admission. So that particular slide was very eye-opener. That particular obsession of avoiding NICU admission, giving late antenatal steroids after 35 weeks can have hazardous consequences, especially ADHD, anxiety disorders, and personality disorders. It was quite good eye-opener. It was very nice presentation, including preterm, full term, and all. Thanks a lot. Thank you very much.
Thank you so much, sir. Now I would like to request Rahul Yavi, sir, to present a moment of honor to Dr. V. Samuel Rajudure, sir. Thank you. Thank you, sir. For the next session, we have a panel discussion. We have a neonatal transfusion practices, time for a relook. We have panelists Dr. Rohit Sashidharan, Dr. Babu Madarkar, Dr. Keshav Kumar Pathak, Dr. Arun Manglik, Dr. Sangamitra. To moderate this session, we have Dr. Naveen Bajaj, sir.
Good afternoon, everyone, and I welcome all my panelists. Now, the population we are discussing is neonates, and one of the most heavily transfused patient I can say in as far as the hospital settings are concerned. Though we don't bother much about it, that what should be our plans for that. So let us spend another 30 to 40 minutes for seeing what should be our transfusion guidelines, what better we can do with the transfusion practices. If you see the data that almost 90% of all the newborns, they require one or other kind of blood products during their stay in the NICU, level 3 NICU if I talk about. And more than half of the baby who are less than 30 weeks of gestation and more than 80% of the VLBW baby, they require RBC transfusion during their stay. Though the volume required is much less, and most of the time the rest of either we talk about FFP or the PRBCs, they get wasted. But we know that the blood volume per kg in newborns at that stage is the highest among the population. And yes, they do also have a immature organ system function, and they are at a risk of higher derangements, infections, and many other things which we are going to talk about. And most of the products which we commonly use is the PAT cell RBCs are most commonly used a blood product in NICU, followed by the platelet transfusion and FFP sometime. Whole blood has some indication which we will discuss, and cryoprecipitate in very rare circumstances. So to discuss this, I do have the panel as experts with me, Dr. Arun, Dr. Rohit, Dr. Keshav, and Dr. Shikanti is there. Dr. Babu somehow couldn't make it. He is on the way. If he comes, then we will include him in the panel. So before we go ahead to when to give it, how to give it, so what are the transfusion risk which we face? Dr. Arnal, I like to start with you. What are the immunological reactions? Are there or not? Because we do have in our mind, we do have the doubt that there is poor antibody antigen formations in the newborns. Say they don't have the reactions because of the blood transfusion. Is it true, or do we have some immunological reactions also happening in the newborns?
Thank you so very much. I have a disclaimer. Firstly, just a neonatologist. I'm not a hematologist or neonatal hematologist, as you would probably be expecting. So whatever we'll be talking about is over the years what we've learned and whatever is there in the literature. Well, we do have plenty of immunological reactions. Some of them may be quite severe and life-threatening, occasionally fatal. But most of the time, thankfully, what we see are common ones are less fatal and are fairly easily managed. And the most common one would be a febrile non-hemolytic reaction, which is probably due to some cytokines which are present in the donor's blood, and that release of those cytokines into the recipient causes the fever and other symptoms, which are taken care of very easily. Next, we have hemolytic reactions, which could be due to ABO issues, but again, antibody production in the neonate is not that much, so we don't get them much, but we can definitely have it if the antibodies are transferred from the mother, as in alloimmunizations. Okay, and what is important is we can have lung injuries, which again are not that common in neonates compared to adults. And here it is actually an antibody from the donor plasma, which reacts with the HLA present. And that's why when the HLA is present, and if you have a lady's blood being used as a donor, what actually happens that the lady may get some HLA reactivity because of earlier pregnancies. So they say that if you have a male donor, that would be better off as far as TRALI is concerned, that's transfusion associated acute lung injuries. Again, this is quite serious and it causes pulmonary edema, and child goes into distress very soon.
So
within a
in
few
general,
hours.
the reactions are similar to what we see in pediatric age group or the adult age group. We have
Very
to keep in
similar.
mind that the similar sort of immunological reaction, either it is an acute hemolytic crisis or the immediate reactions or the delayed reactions can happen in the
Only one
newborn
thing,
setting.
I'll just add just one point. Grass versus host disease can happen, rare, but that if that happens, we are in serious trouble. Child may die out of it.
So my next question, Dr. Bobby is not there. If someone wants to take it, so what are the infections which we are worried about before we generally tend to prefer the conservative approach for giving any transfusion of blood or a blood products?
Well, there are a lot of viral infections, bacterial infections, which may be transmitted. Even parasites can be transmitted. Among the viral ones, which
stop, the abdominal distension happen. So that is very difficult to answer ourselves as well as explain to the parents that. So we have to keep in mind that the risk of transfusion, especially in preterm babies, the transfusion associated NEC is there, and also the sometime IVH as well as
IVH as well as ROP has been
ROP has been found to be relatively at a high risk in especially preterm babies. Yeah, any metabolic complications, Dr. Rohit, specific to the neonates which can happen?
So the most common metabolic conditions which are seen following a transfusion is there can be glucose disturbance in the form of either hypoglycemia or hyperglycemia. It can be related to the practices, like some units withhold feeds or withhold fluids during the time of transfusion, that can predispose to hypoglycemia. It may be related to the dextrose content in the citrate preservative, which when given rapidly can cause hyperglycemia followed by a rebound hypoglycemia. Other common metabolic abnormality are the electrolyte abnormalities like hyperkalemia, which is also not very common unless we are giving massive transfusion, large volume, too rapid or old stored blood. So these are the conditions where we see hyperkalemia. And hypocalcemia and hypomagnesia is also seen mostly because of the citrate which will bind. These electrolytes will bind to the citrate in the blood and that can predispose to these electrolyte abnormalities.
So this is a chart which shows how much the potassium overload happens during transfusion. In general, if you give a normal volume transfusion, generally it should not be a problem. But very rapid and high volume transfusion, you may need to monitor for.
If it is a
hyperkalemia,
stored blood and so old blood, then there is more risk of.
Especially if it is irradiated. If it is irradiated, then the potassium load becomes double than that of a non-irradiated blood when we are using. So before we transfuse, we should counsel the parents as well as take a proper consent that this is what we are going to give. Either it is cells or FFP. And to avoid the clerical mistakes, double check that transfusion bag labels are correct, that the bag is issued. Any visual particulate matter you are seeing, especially during platelet transfusion or during PRBC, if you are seeing a hemolyzed RBC or some clots inside the bag, and tend to use a peripheral cannula. Can we use central line for transfusions of RBCs? Anyone from the audience can also participate. Can we use central line for the transfusion RBCs or not? So generally a wide bore transfusion cannula should be, peripheral cannula should be used. If you are using a central line, then there is a high chances of getting it blocked just because of transfusion clots itself. Second is, if it is a small board, then the chances of hemolysis is also there. Any central line should be used if you don't have a peripheral line backup. Otherwise, you should prefer to use peripheral line as a first choice for giving any of the transfusion related products.
Just a small comment, that double check transfusion is very important.
Yeah.
Only last 15 days we had an incident.
Cross check, cross match it versus if we are giving FFP versus if we are giving platelets, then how specific blood grouping should be checked or a cross matched or not. If you talk about PRBC, so should we check blood group should be cross matched? Yes, it should be cross matched. Yeah, everyone knows. So what about FFP and platelets? So if the baby is B positive, and so what kind of platelets you can give to the baby? Or do we need to cross match the plate cells also?
Ideally, we should cross match. So you may at times transfuse without cross matching in real distress or situation, but ideally, never know there will be plasma which will be containing antibodies relevant to the blood group the plasma is from or the platelets are from the donor, depending on the donor. And if the recipient does not match with that, there are possibilities that the antibodies contained in the donor plasma, which is there as a component in the platelets as well, well, irrespective of however concentrated you are doing, that may cross-react with the recipient's RBCs and may induce hemolysis.
So generally when we use FFP as well as the platelets, we check the ABO specific blood group. That if it is B positive, then the B positive blood group should be of platelet should be given. You can give negative also. RH compatibility is you may not ensure, but yes, ABO compatibility of FFP as well as platelets needs to be assured that it should be of same blood group as far as ABO is concerned. Cross checking I meant was the cross matching as we do in a blood transfusion. You may not need for platelets or FFP of cross matching of a donor as well as the recipient's blood as such is not required. That is cross matching over the slide what we are doing for to detect any minor blood group incompatibility or any other autoantibodies which are there in the donor blood group. So there is another interesting thing. Can we use a autologous or a umbilical cord blood in neonates? Suppose the baby is born, doctor, and you collect a blood from that placenta or a baby's umbilical cord, and then can we keep it and give it later if the baby requires, especially in the preterm babies when we know that the ELBW, 80% of the ELBW babies need blood transfusion, then can't we take it from the cord blood and save it and then give it whenever it is needed?
Autologous or umbilical cord blood transfusion is basically collecting blood once the baby is delivered, before the placenta is delivered, and we separate the contents and then transfuse it at a later date. So can we give? Yes, we can give. Theoretically speaking, this autologous cord blood will help in prevention of immunological reactions that can occur in preterm babies requiring multiple transfusions. And the other thing is it will prevent the shift from fetal hemoglobin to adult hemoglobin in these babies. So why are we bothered about this is because adult hemoglobin will release oxygen, the affinity is less. So there is greater release of oxygen to the tissues resulting in oxidative stress.
So are you practicing it or not? Is it practical feasible to do it for all of us?
The feasibility is the problem, sir. Actually, we have done a study in SRMC when I was doing DM, exactly when DCC was proposed in the NRP protocol during 2015-16. So the feasibility is a problem here because there are three things that we need to look at. First thing is how much amount of blood can we collect when we are following, delayed cord clamping. So the amount of blood we can collect is very less if we do DCC for exact 1 minute. In the study we have done, we were able to collect cord blood sufficiently in only, less than 30% of the study babies. And the second thing is the timing of transfusion. You can transfuse this blood only between 3 to 14 days. 3 days, why? Because we wait for the blood culture, and within 14 days we can transfuse, but most babies will require transfusion either before 3 days or after 14 days.
Yeah, after 3-4 weeks.
And the third thing is storage of this blood. The component is also a problem because the blood bank needs to have a separate permission.
So as far as the practicality is concerned, it is not feasible. So probably it is not to be practiced right now because we don't have the proper storage facilities to do this. Okay, another question to Dr. Arun. Dr. Arun, it might be a common question the parents ask that, okay, you need a blood to the baby, I am the father, so I can donate. Or the mother, you can take it has been a practice a few decades back that you take a syringe, take a blood from the mother, only 10 ml, 20 ml is required, and then you keep on and you transfer to the baby. Is it practical okay to do that?
Well, it's both yes and no. Because as you said, from the parent you can always take a small aliquot, and the neonate will probably require 20 or 30 ml of blood. From the blood banks, most of the time they'll give you a full volume and the rest is wasted. That's one aspect to it. But the practical issue is that the HLA typings of the baby and the parents are sharing half of the HLAs of the baby, and that can result in problems. There can be HLA associated issues, particularly graft versus host disease, which can be very, very detrimental, particularly if the mother is donating, because if she had an early pregnancy, there will be some cross fetal-maternal transfusions which have occurred during pregnancy, and HLA typing would cause subsequent problems in the subsequent pregnancies. So ideally, no, but sometimes we do allow, particularly if the parents are very insistent and religious, we should explain to them that the baby may have problems and we document that they want it that way. Ideally, no.
So higher risk of having a cross activity across the antibodies as well as the HLA. So possibly not the ideal choice, not the first choice to use any of the parents, but yes, during extreme circumstances you may do, and that too with the mother. So father should not be allowed to give a blood to the baby. What are the, so let's come to the indication when we should transfuse, and to Dr. Keshav, Dr. Babu is not there. Will you able to answer with the audience that what are the indications for packed red transfusions?
So basically, as far as indication of PRBC transfusion concerned, we have to take the multiple things in account. It mainly depends upon the few things. That is, what is the gestational age of the baby, whether you are treating the term baby or the preterm baby. The next thing, the study has shown that basically what is the postnatal age of the baby, whether you are in the first week or the second week or beyond the third week onwards. And third thing is, what are the different modes of respiratory support that your baby is on. So when you take into this account, and whatever the landmark trials that has been recently published, like as ETTNO trials and the top trials, they have assessed the liberal transfusion versus the restrictive transfusion.
So overall, we tend to be very restrictive as far as the transfusion is concerned.
Based on landmark trials, one thing is clear, that is restrictive transfusion policy is the standard of choice, and currently we are following the restrictive transfusion groups. Again, based on that, and even NFCPG has given clear-cut recommendations.
This is the general guidelines,
this is the general guidelines, especially less than 32 weeks baby. This we have to follow. That one side is there is a postnatal age, another is the mode of respiratory support, and third is you will see that whether baby is
more
preterm.
stable
So
the
baby
baby is, the
babies.
more restrictive the policy. Maybe
Yes,
at a 7.5 or 8, you tend to wait before giving a PRBC transfusion, and for a sick baby on ventilator, you tend to give it at 10 to 12, especially in the earlier few days. You can follow and see on the website also, the table is available for the pursual. And the next one to you also, how much to transfuse and how much should be the duration of transfusion?
Yes, regarding volume of transfusion, basically most of the RCTs that have compared the high volume versus low volume. So low volume, that is 10 to 15 ml per kg, has been compared with the more than 20 ml per kg of transfusions. And what outcomes they have seen? They have seen the survival as well as the different morbidities in the form of ROP, BPD, and the patent ductus arteriosus. They did not find any increased risk of mortality.
So if we conclude all those studies,
so after conclusion, after concluding all these studies, low volume is as good as high volume. So one should follow the, even NFCPG as well as British Society of Hematology has clear-cut given recommendations regarding low volume transfusion, that is 10 to 15 ml per kg, and especially in non-bleeding patients, if you will go for higher volume more than 20 ml per kg, even it can result into circulatory overload. So my conclusion is you have to go with 10 to 15 ml per kg. And regarding rate of transfusion, usually you have to complete it within 4 hours, and usual rate is 5 ml per kg per hour. But yeah, if you are dealing with some cardiac failure cases or like as symptomatic anemia in the form of congestive cardiac failure, then you need to go slow. That is less than 2 ml per kg.
And do monitor these babies even if they are stable, because I'm sure most of us has seen adverse reaction of transfusion, especially when the baby is very, very stable and just ready to go home, a ELBW baby, and at around 1.5 or 2 months of life, we are started transfusion, and then they have a adverse effect. Even if the baby is stable, do monitor all the vital signs during the transfusion and at least 1 hour after the transfusion. So there is a lot of debate about that. I'll ask that, the blood bank should give a very fresh blood to the baby. Dr. Rohit, so what should be your consideration? Is the age of packed red blood cells is in consideration while transfusing or not?
So when you say fresh blood, there is a lot of controversy regarding the definition, whether it is 3 days, 5 days. Some say up to 14 days is to be considered as fresh blood. And the standard practice, if you look at the median age of the blood which is being given to neonates, most of the studies have shown that it's around 14 to 15 days or something. And the concerns, if you say will stored blood will be the same fresh blood? You can see that there is a gradual degradation of the RBCs in stored blood. There is a chance of increase in potassium and hyperkalemia, and also some immune reaction is also much more in stored blood. But if you look at the evidence, there is limited evidence in neonates per se, but there is a large study called the ARIPI study, and they compared fresh blood less than 7 days versus standard issue, and they did not find any difference in when it comes to mortality or the common morbidities as a whole or in infection. And if you look at the adult guidelines and adult evidence, there are multiple meta-analysis which have shown that there is no difference in any of the outcomes, whether you use a fresh blood or whether you use a standard blood. And on the other hand,
so generally the age of the blood is irrespective of it. You can use even the blood which is older than 7 days, but maybe preferably if you have a choice of having a less than 1 week old blood, and then you may tend to choose it.
That has one implication. One is that the fresher blood, that means it puts a lot of stress on the blood bank. You need to have more additional donors, more additional storage and all these facilities. And every time if you give fresh blood, that means the baby is getting exposed to multiple antigens.
So the risk of any complication doesn't increases if you are using a blood which is older than a 1 week of life.
So we can consider in select situations when you have to give large volume blood or when you have to do an exchange transfusion.
What is the benefit versus risk of irradiated PRBC is quite in use nowadays. Even we tend to use it quite often. Is there any specific indication or everywhere we should be using? What are the benefits as well as the risks?
The benefit of irradiated PRBCs is it prevents transfusion associated graft versus host disease. Especially in those population of babies where multiple transfusions are required and there is immunocompromise. But what is the risk of these irradiated PRBCs is basically irradiation results in storage lesions in RBCs. What are storage lesions? Is irradiation results damages the PRBC, the membrane of the RBC and results in leakage of potassium causing hyperkalemia. So what is the best time to prevent this risk and balance the benefit of irradiated PRBC is we need to irradiate the PRBC prior to transfusion and transfuse it preferably within 4 hours.
So any specific population where we should try to give irradiated only, maybe ELBW babies less than 1200 grams, we should tend to use irradiated PRBC, generally speaking. In older neonates, if you have a choice, you can use irradiated. If you don't have, obviously, then you can use. But it is preferred to have a irradiated PRBC over the normal. And these are the specific situation with the extreme premature baby, any malignancy, any cellular deficiencies, or HLA cross-match products. Then you must use a irradiated PRBC in those circumstances. And Dr. Arun, what about the feeding protocol? Because in our unit, our staff nurses are very, compliant about it, very stressed about it that we are giving transfusion, or should we not?
Well, we have a wonderful guidelines from the NNF itself. In the community practice guidelines, the CPG, they are very clear about it that you stop feeds 3 hours prior to starting the transfusions and continue to hold of the feeds till the end of the transfusion.
And there is a concept that practice only.
There is a concept that if the baby is absolutely healthy, maybe a full term 38 weeker, for some other reason the child had bled or something and otherwise was not sick, maybe in those situations some researchers say that you may not withhold feeds, you may continue, but overall by and large you need to stop the feeds and maintain the blood glucose by having adequate IV fluids.
As Dr. Keshav has also said that the risk of NEC becomes higher, especially in a preterm babies when we transfusing it. Though we are following the restrictive transfusion policies, the one way to reduce the overall, incidence and the prevalence of giving any of the transfusion blood-related products to the newborn. Is there any specific measures which we can employ to give to reduce the chances that a preterm have exposure to the blood products, especially the PRBCs? Is there any measures we can do quickly if you can count few one? Dr. Rohit?
So one thing which we should do is delayed cord clamping. That itself gives us adequate stores for.
Yeah, enough evidence is available that the delayed cord clamping will reduce the risk of
Then you should go away with. We can even use the cord blood for samples like blood groups and DCT and other investigations, thyroid, etc. And another important thing is to go away from routine samplings. Like only when you know that it is indicated and it is going to interfere or change your management should we send a sample. There is no
clustering of sampling. That if you want one, you want another sample also tomorrow, but there is no emergency, you can club all this, then you have to take the smaller amount of blood.
Another method is using micro sampling techniques like capillary blood gas, and even most of the blood gas will have electrolytes, even bilirubin, and lot of parameters are available. Even urea creatinine is available in some of the blood gases. So micro sampling method is one technique. And one more thing is use of point of care non-invasive devices, which again will help us to go away from sampling. And one thing is you have to like only if you monitor how much blood letting you are doing, then only you will come to know the significance of how much blood we are taking from the baby on a regular basis. So that is another policy which you can implement too.
Yeah, true. So your staff also should have the habit of putting it down that on this day this much of blood volume has been taken from the baby. And if you are very liberal in sending samples, you can calculate that half of the blood in a very sick extreme preterm baby in a 1 month period you have already sent to the lab.
Just a small point. I mean, just to add to what he said, absolutely micro sampling is very important, and we must ensure that the labs support us to that extent.
Yeah,
quite often in a lot of places, particularly a bit in the periphery, the lab will say, I need 2 ml of blood.
Yeah, sure. Is there any role of recombinant human erythropoietin in this ELBW? Is anyone using in the audience RHEPO for reduction of transfusion in extreme preterm babies? Or any of my panelists is using?
We had used, but
we had used of recombinant human erythropoietin in the first week of life, maybe in the first 3 days of life, has proven to have an advantage of reducing the risk of transfusion in the later, especially in ELBW babies. So that practice probably some of the units are doing, some are not much convinced to continue it, but that is okay. But that, yes, that will help. So Dr. Keshav, should, as we talked about irradiated blood, then should all the blood products should be leukocyte reduced and CMV seronegative donors should be tested for everyone. As you know, the CMV spread, especially in a ELBW baby, from the transfusion which we have used during NICU stay, is one of the common reasons of giving CMV to ELBW baby, which are already have immunodeficiency.
Yes. Thank you, sir. Sir, as far as transfusion concerned, we know that most of the transfusions that we provide in our NICU mainly goes to the extreme preterm or the very preterm babies. And when we talk about CMV, transfusion associated CMV, these are the subgroup of babies or the chunks of babies that are more symptomatic or most predisposed for the transfusion associated CMV. And if you go for leukoreduction as well as you go for CMV seronegative donors, by combining, even you can reduce the chances of CMV transmission to 0%. And it has also been seen that even it reduces the all-cause mortality. So based on that, there are other advantages also. Even you can reduce the TRALI, as we talked about, as well as some febrile non-hemolytic transfusion reactions.
So if possible, we should start doing this,
especially in extreme preterm or the very preterm babies. Even NFCPG as well as British Society of Hematology also recommend that one should go for CMV seronegative donors till 44 weeks PMA of age.
So we tend to...
I think at least we should follow this practice in at least preterm babies, especially extreme preterm babies.
So Dr. Rohit, we have talked about packed red blood cells, all the questions. Is there any role of giving whole blood transfusion now in the present area?
The standard practice is PRBC only. But there are certain situations where you might consider, like if there is a massive requirement of, there is a acute trauma loss, ongoing bleeding is there, then we might consider. Or in case of some exchange transfusion.
In emergency situation, when you have more time for the availability of packed red blood cells.
It will take time for a reconstituted PRBC in case of exchange. But
and the exchange is probably the only indication which has been left where we can use the whole blood. So when and how we should transfuse platelets, coming to the second component, that what should be the indication, Dr.
Indication for platelet transfusion is we have clear thresholds mentioned in the NNF CPG guidelines, this is an extrapolation of the Planet 2 trial, which is one of the largest trials that we have with our available evidence. And here we know the threshold, it should be less than 25,000 for those neonates without any bleeding, including those with NAIT where there is no history of intracranial hemorrhage. But any neonate with bleeding or coagulopathy or any surgery, invasive procedures, then we need to follow a threshold of less than 50,000 and less than 1 lakh if the neonates have major bleeding or requiring major surgery. So these are the thresholds we follow. And how do we give platelets? Previously, we were thinking about the platelet functionality and thinking we need to give platelets at a faster rate. But we do not give any blood products at a rate greater than 5 ml per kg per hour. And platelets is, it is not an exception to this. Why? Because though we give platelets at a slower rate, like at over 2 to 3 hours, the platelet functionality is not going to be affected and we can very well give it.
So the reactions with the platelets are also not uncommon, especially in a sicker babies when we are transfusing. So again, stressing upon the fact that we should keep on monitoring for any change in the vital parameters while we are transfusing any of the product, either it is a PRBC or the platelets or the FFP. Dr. Keshav, can you tell us what are the indications for giving fresh frozen plasma, which is the third common component we tend to use, and what should be the volume we should give it?
Thank you, sir. As far as FFP concerned, basically we are having two group of babies in our NICU. One babies, those who are having only abnormal coagulation parameters upon screening.
Asymptomatic.
Those are asymptomatic.
Who are not bleeding.
Who are not bleeding. And second group is those who are abnormal coagulation parameters as well as they are bleeding. So one thing dictum is clear that those babies who are having abnormal blood coagulation parameters as well as if they are bleeding, you should go for FFP transfusion. But if you don't have to go for FFP transfusion solely based on the abnormal coagulation parameters, if they are asymptomatic and if they are not going for any invasive surgery or they are having no any underlying coagulopathy, you don't have to give FFP transfusion. One thing also I would like to add, that is especially during hypothermia. During therapeutic hypothermia, if you go for routine coagulation parameters, if baby is having abnormal coagulation parameters, you don't have to go for routine FFP transfusion during TH.
If there is no bleeding.
If there is no bleeding.
Then how much volume should we transfuse at one time?
Again, volume 10 to 15 ml per kg of FFP is well enough. It does not provide any circulatory overload, and ideally it should be given over 1 to 2 hours.
So suppose you have a FFP comes in something around 150 ml of volume pack, and you thaw it, and then
one thing
can
is that
we reuse it again and again? Or
that's a very valid question. Basically, most of the FFP is usually stored at minus 30 degrees centigrade, and the overall half-life is approximate 1 year at minus 30. Once you are thawed it, or once you have thawed it, you can just preserve this FFP in the refrigerator, and you can use up to at least within 24 hours or as early as possible, maximum preferably within 4 to 6 hours. But if it is stored in the refrigerator, it can be used within 24 hours.
So just a small point to add. Absolutely perfect on the dot. There has been an earlier practice in some units to use FFP as a poor man's immunoglobulin. That should be done away with. That message should be loud and clear that one should not be using this as a substitute for immunoglobulins.
Yeah, for providing
and again, I would like to add, sir, especially FFP also should not be given as a volume replacement, as well as prevention of IVH. Even some units are following, some people are even following for prevention of IVH. You don't have to transfuse FFP for prevention of IVH as well as a volume replacement therapy.
Absolutely right. It is a blood product. It has its own immediate as well as long-term adverse effects. Is there any role of cryoprecipitate, or if required for bleeding, should we use FFP or a cryoprecipitate?
Regarding cryoprecipitate and FFP, if you go for evidence, we basically have some observational studies, and based on these observational studies, if you are dealing with acquired coagulopathy, that is if baby is having DIC, or if baby is having some sorts of coagulopathy due to sepsis or due to post-HI or due to liver dysfunctions, definitely the product of choice will be the FFP. But despite FFP transfusion, if the baby is having persistent hypofibrinogenemia, like as fibrinogen level less than 1 gram per liter, or babies having major hemorrhage, so one can go for cryoprecipitate. But
bleeding with documented lab abnormalities,
lab
if you are
abnormalities with
having,
fibrinogen level.
only then you should be going for
But if baby is dealing with some congenital factor deficiency, especially factor 13 deficiency, or baby is having congenital deficiency of fibrinogen level, then one can go for cryoprecipitate. Or if the specific factor level is, factor concentrate is not available, even in hemophilia A or von Willebrand factor disease, one can go for cryoprecipitate.
Yeah, so any specific messages during this discussion we have you want to give to the audience? I'll ask all my experts here.
Yes, sir. Sir, first of all, we should, before going for transfusion, we should always minimize the need of transfusion. So always you have to first think about that whether this baby requires any transfusion or not. So whenever you are going for transfusion, is there any way through which we can just avoid the transfusion? Always think and then go for blood products, because although there are multiple benefits of blood products, this transfusion is not without any side effect. There are side effects also associated with transfusion.
Yeah.
We should try to minimize blood loss at all costs by use of point of care devices, micro sample devices, and delayed cord clamping and other techniques.
We are using three components: packed cells, FFPs, as well as platelets. We must ensure that we really give when we really need it. Just being liberal with blood products is not to be done at all.
So restrictive RBCs as well as the lower threshold for platelets overall, if you think about the baby as such, should be followed.
Checking and documentation is the simplest thing that we can do to prevent transfusion associated complications in the NICU. I think that should be a norm, and we need to definitely check and document prior to every transfusion.
So monitoring of the baby before, during, as well as after transfusion of any of the blood product is must. Mishaps do happen, that especially for stable babies, it does happen. So do not miss out on that. And pick up the earliest action possible, and then intervene, stop the transfusion, and take the steps according to the adverse event which was happening.
And the last line: encourage our labs to give us leuko-reduced and CMV negative bloods.
CMV negative donors and irradiated PRBC wherever feasible it is. Yeah, thank you. Thank you. If the audience has any questions, then experts are welcome. Yeah, yeah.
I would like to know in the numbers how long can suppose INR is sending. A cutoff you are using, sir.
Okay, basically for the transfusion, if the baby is symptomatic, usually we are following the 1.5 times of the gestation specific cutoff. So if the baby is bleeding, simply you have to see the lab parameters. If it is more than 1.5 times, you can definitely give transfusion. You will give transfusion. But if baby is asymptomatic, so definitely sometimes happens that is there are multiple things. When you see the procoagulant factors and the anticoagulant factors, you better know that a newborn is having in the different balance of these pro and anticoagulant factors, and sometimes despite having abnormal parameters, these babies don't bleed. So definitely if there is a borderline, basically there is no certain guidelines that is up to what multiple times or up to what level you will wait. But according to my opinion or whatever the practices we follow, usually we follow up to, if there is some borderline abnormalities or 1.5 or 2 times abnormalities, usually we wait.
Generally the values of a preterm and a term babies are different, the coagulation parameters, and they are different from the pediatric and the adult range. So these values are totally different. So you have to match these values. Either they are normal for that particular preterm baby or a term baby. If they are abnormal, then only the questions come. So most of the time these values are normal for that particular gestation. Even if they are abnormal and the baby is asymptomatic, then generally we tend to avoid giving any of the blood products for specific, until and unless we have specific anticoagulant deficiency which is being documented, and you need to investigate why this is happening, rather than just giving FFP and trying to cover it up. Just try to find out what is the exact reason for that. You might be having hemophilia quite early, presenting quite early in first 1 month of adult, 1 month of life. I have seen a baby of hemophilia having a very huge subgaleal bleed, which was very slow to recover. We did investigate for hemophilia on day one, but yes, and second, third week of life, when we have started investigating that why this is something which is unusual, not matching to the other baby, then it was a hemophilic baby.
And again, I would like to add that what is our stake at the baby. Basically, when you are going for major invasive surgeries or you are dealing with major invasive procedures, then definitely there is a chances of higher bleeding. So definitely, even if the baby is not bleeding and baby is having abnormal coagulation parameter, one should go for FFP transfusion. But if the baby is asymptomatic, you have time to just watch over and just follow the baby. So better to just wait and watch.
Sir. Routinely, no. No role of diuretics routinely while you are giving PRBC's transfusions. No, the PDA is totally different entity. When you are transfusing it, we are not transfusing it considering that the baby is having PDA or not. The guidelines of PRBC has no relation with the baby having PDA. It has a relation with the baby on ventilatory support or a non-invasive mode or not.
And the baby is on now diuretics because of we have to give transfusion if it is a premature. Now the baby is on 120 ml per kilo. How to go about the fluids and the PRBC transfusion? Here we decrease 20 ml per kilo and then give blood. How to go about it?
The total will be 120. It will continue as 120, and then for the relevant part of 5 ml per kg of that FFP which you are using or whatever you are using, you minus that from the total fluid, as simple.
And you might have to stop and significantly reduce the volume of the fluids which you are giving during the period of transfusion.
And probably a PDA question is related to possible expected cardiovascular overload. Okay, but that wouldn't happen if you're, and you got to monitor continuously. You just won't be transfusing and going away. Okay.
Sir, only one question from my side. Sir, can one FFP given to the other blood groups? Same FFP can be given to the other blood groups?
No, the FFP is blood group specific, ABO specific. If it is B positive, then preferably you should be giving B positive, B itself. RH can interchange. You can give RH negative to RH positive, but it should be a same blood group. ABO compatibility should be there. You need not to cross match it, but ABO compatibility should be there.
Hello.
No, FFP cross matching is not done before you transfuse.
Hello. My question is that if you are doing transfusion with 2 ml per kg, so duration of the transfusion can be increased more than 4 hours.
Usually we'll give it at 5 ml per kg. Only in very rare situations when the child is very unstable. Okay, then you may cut down the rate of transfusion. In that situation, obviously it'll get prolonged. And then in that, it's better off restricting it to at best max 10 ml per kg, so you can still finish the transfusion in 4 to 5 hours.
Most of the unit has practice of earliest, fastest is 3 hours and slowest is 6 hours. So generally 4 hours is the general routine. If it is a overloaded baby, sometimes we feel we give it relatively slow to maximum 6 hours, and fastest in case of volume you need sometime to 3 hours. Lesser than 3 and more than 6 has more of a adverse event of having more of a hyperkalemia and transfusion reactions, and slowest will have more chances of having hemolysis itself lying in the syringe.
Reuse of the FFP bag, just talked to one of the panelists. Once we puncture the FFP bag, can we use the further after 24 hours or 30 hours?
That was quite intentional, in fact, that why I have asked this question. You can, once you have thawed, you can use that bag, ranging from 24 hours to 5 days. If you keep it in the refrigerator at a degree of 1 degree to 6 degrees centigrade temperature, we have to keep it that. But yes, if you keep it for a prolonged period of time, the risk of infections might increase. But because FFP, you have a larger volume and you are just giving a 15 ml or 20 ml and the rest of the odd, as such the fall of the factors are only 30 to 40% within 5 days. So still you give a lot many factors within that period, but yes, but if you keep on puncturing with the open needle, then the risk of infections you have to take care about that. So don't do puncture and keep open the needle. You can have a sealed syringe and that can go in parts.
In fact, most of them come with the auto seal system. Once you take the needle out, it auto seals.
Yeah, if that is, that depends upon the blood bank. Some blood banks give you smaller volume also as far as the PRBC as well as FFP is concerned. Nowadays, our blood bank gives smaller volume FFPs also.
Sir, time is up. Thank you so much, sir. Now I would like to request Dr. Navin sir.
To all panelists, yeah.
Sir, I would like to request Dr. Navin sir to present mementos to the panelists. Now I would like to request Dr. Arun Manglik sir to present a memento to Navin sir. Next session we have debate. Debate on AKE in the NICU, clinical concern or creatinine confusion. To debate the session, we have Dr. Kumar and Dr. Jyoti Bagla. To moderate the session, we have Dr. Tejo Pratap Oleti, sir. I would like to request Dr. Tejo, sir, to introduce the speakers. Thank you.
You want to say that's it? This can we have 2 mics to them?
Hello.
Yeah, you can open this.
Hello.
Okay, good afternoon, everyone. I know it's a post-lunch session. Some amount of hyperglycemia and then some amount of surge of the melatonin and other things will be happening. Definitely. Let's see how our debate is. We'll try to help you to be awake and then do it. So we thought, because it's only a 20 minutes time that has been given to us, how best we can utilize this time. So we came out with an innovative idea that will keep some questions which are usually will be there with us, and then 2-point views in a different polls our esteemed faculty will be trying to help. So we have with us Dr. Kumar, who is a senior faculty at Hassan Institute of Medical Sciences. He has so many things to his credit during his career. And we also have Dr. Jyoti Bagla, who is the academic registrar and from the ESIC Medical College, as you can see, and she is also having a lot of publications and other things. So both are very enthusiastic and have a good career and have dealt with a lot of these sort of cases. Okay, so without wasting time, we'll start off with a few questions. So first question is that, is the neonatal AK is truly a major concern? Or is it just because we are doing the creatinine, we are worried about it? Can we have Kumar first your views?
Absolutely, yes. Most of us are working in a neonatal NICU, where most of
whenever a baby comes with AKI, if it is diagnosed, yes, because we only get around 30 to 50% of sick babies are because of AKI. Most of them, AKI are associated with one, increased mortality, as we all know, increased duration of ventilation, as well as there is they lead to multiple organ damage. And then if we see what are the impact of AKI and other organs also important. If you look at eye, yes, they increase ROP. If you look at heart, they got cardiac dysfunction. They have PPH and severity is also increased. If you come to stomach, the feeding intolerance and NEC will also increase. On long-term basis, yes, CKD in childhood, hypertension, reduced GFR, higher risk of metabolic syndrome. So all these are very important. That's why AKI is very important.
So do you want to?
So regarding existence of neonatal AKI, this can never be a matter of debate as far as neonatal AKI is concerned, because there are n number of evidences which indicates that it really exists in true manner. But there are certain confusions, certain diagnostic dilemmas because of unique physiology and kinetics of the creatinine and urine output in newborn. So we will be discussing them in this session one by one, and I'm sure after this session, many of your confusions will be taken care of.
So, Dr. Kumar, do you still stick that? Do you still feel that we need to just look at the clinical concern, or still you feel that creatinine is a good mark?
Creatinine is a gold standard. As such, right now, creatinine is a gold standard for diagnosis, but making it as the only one marker, no. There should be other markers also to increase the diagnostic significance. And for that, we have KDIGO, that is kidney disease improving global outcomes, which has an entity which they will describe on AKI. They have made stages. It is according to them, stage 1, stage 2, stage 3 they have done based on urine output also. So AKI is mainly for children as well as adults. They have modified in neonates, and that is called modified criteria, and it is published. And we should always remember that this is KDIG is the global definition. It is modified in newborn, and it is used in almost all modern studies, and it helps in standardizing the diagnosis. So KDIG we should remember.
Sure. So the main important points in the KDIGO is that from the baseline, how much rise is there, both in terms of proportions and also the absolute value, and also that is there any difference in the urine output. Yes. That is important. So whenever you are looking at a baby with a suspicion of AKI or established AKI, you should remember that you are looking at least these 3 parameters so that you will be able to help that baby better. So do you still feel that absolute value of creatinine is better, or how do you feel, madam?
Yeah. Since newborn has a unique physiology and variable kinetics of the creatinine, there are certain pitfalls in creatinine measurements and diagnosing in AKI based on the creatinine. Because serum creatinine reflects maternal creatinine in first 48 to 72 hours, then gradually it declines, and we can follow later on. Serum creatinine also affected by various parameters like fluid status, muscle mass. It can also, bilirubin can also interfere in its estimation. And creatinine is a late marker. There is a time lag between the injury and the actual damage. So by the time creatinine is risen to the level, already the damage has been done. So alone, this cannot be taken as a sole marker, but of course, it's a gold standard. It has to be combined with urine output and other strategies.
So continuation of the same, Kumar.
Absolutely. Serum creatinine it is a gold standard to say that yes, there is a kidney injury, but we should not take it as a single value. The trend of serum creatinine is important. So to follow the serum creatinine level, if it is associated with other markers also, then it makes life easy.
Does this AKI directly cause mortality, or is it merely a marker of some of the severity of the illness?
Whenever we think of AKI, we usually get frightened whenever there is an acute kidney injury. So yes, this is an independent mortality marker that everyone knows, because whenever there is a kidney injury, we also will get frightened. Yes, there is something happened to the kidneys. We should act immediately.
So don't take it lightly. That's what I can say. Dr. Jyoti, you want to say something?
Yeah, AKI is per se is not a direct killer in most of the cases, but it is just like a red flag. If AKI is present, then it indicates the critical sickness of the neonate, and many of the complications which develops because of AKI in a sick child needs a trickier management. So it's always good to establish the diagnosis well in time so that baby can be managed better.
Hey, you want to add anything more, Kumar?
If you look at one by one, there are so many clinical concerns if it is concerned with AK. If the baby is born preterm, so already there is immature nephrogenesis. One, babies will be on nephrotoxic drugs which can cause damage to the kidneys, and there will be reduced nephron number. So all these things will also cause problems to the baby's kidney. They are also difficult to diagnose. This is also one concern. See, serum creatinine initially may be very high, then it comes down, it takes time to come down. Urine output, we cannot measure it probably because it is variable. And the clinical signs are absolutely non-specific. It can be feeding intolerance, lethargy, metabolic acid. Based on this, we cannot diagnose AKI. And the third concern is fluid overload. See, this is the most dangerous part. Fluid overload more than 10% increases mortality. If it is more than 20%, whatever may be the cause, if it is more than 20%, that needs dialysis. So all these, and then nephrotoxic drugs, whichever is given to the babies like aminoglycosides, NSAIDs, diuretics, vancomycin, then contrast agents, all these drugs, they damage kidneys. So these are some of the clinical concerns we should remember. Whenever every baby in NICU will be having one or two drugs which are nephrotoxic. So we should always...
And some of the pharmacokinetics of adult which are available may not be relevant to the neonatal physiology.
And even these drugs, they may not show us. That means this serum creatinine will take time to rise. So it should be always be watchful.
Sure. You want to add? Let's go through some of the points which are there.
Yes.
And then we can try to...
we will have this case study. This is a preterm 30-weeker. He's 1.2 kg. This is a history of leaking PV. And he's admitted in NICU and he's on IV fluid. So urine output is 2.2 and CBC is as shown. His creatinine is 0.5. He has been put on antibiotics. So what do you think on day 2 of life? Is this AKI?
So what do you feel?
There is a rise of serum creatinine from 0.5 to 0.8. Here there is a preterm baby leaking PV, and then there is rise of creatinine also. This is AKI because there is significant rise of serum creatinine. We should be careful. What do you say, ma'am?
Yeah. See, serum creatinine has risen from 0.5 to 0.8. The value of 0.3 is increased within 48 hours. So that's fitting into the category staging 1. Although there is urine output which is normal and will remain normal even next day, but as we know, most of the neonatal AKIs are non-oliguric. So this child is definitely having neonatal AKI because he is vulnerable. You can see there are various risk factors like prematurity, VLBW, he is leaking PV, he is on antibiotics and most probably aminoglycosides.
So we need to see whether it will sustain or it's only a one value, and then definitely this child is at risk of more chances for the AKI.
So basically we have to anticipate AKI that this child is vulnerable, he may develop. Then only we order creatinine next day. Otherwise we may not.
Sure.
So
we have one more baby, term neonate.
So this is a term neonate.
Did it serve some other purpose, like they were supposed to start an antibiotic?
Yeah.
So because of the PROM risk and some other clinical illness, and you have creatinine of 1.5, and urine output is 1.2 ml per kg per hour. First day, maybe I will feel that might have been a normal because the baby is absolutely only on breastfeeding. Do you still feel that this is a problem?
See,
with the creatinine value?
No. On the day 1, serum maternal creatinine usually reflects the baby's creatinine. So we can check the mother's creatinine as well. And if it is correlating, then we can attribute this to the maternal creatinine level. But if we'll have to follow the child. If baby remain well stable, there is no need of doing anything because this is not looking like AKI. Sure. Even urine output on the day 1 is there is a physiologic oligonuria.
Sure. We have a baby, another baby who is extremely preemie, and then 9 milligrams baby was on ventilator, umbilical lines were there. On day 3 developed a hypotension and oliguria, around 0.5 ml per kg per hour. And you have the value of 1.2 creatinine, previous value was 0.8, and now blood urea is reasonably okay, 30 milligram per deciliter. Do you still feel that now it is an AK?
So, yeah, I ask audience now. Is this AK?
So what do you feel? Is it AK?
Yes. What all KDIGO criteria are meeting here? Number one, creatinine has risen from 0.8 to 1.2, means 1.5 times. Plus, there is oliguria. So, because of creatinine criteria, it's KDIGO stage 1, but there is urine output criteria, which is 0.5 ml per kg per hour, making it into the KDIGO stage 2. So, this is sick child and he's meeting.
We have to see whether the transient urine output, which is lower, or maybe once you change the hypotension.
And also here it is a sick child. It is already ventilated, all with umbilical lines. So there is critical history with serum creatinine going up. So this is AKI.
Sure. Okay. So, Dr. Kumar, do you feel that any other new biomarkers?
There are new biomarkers are there.
Most common bedside tool which we can use is the clinical scoring system. So STARCH study, this is a multi-center study from India, and they evaluated prospectively around 744 neonates were validated this score. This score is basically based upon the clinical and lab criteria. Clinical criteria
Nine clinical variables.
9 clinical variables and 1 laboratory creatinine.
What is this renal angina index?
Yeah. So basically these clinical scoring system will help us in, anticipating that these babies are vulnerable and they can predict the development of AKI in the coming days. Similarly, renal angina index, this is meant for basically for children, but nowadays people are using this in newborn also. And next, in one of our study, we found that renal angina index cutoff score above 80, then there is a prediction of around 90% of development of AKI in those babies. These are various landmark studies on the neonatal AKI, just for reference.
Okay, so we know that now still the confusion exists. Okay, but only thing is that people got sensitized now that yes, AKI is one of the problem that is there. So by changing any of the things in the beginning, can we improve the things?
Obviously, yes. When a child comes to us, get admitted with AKI, we'll get, what happens is, we'll first get, we'll get anxiety. Oh, something is happening to the baby. One, we'll start monitoring IV fluid. We'll stop that nephrotoxic drugs. And then we think of other things. What is causing AKI? So yes, it will develop 100%. It will improve the.
So at least it will try to promote preventive something like that. Regarding creatinine and other things you want to say?
Basically, it's never an early diagnosis. AKI diagnosis is almost always late. It will happen early if we have a thoughtful mind that yes, this child is vulnerable and we have to anticipate and monitor the child for development of AKI.
Just continuation on that. Are we diagnosing it too early?
Obviously, we are diagnosing it late because we completely depend on serum creatinine.
Okay. So you still feel that we need to look at more of the clinical parameters, and many of the scores are also saying that 9 clinical parameter and 1 lab score, which is there. Okay. What do you feel, madam? You also feel
this? We have already addressed.
Sure. Should AK be part of routine neonatal screening also, like sepsis risk assessment. And
Obviously, yes.
Baby is getting admitted.
Nowadays, we are just thinking of serum creatinine. If it is associated with other factors, means other clinical markers, we can diagnose it early.
So how does it help? Basically, if you look at the RST on day 1 of admission, how does it help if it is a high risk baby?
No, whenever whatever the serum creatinine will take time to rise. In case other markers are there which madam told, if they are also done, then we can diagnose early, probably prevent renal damage further.
That's amazing. You want to?
Since there are a lack of universal guidelines, as you told, that for universal screening, but as of now, there is a need for risk stratification of high-risk babies and follow these babies for development of AKI during their management.
Yeah. So big question will be that so many markers are coming on the same, and it will be difficult for us to continue the same.
Yeah.
So do you still feel that it has a future?
Serum creatinine associated with biomarkers. Probably creatinine will not grow, but if it is associated with biomarkers, yes.
So what do you feel, man?
Yes, there is a definite need for novel markers which can detect AKI early before the serum creatinine rises. So definitely there is a need, and creatinine has to be supplemented by.
So other issue with the creatinine is that because as you are saying rise, which is delayed. What do you feel that what are the other factors that could influence the creatinine rise? And
Fluid overload.
Fluid overload
Yes.
is one thing. Then muscle mass,
Yes.
SGA status, and then asphyxia status. All those things also will try to help. So again, last.
Online, what is the real problem? Real problem is diagnosing AKI late because of serum creatinine, which has already caused the damage to the kidneys.
Okay, what do you feel, man?
So creatinine number should be interpreted with the background of risk factors, clinical conditions, and serial trends.
Okay, so final question.
Only creatinine, no. If it should be associated with other biomarkers.
Your tongue.
Yes, basically creatinine is still trustworthy, but yes, a support is required. Either the clinical parameters, risk factors, or the novel biomarkers, because it has its own limitations and challenges, so not a dependable parameter.
Okay, so the thing now with this presentation is that we just got sensitized about AKI. Definitely, simple clinical concern is not going to help. But again, single value of creatinine may not be helping us at any point because none of them are complete 100%, as you see on the area under curve and other things. So definitely, it is better that we need to look at in the long-term perspective to avoid the renal injury and try to decrease the nephrotoxic cocktails which are used in our unit. And then obviously we need to follow up these children for the CKD, then only we'll know that whether these children are at higher risk or anything. So we need to see how these children will fare well later, and then maybe the novel biomarkers also will try to help. So another question, I think in here it is not reflected, but I just want, why are we not using the urea or BUN in the markers?
Blood urea is influenced by many factors. So that is the main reason we cannot correlate whether the child is going for AKI or not. So it is influenced by many factors.
Yeah. Urea basically hydration status and rapid flow, increase in blood flow and other parameters. So blood urea is entire through the entire renal tubule. It has so many parts from where it is absorbed. So it is not at all a.
It is not specific.
Mark.
Should we have some 10 seconds time, or we can take 1 or 2 questions on the AKI if any of the people have? Here, please. Which one?
Cystatin C is just like a blood sample, serum cystatin. There is a urinary cystatin as well, and it's a ELISA based test, so it can be done as quickly as urea. And the cost is somewhere around in government sector where kit is multiple times used, somewhere around 500, 400, 500, not very expensive. And regarding NGL is little expensive, exact figure I really do not, but there is a easy way of this comes in a strip form. So it's a bedside clinical, point of care test. So that's the advantage of this thing.
Any other people?
Thank you. Thank you, sir.
Thank you. Thank you very much.
Thank you, sir. Now I would like to request Tejas sir to give mementos to the
Thank you.
speakers.
ఇంకోటి తీసుకోరా.
Next, we have panel discussion. Stem cells at birth, promise, peril, and practicality. For this, we have panelists: Dr. Boris Willy Werner Kramer, Dr. V. Raghavan, Dr. T. Abhiramlata, Dr. Veena Akkineni. To moderate this session, we have Dr. Sahitya.
I remember.
ఆటో కట్
A warm welcome and a good afternoon. At the outset, I would like to thank Neocon for providing me this opportunity. Today, we are going to have an engaging discussion on cord blood banking and stem cells at birth. What is the latest clinical evidence, what it promises to be, and what is currently happening in the world. So, I'm Dr. Sahitya, and this is my CV. Let's move on to the presentation. Today we have among us a very esteemed faculty, Dr. Boris, Dr. V. Raghavan, Dr. Abhiramlata, and Dr. Veena. So without further this thing, we'll dwell into the presentation. A brief overview. So the whole point about cord blood banking started when a successful umbilical cord blood transplant happened. That's the first happened in 1988 in Paris. After that, it promised to be a cure for a lot of incurable diseases where you did not have mad sibling donors or mud donors available. And New York, with the help of NIH, established the first public cord blood bank in 1992. These two are documentaries on stem cells. One is by Stephen Hawking, and other is just how do we collect and how do we go about it, also known as the God cells. So, what is the promise of stem cells? What is the current scientific and clinical evidence? So the first question to ma'am, what are the main stem cell sources prenatally and which is approved for clinical use today?
Good afternoon, everyone. So from the perinatal tissues, we have many sources of stem cells. The most commonly used one is the umbilical cord itself. Apart from this, we have Watten's germline, we have stem cells from the perivascular tissues, and we can take stem cells from the placenta and even the amniotic fluid. But of these all sources, the only approved source of stem cells is the umbilical cord blood. So from the umbilical, what is done is after the baby is born and after delayed cord clamping, we'll be emphasizing that in our panel. So the remaining blood from the placental end is collected, and from this the RBCs are removed and only the nucleated cells are stored in liquid nitrogen. So this is the stem cells that we are storing for the future, and this is equal to that of bone marrow from a healthy donor. So any indication for which we can do bone marrow transplantation or hematopoietic stem cell transplantation, for all those indications we can use this as an alternative source. So there are advantages and disadvantages that Dr. Veena will discuss in the next question. The major indications for which it is approved for use right now are inherited hematological disorders like thalassemia, pure red cell aplasia, etc., and hematological malignancies like leukemia, and primary immunodeficiency disorders like SCID, and even inherited metabolic disorders like mucopolysaccharidosis and osteopetrosis. So basically, whichever disease which can be cured by hematopoietic stem cell transplantation, for all those diseases, we can use this as an alternative source. So apart from this, the next most explored one is the Wharton's jelly mesenchymal stem cells. We are basically exploring this as an alternative option because this is much more multipotent when compared to that of the hematopoietic cells. These cells can differentiate into cartilage, bone tissues, fat, etc. So they are like much more multipotent, and we can even stimulate them to differentiate into neuronal cell lines. So that is the advantage of the mesenchymal Wharton's jelly stem cells over the hematopoietic cells, and these cells are being explored for neonatal uses like BPD, HAE, etc. Apart from these two, the other sources like placenta, amniotic membrane, and the amniotic fluid, these are very less explored as of now.
Yeah, I think ma'am, you summed up quarter of my presentation. So yeah, as ma'am has rightly pointed out, we have cord stem cells. The differentiation is basically cord blood has more of hematopoietic stem cell transplants and tissue has more of mesenchymal stem cells, which are used in tissue repair. So moving on, this is to Dr. Veena. She's a pediatric hemato-oncologist and a transplant physician. So in 2022, what are the accepted therapeutic options for cord blood transplants, and how does it compare to your routine peripheral cells or the bone marrow transplants?
So basically for the audience here, the stem cell, whether it is a hype or a hope, I think you'll be knowing by the end of this presentation. So whether actually this is required or not, what is accepted therapeutic options. So what is cord blood stem cells? Basically, umbilical cord has some hematopoietic stem cells. So what are those stem cells which can form any type of cell, which can form the lineage committed cell. So the purpose of this collection of umbilical cord stem cells is that it can treat any condition where the blood is failing or there is an immune system problem. So whether it is a malignant condition or non-malignant blood condition or an immunodeficiency or some genetic metabolic disorders in which hematopoietic stem cells can make up that regenerate and repair that body. So for that, it is an accepted therapeutic option. For example, malignant conditions like leukemias, lymphomas, thalassemias, immunodeficiencies. This is what stem cells are supposed to be. We are expecting from stem cells that they will cure all this. But whether umbilical cord stem cells, whether we can collect and transplant them, whether they will cure or not, we will get to know all this. But whether we have to store it for the later purpose, and then because when we have to transplant, when any condition you are diagnosing it, for example, HLH or any metabolic disorder, when you say the treatment is bone marrow transplant, what do you mean? Is it bone marrow or is it a peripheral blood stem cell or an umbilical cord? So that is the thing which we have to know. So there are three types where you can give the stem cells. One is directly from the bone marrow or from the peripheral blood or from the umbilical cord. So as of now, through so many years, if you see the data, we are moving away from the umbilical cord transplants because the best success will be with the matched sibling donor, that is directly from the bone marrow or peripheral blood. If there is a sibling match, we would ideally do a transplant with that. Otherwise, we would go for an unrelated donor or a haplo donor. Haplo meaning half match. Either it could be one of the parent. So if these both are not done, then we would ideally go to the umbilical cord transplant. So if we see the graph over the subsequent years, the umbilical cord transplant, that is the yellow color one, the graph is coming down. So the usage is coming down. So because the umbilical cord, we collect the cell about 50 to 60 ml. So in that amount of blood, the cell dose will be low. So when the cell dose is low, the immunological engraftment and all will be delayed. There is risk of infection. So there is some disadvantage with that. We'll see if further with the presentation how it will go.
Yeah, as correctly pointed out, so the approved indications for cord blood, this is very important. So whenever a live cell or other private cord bloods come, they promise a lot of hype. But what's the actual current indications are just for these hematological cancers, thalassemias, immune deficiencies, and metabolic disorders. As of now, these are approved and standard of care. But however, from a transplant physician, we are moving further and further away from cord blood transplants. Like rightly pointed out, we have a delayed engraftment in India, especially when we have endemic multi-drug resistant infections. Waiting for the long reconstitution has increased our mortality. So the advent of haploidentical, this is the international data. Indian data, ISBMT has just used 60 cord transplants over a period of 10 years. Only just 60. Look at the number and how many cords are being preserved. So there's a rapid underutilization of cords being stored. So moving on, this is to Dr. Boris. He's a Chief Medical Officer at Neuroplast BV. So what are the investigational therapies for cord stem cells?
Thank you very much. Well, from a neonatal point of view, there is nothing to add. However, we would love to use mesenchymal stem cells as a regenerative power. So if you please go to the next slide. We could think about neurodegenerative diseases. We could think about a reset of autoimmune diseases. We could think about BPD, our most common adverse outcome after preterm birth, or even ocular regeneration. However, the evidence can be summarized very quickly. There is none. And therefore, the problem was also tackled from a different side. You have probably heard of exosomes or extracellular vesicles. These are secretions with a double layer of lipids, as shown here on where I'm sitting. Okay, sorry. Oops. Okay, then I'm falling down. So you see here with a double layer, and there you have mRNA, protein, and lipids in it. So these are vesicles which have a huge influence when they are absorbed by neighboring cells. And that is one way how we think that mesenchymal stem cells do their magic. So this has been tried to avoid the transplantation issue of giving stem cells and then just give the exosomes. You see, it did not work. Next slide, please. So here is a phase 1 trial, which is now the third one with the same stem cells. One was published in South Korea early on, then one in the US, and this one now in Europe. Always trying the same cell preparation, which was generated in 21% oxygen. Well, it works with respect to safety. The phase 2 clinical trial in South Korea showed no benefit. So that is always the next step. After showing safety, you show efficacy in a phase 2 trial, and that failed in South Korea. We will see whether this will be better in the US or in Europe. Next one, please. So, hypoxic ischemic encephalopathy, the ultimate neurodegenerative disease in neonatology. This study was published 23, and we are still waiting for the long-term follow-up, and we are waiting for the phase 2 trial. This is a phase 1 trial, so the only question that can be answered is it safe? Next slide. And this is a still ongoing trial.
Yeah. So, can I just add? Sorry. So, the major advantage of using this exosomes is we are worried of using stem cells in neonates because of the risk of future teratomas. So, the longer the lifespan of the individual beyond the time of stem cell transplantation, the higher is the risk of all these tumors. So that is the main reason why we started trying these exosomes. And these exosomes contain all the mediators, either hormonal or enzymatic mediators, that is essential for stimulating the regeneration and repair. So that is why we, there are a lot of upcoming studies about these exosomes, but all of those are, as of now, animal studies. We don't have any evidence from human trials. And among all the neonatal morbidities, the morbidity that has maximum evidence as of now is HAE. So there is a recent systematic review from our own country done from AIMS Rishikesh, and they have included 4 studies, and they have shown that if we use stem cells along with cooling, then it improves the neurodevelopmental outcomes up to 1 year. For all the other studies, it is still in the experimental stage.
Well, I dare to partially disagree. First point, if you give stem cells, they are cells that can adjust and take their own decisions how they will respond to the environment that they encounter. The exosomes you have prepared are fixed. So you give one preparation in its biological potency, and then it is distributed with the concentration that you give, and then you see and wait. That is very different from stem cells that have the opportunity to proliferate and to differentiate. Those 2 features make them stem cells. So they can adjust to the situation that they encounter. So that is one aspect. The other aspect, from a regulatory standpoint, exosomes are a nightmare, because you cannot really give a reliable description of the composition, and if you make it very standardized, the biological potency goes down. So from an industry point of view, I don't think that exosomes are the way to go. And the other aspect is with the route of administration. Do you give the stem cells intravenously in HIE, or do you give it intranasally? That makes a big difference. So even the access route is not really clear how we do it. If we give it by nose, we can imagine that it goes along the nerves olfactorius into the brains. However, if we give it intravenously, the blood-brain barrier is tight. So where is then the magic coming from?
Yeah, so we are doing an animal study right now at our institute. So what we are doing is, we have developed an animal model for periventricular leukomalacia using hypoxia, ischemia, and inflammation. And we are trying stem cells and erythropoietin. And what we found is the stem cells, we are giving intravenous only. Still the intravenously given stem cells do make a difference in the histopathology of the rat brain.
We did the experiment with piglets where the hypoxic ischemic therapy with respect to hypothermia was developed. We don't see any effect intravenously, and we see only an effect intranasally.
And just to highlight this, it's not umbilical cord stem cells. These all trials use mesenchymal stem cells. So the cord blood banking that's happening right now utilizes only hematopoietic stem cells. And ma'am, I think in your animal, you're using just hematopoietic stem cells and not mesenchymal stem cells.
We are using the mesenchymal stem cells from Barton's jelly.
Okay. And have you regulated it on the dosage, and how are you preparing it?
So we are giving 2 into 10 power 6 cells per dose, and we are giving 5 doses.
Okay. Before, during, or after cooling?
No, we are not cooling. So these are rats.
Yeah. So yeah, it's still phase 1.
Yeah. So, ladies and gentlemen, there you see the problems. The regulatory authorities will say cooling is the gold therapy. You have to show that you are better than the gold standard. So this is then one of the challenges. With your model, you will have a problem to integrate this gold standard in hypothermia. But without that, the regulatory authorities will never approve a clinical trial.
No, so our model is PVL, not HAE.
Yeah, just moving on. I think we've delved too much into this. So next question is to Dr. V. Raghavan sir. What is the realistic probability that the child will use his or her own privately banked cord blood over a lifetime? And what do you explore the reasons why it's going to be what the percentage is?
So lots of discussion going on here. I'll just try to keep it crisp. So the realistical probability, it's like a Bayesian question.
that a child will use his own, her own privately banked cord blood over a lifetime is close to zero. Close to zero. Okay, so why are we having this discussion in the first place? Because these stem cells, if we have a public sector banking of stem cells, then altruistically you can donate these stem cells. Whereas in the private sector, we might develop onto that topic later on. The families pay for it and they use it for their own purpose, thinking that it might be of use for their child. Practice is not going to be of any use for that particular kid. Maybe it might be of use for the sibling, provided the sibling has some genetic disorder or thalassemia or aplastic anemia or things like that, where hematopoietic stem cells have been proven to be collected from the cord blood, have been proven to be almost equivalent to that collected from the peripheral blood or bone marrow. And they do have their own issues, as Dr. Veena had told. But yes, but for this particular question, the chance of that particular baby requiring the stem cells collected from the cord, the probability of using it for that baby is zero. I can say 1 in 4 lakhs, 1 in 6 lakhs, but it's practically zero.
Yeah, as rightly pointed out, because why? Most of the conditions which is approved are genetic disorders, or even for that matter, acute leukemias. So there is a theory that although there is no upfront genetic predisposition, there's a probability of pre-leukemic clones being stored in the cord blood. And if you use the same cells for transplant, they will develop into leukemia. So as of now, the indications are very rare, only in acquired conditions like aplastic anemia, like rightly pointed out. The also issue is the dose. Because the dose is so less, for an adult, you might have to do a double cord transplants. And the next factor is the period. So most of the cord blood stored are only till 25 years of age. The probability of you developing a malignancy in first 25 years is again very less. Most realistic use, like sir has pointed out, it's to a sibling who has a genetic disorder and you want to store the cord cells. I think Dr. Veena would want to address on this, no?
So basically, to simplify this, for example, a baby is born and they have been asked for collection of umbilical cord stem cells. Okay, they have preserved the umbilical cord stem cells. Now, after 4 years, this baby is being diagnosed with some HLH or some genetic disorder like HLH or acute leukemia. Now, he has to undergo transplant. So whether you want to use his umbilical cord stem cells or not, because they have preserved. So this is a genetic disorder. HLH is a genetic disorder, already has a genetic mutation. Now leukemia also is though it is not a genetic disorder, it might have some clonal mutations. So if you transplant with the same cord stem cells, that there is likelihood that stem cells will also have the same genetic mutation. So you are infusing them again with the same genetic mutation. So you will not use the stem cells for the same child. So it is only that the stem cells which you collect at birth will be only useful to the others. It is just like a blood donation. You are donating and giving to somebody. So you will donate your cord stem cells to public banks and then it will be useful to somebody else. It will not be useful to your own self. Suppose if the sibling gets some genetic disorder or leukemia, can you use that cord blood stem cells of that sibling? So anywhere if the sibling gets, the other sibling is alive and awake now, so we can rightly use his live stem cells. We don't need to go back to his cord stem cells and use it. So this is the way I could simplify it.
Yeah. Rightly pointed out. We'll move on to the next aspect. So this is all the promise that the stem cells has shown us, but there's a clinical and scientific evidence. So next question is regarding the peril, the ethics, regulations and commercialization. So it's just divided into 3 parts. So let's start with Dr. Abhirmalata ma'am. What are your concerns regarding cord blood banking exclusive to marketing concerns?
Yeah, for public banking, as Dr. Veena said, there is nothing related to marketing. So most of it is, it is it should be addressed as a noble cause, like where it is something like your banking or something where you are going to help somebody or save some life. So there is no question of marketing here. But the only point I would like to point out here is like we should not deprive the baby of delayed cord clamping in the attempt to collect the blood, which may be used for some other individual. So that is the only thing we have to ensure. For private banking, as already discussed, like the chance of it being used for the same person or even for the family member is very, very less. So that should be explained to the parents in detail. And again, we should not deprive the baby of delayed cord clamping and for an imaginary use in future of these cord stem cells.
Dr. Veena, what are your ethical concerns currently in India regarding private cord blood stem banking?
So regarding private cord banking, I think the moment somebody is pregnant and they are yet to deliver, so all these they come, the company people, they come and they explain you about the stem cell. That is the most we are emotionally fragile that time. They are promising that this is the biological insurance for your child, once in a lifetime opportunity for your child. This can treat 80 conditions. They will only give you partial information. You're not having a complete information about this, whether actually how many transplants have been done till now, how many of them are actually utilizing the stored cord bloods, what happened to the if you don't pay later on, what will happen to the the transplants, which umbilical cord stems which have already been stored. So there is no proper information to the parents because they go at the time of some vulnerable period where they have to take information thinking that they will deprive their child something important in their life. So these are the things which has to be addressed at the ICMR level. There have to be some strict guidelines upon this so that they will not give some false hope and emotionally they won't become liable that time.
So, to Dr. V. Raghavan, sir, what is the collection and storage concerns you have when it comes to cord blood banking?
Yeah. So now we don't call it delayed cord clamping. It's presently we call it deferred cord clamping. So if you use the word delay, parents might take it wrongly that you have delayed some intervention. So DCC stands for deferred cord clamping, and we in ILCOR are in the process of bringing out standardized definitions so that the future studies that are going to come, the authors can at least refer to these terminologies and then plan their studies accordingly. So coming to collection, okay, there are one large single center study which has shown that if you defer the cord clamping for say 30 to 60 seconds, previously they used to say at least 30 seconds you defer the cord from being clamped. The obstetricians were okay with it because it was not, they felt like it was not interfering with their active management of third stage of labor. But now the guidelines have gone beyond 30 seconds. Okay. So once you defer the cord clamping for at least 60 seconds, first of all, the amount of blood that you can collect from that placenta is going to be very low. And the yield of the cells, the hematopoietic stem cells that you're going to extract from that particular unit is going to be much lower. And I'm not restricting to 60 seconds. They say at least 60 seconds. And if it is a preterm baby, suppose it's a preterm baby, the ILCOR cost chart based on the individual patient data network meta-analysis done by Seidler, it is clearly shown that if you delay for 60 seconds, it decreases the probability of mortality. The certainty of evidence was high. Okay, so the evidence of effect, the certainty of evidence was high. Now, if you delay for 120 seconds, it decreases the mortality further. So there is a dose response gradient. Now, many of you might argue, how can I delay the cord for the clamping of the cord for 120 seconds in a baby who is born 28 weeks of gestation? Now you have intact cord resuscitation, intact cord stabilization, physiologically based cord clamping. So this whole concept of collecting stem cells or even collecting the cord blood itself, I feel in the coming future might not exist. That wonderful graph that was put by the time series chart or whatever, it was put by the moderator. Yeah, you can see the trend, right? From 2013 till I guess 2023, It's going down. And these large studies have been published very recently, this year. So my take on this is collection is going to be a big problem. And it is going to be unethical. You cannot jump deferred cord clamping and go on to collect the stem cells, right? That is one. Next, storage. There is always a risk of infection when compared to stem cells that you collect from the peripheral blood or the bone marrow. So regarding deferred cord clamping, I just want to stress upon that point, and we will come to that again while we address the issue of counseling the obstetricians and the parents and the neonatal team.
So rightly pointed out, the DCC practices are they being actually done while doing cord clamping is highly up to debate, and ICMR has given guidelines that before you promote for cord blood banking, DCC has to be followed. Again, I would differ with Sir on this, although this study shows that beyond 60 seconds it has impacted. This is a recent review by the Spanish group published in Blood Transfusion, where they did not find any difference in the TNC numbers, that the quality of stem cells collected post 30 to 60 seconds. Again, only 2 articles. We do not know, and people who are practicing abroad, I'm pretty sure they would be practicing DCC, and what is their stem cell values, we do not know as of now. But yeah, definitely DCC has to be practiced, followed by cord blood banking. So moving on, ICMR has come up with these guidelines in 2023. A regulatory framework is by CDSCO, mandatory testing for all infections, and regularly they have to check the viability and send cultures and look at viral and bacterial contamination. So moving on to the most debated topic, public cord blood banking versus private cord blood banking in India. Ma'am, what are your thoughts?
So we do not have any public cord blood bank at present. So the only bank that was running was Jeevan, and it was closed because from 2012 to 2020, there could be only 60 transplants from the umbilical cord stem cells. So that was considered non-viable, and that is also closed. So we do not have any public bank that is running at present. And regarding the private banks, we have 22 approved, ICMR approved cord blood banks in India at present. As we have already discussed all the aspects of private banking, it is not going to be of much use because the probability of it being used for self or for the family is very less. So the government of India should take initiatives to develop a proper public bank for cord blood banking. That should be the way forward.
But with the recent advantage of haploidentical and decreasing cord blood, would you still push for a public cord blood bank in this scenario?
So basically, yeah, that is very rightly pointed out. So now we have been telling that private banking is not useful, but public banking is useful. But if we see the data, the usage of umbilical cord transplants is going down because with the advent of haplos coming up, that is, there is immediately mother or father, that is half match available, we are using their stem cells. Then why do we even need to collect this cord bloods and maintain it in public banks? So the question is, India has a lot of HLA diversity. So what is this HLA? That is the antigen expressions which will be there, which will be required for, we need a proper matching of this to get the successful outcome of the transplant. So India has so much diversity in their HLA compatibility that the probability of finding the match will be very difficult. So if you see, not all the children will get a perfectly fit haplodonor. Yes, with the haplodonors, the chances of umbilical cord transplant is coming down, but however, not all kids with some diagnosis may not have a medically fit haplodonor. So in that cases, umbilical cord transplants would be useful, especially that the chances of getting a perfectly match unrelated donor would be very difficult, especially because the Indian data is underrepresented based on the ethnicity of the Indian ethnic origin HLA. It's underrepresented in international global registries also. If we actually maintain our own banks, if the haplo is not available, maybe we can immediately get the HLA matching from the umbilical cord transplants, umbilical cord banking with some mismatch which is acceptable. So it is not that we should have so many public cord banks which are poorly utilized. Maybe few which are properly organized with a proper consideration of regulations. We can maintain some public cord banks because which would always be useful considering the HLA diversity of Indian or ethnicity.
Sure. Dr. Boris, I wanted to get your insight on this and how is it in abroad?
The problem that cord blood is limited with respect to the numbers, and therefore the patient group that can be offered a transplantation is very confined, is true throughout the world. So depending on how young your population is, you may argue, yes, even if this restricted population is small, in relative terms, in absolute terms, it is big because of the composition of the Indian population. In Germany, this public banking system has gone down. In the Netherlands, it was never introduced. In Poland, it is not introduced. And you showed the American data that despite the better engraftment in the long run and the less complications, the cord blood transplantation is not the way forward to go. I will take now the point of a group of colleagues that we usually don't take. I take the obstetrician's point of view. So the obstetrician is asked to conduct a more or less sterile procedure. Is he or she being contracted and paid by the private bank? So this is the same throughout the world, that the people who are then being charged with this very sensitive procedure are neither contracted nor rewarded for that, which is also, in my opinion, ethically highly questionable. And another aspect, so imagine we have had the situations that the parents had a child that needed a bone marrow transplantation, and then they made another child in order to get this. So if this collection is going wrong and is not sterile, all hell will break loose. And that is one of the reasons why commercial companies have moved very reluctantly into the idea of collecting their own cord blood or their own Wharton jelly for the baby. Imagine the cord is nicely cut, given to the nurse, and then this thing falls to the ground because it's 3 o'clock in the morning and everyone is tired. Then this will be a nightmare from regulatory aspects as well.
Yeah, that's a great point to have. So to finally talk about the practicality in the Indian health system and with the family economics, so how do you counsel parents in your routine clinical practice, and what are the points you emphasize on?
So this applies not only to low and middle income countries. There are recommendations from ILCOR, and the various resuscitation councils have also taken these questions into account. Umbilical cord management has to be discussed prior to the delivery. The discussion should happen between the treating obstetrician, the neonatologist or the pediatrician or the midwife who is attending, and the family. Okay. So I would just give a concise of whatever we discussed till now. And I would say that deferred cord clamping is going to benefit your baby, and you could see it right in front of your eyes. If it is a term baby, the iron shows are going to be better, which might translate into better intelligence. And once you do that, if they can attempt to collect the cord blood, and as the Boris told, if that fails, it's fine. No one is going to die. It's not going to be the end of the world. But deferred cord clamping is the standard of care. And coming to the money that they would be spending, upfront they will have to pay something like 50,000 to 2 lakh is what you told. And with an annual increment of some 5,000 to 10,000 to keep that stem cells being stored. So I would always, with this I will just stop my talk or my view. Just concentrate on deferred cord clamping, and Rachel thinks it's up to you. I'm not a great fan of umbilical cord collecting the umbilical cord for extracting the cells, stem cells, for the exact reason that Boris told, which I have encountered personally while attending so many deliveries in India, in tier 2, tier 3 cities, where obstetricians have been heavily influenced by the private companies.
Thank you, sir. So where do we go from here? Advances may expand indications, but caution remains essential. There's a lot of studies going on in neuroregeneration and tissue repair. So we still need data before just overpromising our patients that your cord cells could save your life or it's once in a lifetime opportunity. Public cord blood banking, we need to advocate more for it in the view that maybe once the advances are available to us, we might be able to use it and it's not for your own child. So to conclude, you have to have a balance between promise and responsibility. Indian pediatricians are the key. You need to counsel your patients well, and these are the key takeaway for practice. Thank you. Any questions? I think we had a wonderful discussion from both the international faculty and the Indian faculty. Yeah, thank you for providing me this opportunity. We are free to take any questions. If not, Dr. Boris is actually a Chief Medical Officer at Neoplast CV. I think if you have time, I think we have 3 minutes time, he would want to share his data, research data.
Well, thank you very much for the opportunity. When we prepared this, I was asked, so how do you now look back when your first phase 2 clinical trial is under a review for publication? The answer is very honest. If I had known this 15 years ago, how complex the biology is, I would have never embarked on it. And that's one of the aspects. So when we started, we analyzed all the data and came to the conclusion the moment you culture stem cells with 21% oxygen, all their potency is gone. And that is, in the meantime, confirmed in trials. So when we looked at possible applications for neurodegenerative diseases, you see the widespread of diseases and with some prominent people affecting that. Next slide, please. So what our idea was is we take the patient's own stem cells and give them literally a lift across an anatomical border. So we collected bone marrow cells, removed everything except for the stem cells, so a negative selection. Those stem cells have never seen oxygen, have never adhered to plastic, have never been tagged by an antibody, and have never been frozen. And within 48 hours, they are given by a lumbar puncture to the patient. And that is then the hope that we have to modulate the function of the remaining functions of the patient. And this is the principle of negative selection. So you remove everything except for the stem cells, and you see the antibodies are not going for the stem cells, but for everything else, be it lymphocytes, leukocytes, and whatsoever. And go back, please. And you see this is a intellectually property protected manner of generating those cells. Next, please. So this asks for sophisticated logistics. You collect the bone marrow, you process it, and within 24 hours it has to be processed and then being given back to the patient. So I think this is the last slide. We have now conducted a phase 2 clinical trial with a placebo arm. Can you imagine the ethical concerns that are there when you tell a patient with spinal cord injury, well, you may be placebo? That was deemed unethical, so we have a delayed start element in that. So at the initial moment, it is randomized, and 6 months later, those who got placebo got then stem cells as well, so that we have a placebo control, a placebo comparison moment, and then delayed and early treatment phase. That was ethically very challenging to get this done. I don't have to talk about COVID, and now we have a benefit in a relevant outcome. What is a relevant outcome for a spinal cord injury person? The control of his or her bladder and his or her gut. Nothing else matters. Thank you very much.
Thank you, ma'am. It's a wonderful session. Now I request Dr. Sahitya madam to hand over mementos to the panelists. You can go on to the stage. Very much. Now I request Dr. Boris sir to hand over memento to Dr. Sahitya ma'am for moderating such a wonderful session. Thank you, ma'am. Thank you, sir. Our next panel discussion will be on neo challenges in neonatal world, exploring stress and bursters. The moderator will be Dr. Naveen Jain, sir, and the panelists are Dr. Amanpreet Seth, Dr. Vinay, Dr. Sarjit Kaur madam, and Dr. Somashekar, sir. We welcome Dr. Naveen Jain, sir, to take over the desk.
Thank you so much, Shekhar. मोहित, any other stresses other than Indigo flight जाएगी कि नहीं जाएगी आपसे? हैं? कैंसिल कैसे? ठीक है. Thank you, and this is our stress buster team or stress management team. We are going to throw them difficult situations that we face every day, and they will try to help you on what you can do about it. And I thank Somashekar for joining. His name is not here because he agreed to challenge stresses right away without knowing what the questions are going to be. So these are common situations. We are not going to have any exam-oriented presentation here. It won't be of any help to you. But after you pass your examinations, this is what will be required. We recently faced a twin pregnancy where the family belongs to a religious group called Jehovah's Witness. And with full respect to the religious group, they believe strongly that they will not take blood products come what may. The mother is Rh negative and babies are clinically isoimmunized in pregnancy, 32 weeks pregnancy. They have clearly said that they will not take any blood product after babies are born. Even IVIG, they were dilly-dally that they will take or not take. We had at least 3-4 meetings with the court, with all sorts of meetings. Their own experts fly in from nowhere and they come and talk to you saying that you can give D-penicillamine, you can give this. So this is one situation where parents are not agreeing with your plan and you have to continue care. Others are very common. Preterm baby hai, parents want to go home, 33 weeks hua hai, nahi abhi nikal do baby ko ghar bhej do. Or your blood sugars are dwindling and the parents don't want to stay. Bilirubin is 20 on day 3, they want to go home. So what do we do in this kind of situation? Amanpreet sir.
Sir, thanks. At the outset, I will thank the organizers for inviting me. So it's a very relevant question, sir. We face many of these challenges many of these challenges in our day-to-day practice. So just as sir said, parents are not agreeing with your management plan. So what we can do is that first of all we have to understand why they are thinking so. So better that you first have them sit in a private room or in your office so that they are also calm down, and then you can tell us that these are the management you are wanting to give to the patient, and the risks and benefits that this management, how the baby will be helped with that, and also tell them the risks also in their own language, that if you are not giving this treatment or giving us the chance of to give that treatment, the patient will suffer badly. So these are the problems which we face, and how you can tackle these things. So better to be in a safe and calm environment. Then if still they are not agreeing, so many times situation comes that they are not agreeing with your plan, then take this informed refusal in your documentation. So because this is medico legally also important, and if still they are not agreeing to for the management, and they are putting the baby's life at risk, then you can always inform your hospital administration, your seniors and your colleagues, and also take the help of your legal team, and also involve the child protection services. So in every district there is a district sir, so that can be called and they can be asked to help us. And then if some religious group is coming, then you can call their priest to convince them that you stay. And similarly for preterm baby wanting early discharge, so because many times we face the similar situation, in that case we usually back refer them to their native place in a normal SNCU if they are on OG feeds. But if still they are on a ventilator, then it is very difficult. Then you have to involve your legal team or your hospital administration to have them stay.
रियल लाइफ में भी तुसी इतने ठंडे रहते हो कि गुस्सा आ जाता है?
नहीं, गुस्सा बहुत आता है. But lately I have calmed down. Initially I was very aggressive. When I passed TM, I used to fight a lot, but now after 8 years of my practice, I think it is better to stay calm. So this is how experience teaches you, I think.
In such instances, do you send them against medical advice or on request?
Either way, there are.
What is the difference between on request or against medical advice?
Ravi sir, either way, if the baby has risk of death or disability, then you are in trouble, whether you write anything on the summary or not. Because if death or disability has happened, we need to understand that the liability on the pediatrician is criminal in terms of even stripping of your degree and even going to jail, and the person who judges your case has no medical knowledge. And therefore, instead of writing, you write discharge at medical advice or this one. It's important in verbal actual language what communication you have done. Document. Signatures have no value. Parents can say कि I signed under stress. डॉक्टर साहब ने कहा साइन कर दो, तो मैं तो पेशेंट था, साइन कर दिया. What is more important, your statement is respected. If you wrote in fail, Pankaj wants to say something. Can be done. Audio-visual recording, documentation, but your explanation to family that A, this is the standard of care. B, if you cannot stay with me for financial reasons, social reasons, why don't you take another standard of care elsewhere? Very important point, which is refer back. Don't try to say ki, well, the worst thing you can do is to say, I will not give discharge summary. You are digging your own grave, because then you are not telling the patient what to do after this. So this is something we were taught somewhere, that don't give, I won't give discharge summary अगर तुम जा रहे हो बिना मर्जी के. वो सबसे dangerous है. उस discharge summary में you write clearly that I have spoken to so and so, Abhishek is my student, I have spoken to Abhishek that you should not go please, this is a phototherapy requirement. Even if you're going back from here, go elsewhere. We'll continue, sir. So this can get into...
Dr. Naveen, yes, Somsekhar. So one of this practicing in a rural area. So if you're practicing for a long period of time, you should have at least one of the people in each village that you know who's senior enough and get them to convince. So if you know sarpanches, you can talk to a sarpanch and say, talk.
Yes.
They will usually listen to the biggest boss in their village.
Right. I'm taking, please. Yeah. Take a mic, please. Give me mic, please. Yeah.
Pushan Udayati, neonatal consultant, Ankura, Hyderabad. That's a very good point, sir, that discharge at request or discharge against medical advice, but the safety of the child still a compromise.
First, yes.
Now, what my comment or maybe question is, in that case, you are not stripped of your responsibility, though they are leaving, because the child is at stake or risk is at a very high. Can we involve legal authorities, the police, because parent also has legal responsibility?
I cut short it because there are more questions, but I'll answer clearly. When we had this Jehovah Witness case, we informed, in fact, the court. We spoke to speakers like people like Dr. Bhutani also. That baby was so difficult for us. And he said, even in the US, when it comes to religion, people try not to go to court because you will get stuck in the court forever and you could steer. So it's best to solve by getting their own religious leaders to get involved and try and find solutions.
But here the police, legal, they want to leave from the hospital. Can you involve police? Because it is a responsibility.
Win the case, but lose your practice for the rest of the life. You won't be able to practice in the same region. I'm telling you practically. So better is to not to go into conflict mode, is to try and help the patient. We'll come back, sir. I think we'll keep 5 minutes for the end for open discussion. So you can get even more difficult for something which you can't think is dangerous. Vitamin K or hepatitis B given at birth, 1 month later baby comes with a big injection abscess. You admitted, IND done, you hoped everything will get okay, but the abscess wouldn't stop draining. You're thinking is osteomyelitis, MRI kar liya, ortho ko involve kar liya, and patient is saying it's not only about paying the bill for the stay because this is your hospital acquired problem. My baby may have problem in future, mental trauma, I want 2 crores compensation. Okay. Or breastfeeding certificate was given by us. Breastfeeding certificate दिया and किसने लिया? Magistrate ने लिया. किसने लिया? Chief Justice को sue करने के लिए लिया कि मेरे को छुट्टी नहीं दी correct time पे. And she got it written in the breastfeeding certificate that this was critical. But critical is a legal word. Or this is an old story. All these are not coincidental or not. These are all my own stories. ठीक है? और Nestle की tin में, sorry if there is any company person here, worms निकल आए. Bystander को tin चाहिए था sue करने के लिए, लेकिन company लेके चली गई. Now they are saying you have destroyed evidence. 15-20 दिन तक पुलिस को थाने में बैठा रहा pickpockets के साथ में. So I am going to ask my experts, what do I do if I am thinking I am getting into a medical legal situation?
Sir, this is also a very common scenario. So we do have medical complications while treating patients, and one is this injection site abscess, and in neonatology practice, common is pneumothorax on a ventilated baby. So whenever this happens, so again, first thing is you manage the baby first. So if you are dealing with such complication, manage the baby first, make the baby stable first. And after making the stable, then gather your team and ask that how it happened, when it happened, and who was the person responsible. It is a team meeting. It is not involving the parents. So gather your team, gather your facts before meeting the parents, and make a common narrative that what do you want to tell, because sometimes you tell something else and your staffs tell something else. So this conflict of statement should not be there. So better have a common narrative, and then again then you meet the parents in a private room, of course, and have some 2 persons with you. I think one yourself and one senior nurse can accompany, so that more weightage is given, and then again you have to acknowledge that some complication has occurred.
I'll just add one point, because don't wave off the bills straight away thinking that they will be saved. If you waive off the bills, Supreme Court has presumed that there is a medical error on your side. So if you want to waive off the bills also, the patient should make a request, look, I have a financial situation. Can I take this because this was not anticipated? And you can help them. But if you waive off on your own side, you're already admitting to error and that this care was given by mistake. I'm going to push it faster. Sorry, Amanpreet ji.
Yes, okay.
Conflict at work, other kind of stress. Rahul ji. No, we ask your opinion on this. I have put this as PDA is inversely proportional to the gestation of the consultant. So, wanting to treat. So, Asha is here and Abha is there. They look at the कब जाएगा ये रूम से बाहर और हम बना देंगे PDA को टैकीकार्डिया और हार्ट फेलियर होने वाला था हमने रोक दिया अभी. So, how do you deal with this conflict at workplace?
So usually conflict of opinion usually happens because of the differences in training, and also mainly because of the senior junior change in trends of the practices. So one has to be like they have to keep their emotions in check. Mainly it is a team game, so you have to make sure that everyone is in common page. So ensure that mainly taking care of the baby should be the first priority, and you should have discussions. Maybe you can have grand rounds kind of a thing where you can furnish your evidence, and also you can request, you can ask opposite person also to furnish their evidence, and also you can take third opinion, means third person's opinion, you can take that. And at the end of the day, baby's health should be the priority, and there should not be any ego in these kind of things. That is my opinion.
Rahul, you managed to manage conflict, or you just burnt out everyone else and said, "Ki, I am right." So conflict resolution मोहित जी कैसे करते हैं आप तो 3-4 लोग हो एक साथ और बिजनेस भी है साथ में. हाँ.
The best what I have seen is the senior most should go down. Then, because the senior most is the least useful person in the unit, and that is what I always realize. So I always go down. This is to be done, but now it is your responsibility. You are equally responsible. Take your decision.
Okay. Wonderful. So most of my residents, when I ask them that where do you want to work tomorrow, they want to work in a unit where at least there are 2 people, so that they don't suffer and they have good work-life balance. But बहुत सारे imbalance भी आते हैं उसके साथ में. I have found people who are trained in the same unit also not agreeing on the same way they work. We are 2 human beings. Anyways, now this is another interesting one for people like Rahul, Mohit. Ki you were, maybe you are still a hero once. And a new consultant joins your unit. Young बच्चा आ गया कोई और आपको अभी समझ नहीं आ रहा है कि whether you should stay or you should go on. So we have seen the Rocco, है ना? So whether Rocco should leave or Rocco should stay.
So this is also my question only. So once a hero, always a hero. So it is not like experience always matters. So it also depends upon at what age you are. So at very young age, you feel like you can do everything, but you don't have the experience. At 45, 50 years, you feel like you are at the peak of your career. And at 60 years, maybe beyond 60, you should let go of the things to your juniors. So that is how it has to be.
Vigorously shaking his hand, Rahul. He's saying at 50.
But having experience is always matters, because with experience you have dealt with many of the difficult patients, conversations, and also you have had most of the networking. So you should always build a team where everyone is feeling valued. So as junior also will have insecurities about how he can do the things with the senior and all. So insecurities should be kept aside. Everyone should work as a team, and also seniors should adapt to the new challenges. They can pick up new things like simulation, all those things, which I think everyone is.
Which they can manage at that age also.
So yeah, means we can pick up new things and new challenges and be useful for the team. That's it.
Naveen,
Yes.
Same thing, Somshekar. So one thing I think if you go alone, you can go faster. But if you go with a team, you can go longer. That's the common thing. So if you have a team. But the most important thing is if you can't get replaced, you can't get promoted. So the point is you have to kind of give your more and more work to the juniors. So you can do different kind of work. There's enough work for everyone and there's no shortage of work.
I really hope wisdom stays with everybody at all time. So family versus work is another thing. Whatever questions we've taken up is something that maybe in the lighter vein, but we all need to reflect actually. And this is something which I was meeting yesterday also that with the same team from Melbourne. Arvind Sehgal was there and he knew that I'm landing in Melbourne. And he said कि जो आपका blue book model है development का आप आके हमारे यूनिवर्सिटी में present कर दो. I said वाह मेलबर्न में presentation करने को मिल रहा है. And at the same time I had booked my tickets to watch those penguins which come out from the sea in the evening. That is 200 kilometers away from Melbourne. So I wanted to see that. Other one is literally this wife's wedding anniversary. मतलब मेरी भी थी.
His wife's or couple?
That's what. It's not only wife's wedding anniversary. Both of us.
I had committed to Vishnu Bhatt sir कि I will come to Jipmer. Sir ने कहा कि जिपमर आना है तो आना है. सोचा ही नहीं और घर आके बताया बड़ी खुशी से कि जिपमर से मेरे को इनविटेशन आई है. तो उसने कहा कि उस दिन तो मेरी वेडिंग एनिवर्सरी है. मतलब मेरी मैं तो फंस गया. And so what do you do in these kind of situations that you're getting to speak in Melbourne? And please understand Jipmer is as prestigious an organization as is Melbourne. So क्या करेंगे सुरजीत सिंह?
Yeah. So looking at this picture, you know my reply. Oh my God, Melbourne. Yes, I would say yes for this talk, and definitely my kids penguin show, but I would explain them that this is once in a while opportunity. So I'll give them some extra time. Maybe I'll miss this penguin show and give some quality time, spend some quality time with them later. Because if you talk about me since they were small, I made them understand what are my duties, how dedicated I am, how hardworking I am. So what I want to build into them is like the kids see what the parents do. So they've been seeing me, how sincere I am and how dedicated we are towards our profession and towards academics. So I want even them to be like me. So I think they will understand because since they were young, I want to build into them these qualities. So I think at least my kids and all of you, if you make them understand since beginning, they will definitely understand. And yes, you have to bribe them with maybe some extra gifts or chocolates or some extra quality time, and they have like a little heart and they'll understand.
आप क्या करोगे? मेलबर्न में टॉक दोगे यूनिवर्सिटी में जाके या जिपमर? इन्होंने जिपमर को तो हवाओं की ही नहीं खाली मेलबर्न को होगा.
उसका भी मैं बताऊंगी. वो एनिवर्सरी का है.
जी.
This is for the kids. I think they'll understand.
मतलब
बच्चे तो समझ जाएंगे उनको थोड़ा सा. And for the anniversary, yes, it is. If I have many invites in the whole year, and I'm getting another invite on my anniversary, I think I'll miss that invite. And I think life is very short. We need to give time to our loved ones. So important occasions of our life, I think we should give time to the family.
Pondicherry. We did that.
Yeah, we can
and
take them
unfortunately, she agreed on Aurobindo Ashram. This is the real story. And Modi ji landed and Aurobindo Ashram was logged. But only, उसके बाद we went for scuba diving. तो वो अच्छा था. Anyways.
Naveen here. My wife's birthday and anniversary both are during Neocon and Pedicon times. So
तब भी अकेला
She's accepted it then for all the years.
Ma'am, continuing with this, this is a genuine thing which everyone in this hall needs, is health versus wealth.
Health versus wealth.
So whether you need to get into some exercise routine, Pankaj तो सुबह भागते हुए दिख रहा था, मैं पीछे से आ रहा था, हम walk पे जा रहे थे, धीरे-धीरे something like breeze went by, that was Pankaj. And versus long working hours, or how many of you actually find time for lunch and नहीं सोचते हो patient wait कर रहा है बेचारा, खाली पैसे के लिए नहीं, they're waiting and they should not wait for longer, and you just gulp your lunch with an OG tube and then go back to work again. So what should you do, ma'am? Surjit ji.
These are few things I have noted down, which I actually follow. We have all this stress in our daily practice. We have life imbalance, stress, work pressure, and one very important thing is wealth pressure. I'll tell you how it is. The next slide. There are few points which we all have to follow, and even I try to follow. Having a good sleep of 6 to 7 hours, because like if you're sleeping well, you can work well, concentrate more on your work, and you can put your phone on call forwarding while you are taking rest, or maybe during your OPD times, if you get 15 to 20 minutes or half an hour to take a nap in the hospital so that your mind is relaxed, you can do these things. And regarding eating, once I try to have a good breakfast, so that we all know that we might not get time for lunch, and I carry a few good healthy juices, maybe green tea or coconut water or lassi or some fresh juices. And because eating is little difficult during busy OPD hours, so keeping something liquid or juices or maybe turmeric milk during winters, and then taking it in between while seeing the OPD patients is also helpful. It's easier to follow. So I always carry a liquid juices or something like that with me. And every 2 hourly, I try to take something.
So this slide I will share with you. So क्या क्या ले जाना है? Parents पूछते हैं क्या क्या charge. वही देखा मुझे और कुछ नहीं दिखाई दिया इसको. ये अर्जुन की आंख की तरह से.
Oh, is it? That was just no. I don't carry that. So I didn't. So yeah, I try to go to gym. That's my picture. At least thrice. I've enrolled in a gym at least thrice a week. I try to go. Then in case I miss my gym, and that early mornings, because we know in the evenings we are tired and the whole day it is not possible for us to go. So in case I miss my gym, I make sure that half an hour of walking in the morning, maybe while taking overs, or half an hour walking after dinner. I think this much we can actually do for our health. And I've actually kept a cycle in my bedroom, so that at night, like while you're watching some series or maybe news for half an hour, you can do your cycling. That in that way you can take care of your health. And there are very few important things, like it is not all the time you have to exercise or go to the gym. There are few things which you can do in your OPD. I keep my tongue depressor, the torch, away from me, so that I have to get up or maybe twist myself to pick up the things, or get up, and I've kept that examination table little away from my chair so that I get up and look at the patient, or in between maybe after 15-20 minutes just go for a round and routine walking. So these things actually help in burning your calories and you stay healthy.
I wanted to say.
Yeah. Then the next, I knew you would look into that. So a few minutes of meditation would help. Get involved in few hobbies. Maybe on weekends, I try to go for some dance activity and all. And decrease your wealth pressure, like decrease your expenditure. Maybe your men are fond of Audis and like expensive cars. When you are spending so much, you have a lot of EMIs, then you want to earn more. You have that stress of earning, how to give your EMIs for that month, or buying expensive bags, Gucci, LV and all. So see, I have bought that because I don't take stress. I knew somebody would point out to that. If I am buying a Gucci or LV, I'm not taking stress out of it. So I am prepared to pay for. I am prepared for that. If I am buying those, if you are actually spending on your cars or world tours, then don't take stress. Basically,
So one of the things I think which I saw in the US, and I think we should all do, especially for people who are doing jobs while sitting. If your job involves more of sitting, I think having a standing workstation really helps, because sitting is a problem. So standing workstations, like most of the professors there have standing workstations. They also have they have a treadmill with the laptop, etc. put up on the treadmill, and so you can, while walking, you can reply to emails and read. So you can do that. They have cycles in the offices. So even your office area can be actually changed to ensure that you have a better lifestyle. And plus, morning is the best time. So you can listen to a podcast. You can move around if you are staying on a campus, it's very good. If you're staying in a city in some place, it can get difficult.
It's not only about your physical health.
I know, ma'am. Sorry, because
Just prevent, don't use lifts and escalators. Try to go through the stairs. This would again help.
Oh, they hate me for that because There are my students and they hate me because I don't take the lift, except for one resident who says I have a knee problem.
Naveen, just one comment.
Yeah.
We are doing everything for ourselves, but most affected are the residents. So if MNF can make a logbook for academic activities, we should make a logbook for your physical activity also, which you do every day. So students' health is more important than what we need.
Absolutely. Now, there are two other more, and then I'm coming back to the audience if we have time. These are again different kinds of stresses. We had stress of work-life balance. This is about 15 years back. सोमशेखर जी, I was coming down. मैं OPD एक लेवल पे था और निक्कू दूसरे लेवल पे था. OPD से निक्कू में आ रहा था तो देखा कि एक नर्स जो है ROP डायलिटेशन के लिए बेबी की आंख में ड्रॉप्स डालने वाली. She is about to put, and the syringe needle दोनों है. And this needle is very close to the globe of the baby, and she was about to apply the drops. I can hear the pin drop silence that is there in the hall. No? And or recently happened that the newly joined nursing assistant was told to take a baby to feed the baby ki ye transition hone wala is, go into the room. She took the baby, happily came back, but the mother was still calling for the baby because she went to somebody else's room and got the baby breastfed and came back. So ऐसी situation में I was thinking throughout the hall that one panelist ran away, Indigo ने भेजा ही नहीं उसको, तो मैं सोचा कौन सोमशेखर दिखा, मैंने यही है सोमशेखर इसकी बस.
So we had an issue like this, not like this. We were doing a study for video recording in resuscitations in the research area. तो एक मेरा रेजिडेंट था, MD रेजिडेंट, वो आया बाहर और he was scared कि क्या हुआ, not this particular thing, but parents said कि हमारा तो लड़का हुआ, आपने तो लड़की दे दी. He mistakenly told that it is a boy when it was actually a girl. My God, 4-5 घंटे बिताने पड़े, quietly talking to everyone, showing them, extracting videos, showing them this is what happened, this is your baby. And so there's a lot of stress which happens when this kind, and the most important thing is to stay calm, involve higher authorities if there's an issue. This is one example of mine. We have had two incidents like this. One happened in the PICU, and just because it was a hospital boardroom like meeting and all, I came to know, not involved in the case, but a patient who was improving and was to be discharged 2 days later received a medication error and died in our PICU. And that patient was known to a health nurse or somebody, again, so related to a nurse. There was, and you cannot say that a patient who is sick, somebody is improving, about to be discharged, dying is like out of question. So it was openly disclosed to them कि ऐसा हुआ है. There was no case filed, nothing happened. So we were quite lucky. So these things do happen. I think it's best to, like as I said, to have a common narrative, discuss, and be very open about it. Because if
you've done a lot of researches in unique areas. How do you prevent? How do you train down, deep down, to each level to prevent this kind of errors? Drops, गलत डाल दिए बच्चे को गलत जगह ले गए. How do you take training to the lowest level or the last level?
It's one of the reasons is because many of our turnover is quite high, 20 to 30% turnover is there. So unless you do repeated trainings, regular trainings, like NABH, for NABH accredited hospitals, आपको हर साल training करानी पड़ती है. Lookalikes, like sound-alike medications, LASAs. So all of these things is inbuilt in the system. So unless and it is required to be done every year, हम सबको training करनी पड़ती है. हमको like even us, we have to sit down and click all the answers. और question ऐसा नहीं कि आपने 1A, 1C ऐसा number भी आता है. It keeps on changing every time you change.
आपको एक और तरह का स्ट्रेस देता हूँ. मतलब ये तो आपने मैनेज कर लिया, ये वाला, ये आप कॉन्फ्रेंस में बैठे हैं, and unfortunately after many Chinese authors have taken over, they produce one systematic review every month,
every week.
हाँ, and each of them gives different answer. Probiotic देना है कि नहीं देना है, IVIG for RH isomnization देना है कि नहीं देना है. Now as a practitioner, as a student, as an examiner, as a guideline making body, what do you do? How do you resolve this kind of stresses, academic stresses?
So probiotic was an interesting question because we did a study on that and we surveyed a lot of Indian NICUs. Most people don't use. They agree that there is evidence. Most people, 20-30% use. Most of them don't use. There was a debate on this in the West Zone Neocon, very well done debate, which showed that there is enough evidence to say that it should be using it. But the problem with the evidence, at least for India, this is like a science question. Our probiotics are not our probiotics, what we use. They're all from outside. And our microbiome is different from the microbiome in Australia or in Europe. So we really don't have probiotics from our own area to say that we should be using this probiotics for, so we don't have enough evidence for that. Now, whether somebody is using, not using, how do you do it? I think it's of all the recommendations, this is like kind of a query recommendation. There are many kind of very good guidelines, but still some units do it differently. I think if it is best noted in a protocol, and if the entire protocol is followed by the system. But I think we should also allow, I think Dr. Vizag mentioned in his this oration that we need not, everyone, it's not like यही follow करना है. अगर आपको vary करना है, you should be able to write, I am varying from this, and this is the reason I am varying for it. I think Dr. Rahul doesn't believe in protocols, if I'm not wrong. So there should be freedom.
Based on the mood of the day. Sorry, just pulling it like.
So this should be, I think there should be enough space. There should be enough space and respect to debate from the protocol. You know, so ये तो book में लिखा है, ये तो guideline में लिखा, तुमने क्यों नहीं किया? I think especially for things which are not very kind of, you can't say that I will start using 100% oxygen for term babies. उस तरफ नहीं जाना है, but you have to be kind of flexible in areas where there is not enough clear evidence or the evidence keeps on changing. Like PDA. Mohit till he dies, he'll talk on this side of that side.
Mohit adult PDA will be diagnosed for that. Anyways, now these are questions for the audience who are in the hall. Self-assessment. You can just read. Nobody's recording this video. Recording nahi ho rahi hai. Do you play any game, or at least watch some games? That means you read non-medical, public pubmed nahi. You write something. Very good. You sing.
Listen to music.
You listen to music still?
I have to listen to my wife's song also.
Do you spend time with your parents? I mean, this is a very important one. Really, do you get time, quality time with your parents?
Phone calls, and like you can't. Stay far away. Phone calls.
Quality time cannot be need not be one-to-one. It should be there. And siblings,
yes,
friends. Rahul to friends ज़्यादा देखा है. And they are very spiritual meetings. And is this frequent or occasional or rare as a medico? So, yoga?
No yoga.
Zumba?
Gym.
Gym? Okay. Movies देखते हो?
बहुत कल कितने लोगों ने धुरंधर देखा है कल या परसों? यहाँ पे देखो
पेंटिंग करते हो? Zen follow करते हो? Or some kind of Zen? Then very interesting. अगला session इसी पे होगा. Okay, this is the last one. Somebody hits your brand new car, Mercedes जो दिवाकर सर जी नहीं खरीद पाए. आपने नई खरीदी. What will you do? You will shout and fight with that person on the street, not like a medico, but just like.
There is a famous saying in India, Pakistan or somewhere, some journalist said, "जंग के बाद टेबल पे बैठना ही पड़ेगा." So there is no point in fighting any time.
Or you will feel disturbed anyway, and take your car to insurance because I'm sure your Mercedes is insurance covered. You thank God that you are not injured at least in the car and you are able to be there. Or you gratitude that you have a car. मैं Mercedes तो नहीं car तो है मेरे पास.
Okay, how many people have been in a severe car incident and survived? So my car got totaled. We were driving high on the highway. We hit a dog and car did not move. The 3 people in the car, all of them were wearing seat belts. Nothing happened to anyone, not even a minor injury. Yes, so I think it's very important to follow guidelines.
So this is both the seatbelt guideline and this guideline. Don't leave it to the PowerPoint. In real life also, please look at this, that you still have some reason to have gratitude. It won't help you to fight. Thank you for adding to the audience, whoever was here. And hopefully, we all will manage stress, health better. And maybe if Manoj had his way, we would have, he said they should have a cricket match between teams, but then he realized कि वो political लड़ाई हो जाएगी, किसकी team जीती थी. So, thank you so much.
I have an unfortunate, I won't say unfortunately, not a very good experience. We had a cricket match with MBBS students, residents. I was the second highest scorer and my resident scored less than me.
यही बताना था मुझे.
Which is the problem. Which is the problem.
चलो. मैं भी गया था सर मैच में.
नहीं वो मेरे
5 साल पहले. I used to play cricket at different level, but जब 50 का करीब हो गया मैं मैच खेलने गया तो जो यंग रेजिडेंट्स थे वो बॉल की चिंता ज्यादा कम कर रहे थे, मेरी चिंता ज्यादा कर रहे थे. सो देन आई डिसाइडेड कि अब इसके बाद आई विल नॉट डिस्टर्ब देयर गेम. वो बॉल के पीछे नहीं भाग रहे थे, मेरे पीछे पीछे गिर गया तो उसको पकड़ना है. तो देन आई सेड आई विल नॉट प्ले क्रिकेट अगेन एंड स्पॉइल देयर गेम. So thank you all for listening, and we'll have academics in the next session. Thank you.
One last saying. There's an old saying that. So before that, we all are working in critical care units. So I think staying calm. That's what we have been discussing for last half an hour. Stay calm. For that, you need a good physical health and mental health also. So there's an old saying: if wealth is gone, nothing is gone. And if health is gone, everything is gone. So we need to take care of health and decrease our stress and manage all these
I hope we all can
complications.
practice a part of what we have preached here. Thank you so much.
Exactly.
Thank you, sir.
Thank you.
Wonderful session this. I request Dr. Naveen Jain sir to hand over mementos to the panelists. I request Dr. Mohan Cheni sir to hand over memento to Naveen Jain sir.
Thank you so much. Rescue कर दिया last.
आपको नहीं लगा सर रेड वाइन ढूंढने के लिए
Thank you.
Basagi, basa, please sit. Both of you, no problem, please sit. Good evening, friends. It is great to be here. This particular topic is actually quite close to. It's going to be futuristic topic, sort of. It's more of a home therapy, domiciliary care of neonates. So how to project? Started. No? Yeah. Now. Yeah. So home therapy. Now home therapy is something which is going to come up in a big way, and it is or no any trained thing going on right now. What is happening in the home therapy is this. What is that? Now, previously things were very easy. RDS will be there, mild prematurity, moderate prematurity will be there. Now what we are dealing with? Chronic lung disease. We are dealing with something which is choice. So I would like to ask Rajat, so just tell your experiences about this sort of frustrating situation when baby comes out of ventilator but stuck on some respiratory support, and whatever all the DART, all the regimes we have tried, but baby is unable to wean from respiratory support and the family is asking for discharge. At the same time, you can't discharge the patient. How do you manage this frustrating situation?
So this has become, as I said, more common than it was in the last 4 or 5 years. And they all sign up for spending X amount on IVF. Then they have twins. Unfortunately, twins are preterm. And initial counseling, they will say by 34, 35 weeks, they'll go home. And at least one of them has not read the books, doesn't want to go home. So the earlier that you get a hint that things could be prolonged, it's better to start having discussion. And personally, especially when it comes to domiciliary NICU, I have some experience with home oxygen more than anything else. So I personally depersonalize the situation to parents and say that some parents would want to set up some of this service at home at some point. We'll come to that a little bit later. So you plant that seed in their mind. So it will not be frustration. It will not be a choice. It will be a plan. It will be a plan. So I think that is better to have. But for that, you need a system in place. So I mean, some of us have developed a kind of system. Maybe because of our training abroad, because we used to, in the UK, we used to have, and the trust would stop sponsoring the baby, and then the budget would move to home care team, and then there would be things put in place. So the short answer is it's worth having a discussion when things don't go well, and we are at the knife's sharpest edge between the hospital management, which may not want to lose the patient to home, and to spend an amount of money and time. And sometimes it's not even money, Rahul. It's parents have to go back to work.
Yes.
Their entire life is taken over by being in an ICU. So I think a little bit of planning and whoever is in the audience to start thinking that can I find resources where I work, whether this can happen.
Excellently put. So what we do once we cross this 26-week Rubicon, then we went up to 22 weeks. And this 26 to 22 weeks gestation age, these petty babies, we face this problem a lot. Now what we did is, we got certain turning points, 34 weeks, 37 weeks, 40 weeks and 44 weeks, post-conception age. What we tell them that you are counting from after birth, but nature is counting from conception. They understand this concept, that nature is counting from conception, you don't count from birth. Now, once this 34 week is getting crossed, at that time itself we give them option, that there is an option, that this required 37 week, then you go for the next week, because they usually plan in bulk. They plan in month. But what happens is usually what previously used to do, next week, we try to wean the baby. Usually the weaning is done on Monday. We don't wean on weekend. On Monday, weaning is done, weaning phase, and we have to look at their sad faces every time. Baby is good, baby is active, but oxygen dependency is not coming up. So this 34, 37, 40 and 44. And if you make it planned, even if this particular baby does not wean from 44, this one, they are already primed for this home care. If they are primed for home care, if they plan for home care, then it is not a frustrating issue. It is a planned issue, as Vijay pointed out very well, that if you plan properly, it can be a nice experience rather than a frustrating experience. Now, I would like to ask Somsekhar sir, so what are the indications, what are the key indications we get for offering home therapy, the neonatal therapy at home you come across?
So you mentioned previously, and so all of these things mostly don't apply. But what actually applies is kind of early discharge, antibiotics appending, and so these are the two common things where patients are not ready to stay, and they want to go home. The advantage is that we are not a big metropolitan, like it's a small area, and distances are really closer, and you can move. So what we can do is we can kind of one of the most important things is involving the parents in care right from the time the baby is in the NICU. So they kind of understand how to take care of the baby. So if they have to give gavage feeds, etc., which they begin giving in the NICU, they become confident. They go home and they can continue feeding. In many places, suppose for some, like if you're giving antibiotics for 3 or 4 weeks and they want to go home, and there is an option of coming in the morning, doing the thing and going back home. So in that way, because the distances are shorter, they can do these kinds of thinking. There's phototherapy on your screen. So even here in many times, because they want to go home early, and this is for bigger babies, and we are worried about the bilirubin building up. It's not like in the West where people find it very difficult. There are a lot of insurance issues. Here it's relatively easy. They can come and we can do the test, and they can stay for a day in the hospital and then go back. So when so you can tailor make a lot of these things in consensus with parents, and many people are happy to do it. Now this has actually changed after PMJY, because previously there was a lot of thing on cost which they had to come out of their pocket. But if you're a PMJY institute, then they're ready to stay for as long as you want. So
That's good.
Changes have happened now.
That's good. Rajat, what do you think about what are the indications?
Yeah, quickly, I think this is a very important topic. I think I foresee in 3 Neocons from now, this talk will be in Hall A, and there'll be companies running home NICUs.
Yes.
So that's a prediction. Somebody can write it down. So the low-hanging fruit is obviously phototherapy. There are parents who just want to make kharid lunga phototherapy or charging. So gastrostomy feeds, home BiPAP in neuromuscular babies because it is never going to change.
Yes.
Then trachea babies who have gone home on ventilation, and then home oxygen babies for preemies.
Yes.
I'm very wary of sending premature babies on CPAP home because if they're CPAP dependent, then they're like wuss. They're not going to make it. One little bit of choking and then they will go away. So I think if you're a unit who wants to support these kind of things, you develop your own criteria. For example, BAPM in the UK has a criteria for transition care and home care, but we are very heterogeneous. So you develop your own. So my own practice is this. So are you home ventilation because you have a poor drive, poor airway control, or prematurity which will get better? I'm going to send only home oxygen premature babies. All the others will need a proper team.
Yes.
Home TPN in intestinal failures and others we have done. We have a lot of entrepreneurial thing in home-based adult ICU, adult all those things. It's a double-edged sword. So they will just send somebody who doesn't know much. For them the size of the patient to our size will be like ballpoint
tiny.
So they will this thing. So we have to do that. One of the things I think that will come up a little bit later. So I think be very clear what you want to start, and start very small and make that work and have some safety net. So these are the indications.
Perfectly said. But this is how we were. Initially we discharge on low flow, then we discharge on HFNC, discharge on CPAP, then we discharge on non-invasive ventilation. So gradual escalation of the ability of our system to deliver a good quality home care. It should be planned. If it's unplanned, then it's like actually frustration, because when that particular thing is unceremoniously discharged, and then as he pointed out, disasters can come.
Yeah. So taking from what he said, from what I've seen in the adult home care, because in our hospital we have a home kind of care service.
Yes.
There in the adult space. And there are a lot of private operators in the home care space who are not very well trained. Many like Ayurvedic homeopathic doctors running home care services, which is also not very well done. So that needs improvement, and I think it's a space for entrepreneurs to enter the home care neonatal space, at least in the urban metro. So there is, as you said, in 3-4 years time or 5 years time, this is going to increase because we are going to be saving more and more premature babies, and these problems are going to remain for the next 20-30 years.
Yes. So this is the first what we so the first meeting when the home care is planned. Then what happens is that 4 parties are there here, 4 stakeholders are there. One is home care provider. The home care provider is actually, as Sir pointed out, you should be expert in managing infants. Usually these babies are no longer neonates. They are actually they are more than definitely 1 month. They are infants, actually, young infants with respiratory challenges or nutritional challenges. Second is family itself. Family is usually exhausted. Third is the treating team. Treating team also exhausted. But now treating team has got some part of relief. Now happiness is different, relief is different. Happiness comes up because of cure. Relief comes at least this baby is going home. So that particular relief is there. At the same time, anxiety is there. After you going home, suppose something happens, whatever we have done for the last so many weeks can suddenly collapse. And hospital administration, that is the biggest elephant in the room. So but they have actually collected a lot of money from the hospital, and now patient has stopped paying, insurance is over. So hospital administration also pressurizes the treating team that discharge the patient. The patient is not being discharged, the patient. So these pushes and pulls are there right now. So you also worked in corporate hospital, different types. I also worked in corporate, government, say various types. These are 4 pushes and pulls are going on. Now, how to manage these pushes and pulls? Because there are 4 stakeholders here. How do you manage?
So I think it's very easy to lose sight of the baby. So the baby should come first.
Yes.
So if you can convince all the 4 contenders here that what is it that is best for the baby. So if you feel that it is still best for the baby to be cared in a complete hospital setting, so you will have to find a hospital which will take care of the baby if it is not yours. If you find that the family is an issue, they cannot do, then it is about upskilling the family, putting something in place, whether they get a part-time nurse to come in, they get a grandmother who is sometimes very bright and she can get trained, all those things. Then the hospital administration, the way I would convince them is that in going days, this is going to be the norm. Okay, so the patient retention will be better if we can send babies home because this person is exhausted.
Yes.
Otherwise, he's going to leave even following up with us.
Correct.
And a baby who is on home oxygen is a good client to have for the hospital because
perfectly said. Perfectly said. I'm very happy. So this is the trick I use with hospital.
So the treating team is something that people who have experience in this can train, and they start seeing the advantage of keeping engaged with the family.
Yes.
And still treating this at home. But I'll circle back to what I said. If you feel that this is not a baby who's going to be safe outside this thing, please do not try this on the baby.
What's your experience, sir? Do you feel this conflict of interest? Hospital administrator and patient and family. When the conflict of interest, how to resolve that?
So I think if the hospital itself starts home care services, it's the best thing because they will be pulling money from both the sides. So in our adult space, we have it, and it's a requirement. But what we have been using, because there's again rural areas, so there are a lot of ASHA workers.
Yes.
So we have a network of ASHA workers, and we can network with them, and so we can get back their patients faster, earlier, and so they also know what to look for. So they are like the proxy people, but they're not, and they're fairly well trained, but not to the high levels, but whatever levels we can do.
Yeah. As far as our organization is concerned, I'm working in Cloud9, this hospital. Cloud9 has actually taken this home care at different level. What they do is all deliveries, 2 days of home care is given complimentary as a package. So the patient goes home, even normal baby also, even NSU baby also. There the sister goes, now the 8 hours package, 16-hour package, 24 hours. The package money starts after 2 days. What happens is the patient gets a taste of it. Patient gets a taste of what is home care. Whether the presence of sister at home is it going to make easy or is it going to make irritating this one. So they take their own judgment. So dressing, feeding, phototherapy, all those things is covered in the package. So if it is made as a part of the package, then it becomes a habit. When real home care is required, like for example CPAP or something, acceptance is easier. So hospital administration should not fight with the interest of the baby. Fight against interest of the baby. So we have to make all this fighting this one together, and we have to go for better improvement.
This is not happening, but I think this should be considered.
Yes.
The corporates may not be considering, but there are a lot of individual hospitals of people who have their own hospitals.
Yes.
Who also need to send. So what has happened in Gujarat, in one of the northern states of Gujarat, PMJY requires somebody to be there all the time.
Okay.
So like 10 hospitals had taken PMJY, and then somebody came and said, "Okay, doctor nahi hai," and so they stopped PMJY. So there's an issue. They all got together. They set up a single hospital. All patient people contributing to the hospital. And they had somebody permanent there.
Correct.
So if people in a tier 2 city, cooperative tier 2 city, neonatologists and everyone gets together and establish a single home care system, it is helpful to everyone.
Yes, that's good. Good idea actually. Next is doubts. Now, when this particular thing is raised, now a doubt comes up. Whether the family has got doubt, and treating team also has got doubt. Family has got doubts that whether this is safe. Second thing, is the hospital dumping us? Is the hospital tossing us? Usually they don't use the word tossing, or whether just because we have stopped paying or with this one, is the hospital getting rid of the patient? That is the main thing, and they don't express, but their body language is showing usually. Second thing, the treating team also is having doubts, because as sir pointed out, the adult person is going to take, adult nurse is going to take, whether whatever we had done for last 2 weeks, suddenly that particular aspiration will happen. So how to overcome these doubts?
So what I have personally seen is they're okay for something like phototherapy because it's a low-hanging fruit, they save money.
Yeah.
But to take a baby home on oxygen, they see it as a failure. There's a lot of stigma. Okay, so they feel that they've already brought in a baby who's disabled.
Yes.
Okay, so that part, half the families where I've offered home oxygen, they'll say, sir, we'll see for another week or 2 weeks. If we do not get out of oxygen, we will do that.
Yes.
So then there are objective things. I might feel like this baby is for home care. You may feel different. So there are objective ways of doing this. So there are polysomnography tests that you can do even in preterm babies, or even if you have slightly high-end monitors, you can get a 24-hour download of at least cardio respiratory events tracking, and then if your baby is spending more than 30-40% below 85% when you take out the oxygen, that baby is going to develop pulmonary hypertension in a month and might have a silent death. So it's easy for us to convince them. So sometimes you address it head on, sometimes you take the advantage of technology, and sometimes you ask them why they do not want to go home, and they might come up with we are not geared up for it, so that is okay. Never thrust it upon them. Allow them time and they'll come to terms with it, and they may not have experienced how it is all set up. So you paint a picture, and I have at least 5-6 families who are in the vicinity who can talk to them. So I can just say that, do you want to talk to this baby of Sakshi now? They have gone through the similar situation 6 months ago and the baby is doing well. So they might just exchange notes, and they will find out cheaper ways of hiring equipment. They will find a favorite nurse in the area. So all these things happen. So you do it in stages, and I think the more senior you are, you get an idea of why there is a resistance coming from you. Address it. Don't brush it under the carpet.
Perfectly said. The best counselor is not doctor at that time. It is another family in similar situation. That is the best counselor. Once you give phone number and all, first of all, they start trusting you. The similar thing has worked. It is not experiment. It has happened and happened successfully. They talk with each other. And when they come these babies are coming for follow-up and neurologically normal, then they get confidence. So these doubts should be overcome. If they are having doubts, and at that time, if you discharge them, then actually problems can develop afterwards. Now, these are the specifications. As I pointed out, adult in COVID pandemic, there was a lot of home care was going on all over the world. Or oxygen concentrators, CPAP, and all those things. Now, COVID has gone, but these machines have stayed. Now these machines are actually being used in a large way. So these are the specifications. So out of these specifications, Rajat, this one, what are the specifications you feel most important? Because these are the adult specifications, children's specification, infants and neonates specification.
So I'll start with the simplest thing of home oxygen. So home oxygen, you need to have a pressurized cylinder or home oxygen concentrators. Concentrators can be quite noisy. The parents have to live with it. Even if they have a concentrator, the concentrators need at least 2 hours of rest in a day. So they need to have 2 concentrators or to switch over to an oxygen cylinder. And they have to bring the baby to the hospital with a small cylinder. So all these 3 things should be. And you never send them home on a weekend because all these things should be there. Then they need suction. They need a good SpO2 heart rate monitor. And they need to be trained in full life support. So this is for the home oxygen. So for the devices, interfaces, the device and the drive that we use in hospital, 2 portable devices are very different. They are flow-driven CPAPs. They are noisy. They give dry air. They do not humidify. Or if the humidification unit becomes quite bulky. So I have only 2 babies who I have sent in this age, older babies I have sent, where I have taken the permission of the hospital and got the equipment that they're going to go home for 2 days into the hospital and tried that interface. And in one case, it miserably failed. The baby would not tolerate at all. And in another case, we were successful. So CPAP, so these are the specifications you have. And all the vendors and the people who rent this out, they will just circulate the equipment that is easily available for them, or they need to have some ROI on. So you need to examine that and do that. Then the trachea ones are much easier.
Yes.
The trachea ones are much easier. The face, nasal interface are much difficult. HFNC is an easy answer.
Yes.
But you should is not going to fail HFNC. So these are the things.
So those babies, this one here, what we do is, this one is we actually put competition among vendors. Initially, we explained vendor A, then vendor B, vendor C. Then we understood that it is not going to work. So we started put a tender sort of this one. We bring all the vendors. This is the requirement, and who is going to give machine, and let them compete with each other. And then out of that, one person is actually able to get the best possible, best safest, and which is suitable for infants. That vendor we can support. Then vendor also starts investing in the equipment. Once they come to know that these type of babies are going to increase, they also invest. So virtuous cycle is started. So
less than 5 kilos is difficult.
Yes. Yes. Yes, sir.
The point I wanted to make is in 2001, 2002, I had seen KMC related PowerPoints and videos from Colombia where they used to send mothers at home with oxygen.
Yes.
We are in 2025 in India, third, fourth largest economy, and still we are not doing this, which I think suggests that we should be innovating and doing it.
Yes.
If
we are doing,
not
but
so much,
not large scale.
Yeah.
Large scale. So this particular age has come now that NICU has to move to the doorstep. Now this is the thing commonly we have to be very clear. And once you give this table to the family is very happy. If you buy the equipment, usually this buy equipment may not be new, sometimes second hand. So buy equipment and rent. So these are the usual prices. What we can see is CPAP without battery, CPAP with battery, oxygen cylinder, and suction machine, and rental price. Now they are usually asked this one, what is cheaper? As Vajat pointed out, they also talk with each other, what brand they use, what machine, and all those things. So in your experience, they like to take on rent or they would like to buy?
See, I do not advise them to buy, because when you take rental, so I don't know whether your hospital uses printers on rental. So if so most hospitals and big offices never buy printers.
Yes.
Okay. So if the printer is not working, that guy will just come dump another printer and go.
Yes.
So I think rental agency will have the responsibility of immediately replacing a machine which is not working. So as of now. So otherwise, if you buy and then you go and buy something which is of second quality, third quality, used car kind of thing, and if it fails, then baby is at risk.
Yes.
So as of now, I have, suction machine they can buy, simple things they can buy. Monitor is also quite expensive, reliable one. The oxygen concentrators are very cheap now because they want to shed it because during COVID, so I have had 1 or 2 families buy oxygen concentrators.
Okay.
I don't know. They bought it mainly because I think they were going to relocate to Bihar.
Okay.
Because there was no rental agency there.
Yeah.
But abhi kam mein mil raha hai na.
Correct.
So
yes, sir. Anything you want to add?
I think it's around 60,000-70,000 when you buy it initially. Must be cheaper than that if you are trying to offload it with 30,000-40,000 or so. But as you said, noise becomes an issue and the rest.
So ultimately, this one we have to guide them that this one they can't rent, and we have to help them that these are the options and let them decide. Sometimes I have seen, sometimes some families get doubt whether the hospital is having any vested interest in the promoting all this one. So we have to be very clear that these are the options, and you can inquire, and we will ensure the quality control and specification should be our role. Now this is another phase comes. So switching, the baby is on hospital machine. Now we are trying to send the baby home. Now this home machine has arrived. Now switching is going on. So that hospital machine CPAP, now we are switching to home CPAP. And then sometimes it works, sometimes it doesn't work. And so what are the difficulties you find in switching phase?
So basically, if you're an NABH accredited hospital, you cannot use any equipment which is not yours, we have not examined.
Yes.
So see, if I've done something, I want to use that equipment. At least for half an hour, 1 hour, 2 hours, if not for a day, so that we check it. So then it's a discussion you have within your risk team and say that let us try this, make sure that this machine is working and then going. Then having checklists actually help. So, I think you have that slide later on. So one is you need to make them aware of what things they need at home. So electrical safety, electrical supply, fire hazards, they should not be open flame near oxygen. All those things that we have in hospital, same thing has to happen because the last thing you want is that. then they will have extension cords like this, multiple extension cords, the sparks will come. So we have to ensure all those things. Unfortunately, we do not have an agency which is mature enough to go and check all of these things, but we personally make them aware. First is the safety.
Yes.
Second is the equipment familiarity. So it is easy to do home oxygen. It is easy to do IVs and other things because somebody else does it. It is easy to do gastrostomy. It is easy to do OG feeds, NG feeds rather. The BiPAP machines, we have always had the vendor to come and try on the patient.
Yes.
And then 1 or 2 hospitals have had a problem with that. Then I had to go and explain that. Then I said, you ask your biomedic, our biomedic to check for electrical safety. You're only worried about electrical safety.
Yes.
And the second thing the hospital is worried about, I cannot bill BiPAP for 1 more day.
Yes.
I tell parents that the hospital is still going to bill although you're using it.
Yes.
Because on the system it is showing.
Yes.
So this is in preparation.
Yes.
So that way everybody is happy.
Yes.
And part of my job is to make everyone happy.
That's good.
I would have won an election.
because what we see is biomedical engineer of hospital, then nursing in charge of our NSU, and the home care provider. All 3 people, when they sit together without any interference from the routine work, usually we deserve to do it by post-lunch session, like afternoon time, 2 to 4 o'clock. They set up, they put something, and suppose they are not comfortable. Biomedical people, they suggest some changes, some leak is there. Common problem is loose fitting. So that particular thing should be settled in actually under supervised situation, as you pointed out. So these are the switching phases. This is quite crucial. Next thing is hospital equipment to home equipment. So that successfully transition is there. Then we allow the home equipment to run in the hospital. Home equipment allowing to run in the hospital. Then we see whether it is causing any problem afterwards, and then only discharge. Now, what are the challenges to parents? The challenges, actually, parents are actually nervous. So what are the challenges to parents you face? What are the parents must have talked with you when they come back? Sometimes they call you. They can't come back also. So baby is stuck at the home, this one.
So I want to add another thing.
Yes.
Like with AI and all, the recent, has the thing changed in the last 4-5 years?
The parents have changed. The chat GPT, anything immediately you say, and chat GPT has a bad habit of not saying it doesn't know.
Okay.
It will guess what answer you want and it will give you. So if I say that, are the doctors asking me to use this equipment because they don't want, it will agree with you.
Oh my God, okay.
Yeah. So one thing it doesn't do is, I don't know. Don't ask me this.
Yeah.
It never does that.
Correct.
Okay. So right now, I think we have covered most of this.
Yeah.
So constantly I bring the focus back onto the baby. I say that I have looked after your baby for 1.5 months, 2.5 months, 3 months.
Yes.
I want the baby to stay in, and my responsibility will be to guide you, will give you red flags. You will know when to come back, but still the immediate troubleshooting you will have to do.
Yes.
Having said that, I do not want you to become a nurse or a doctor.
Yes.
I want you to be a medically aware, slightly upskilled parent of a baby who needs care at home.
Yes.
So let me take you through the 5 things that you need to know. So most of them, then calm down. You have to remove that God complex we have as doctors. No, they start getting that.
Yes.
They get very institutionalized. I know my baby better.
Yes.
So I said, don't do that. They have a lot of burnout. So they have to constantly explain to the relatives why doctors did not get the baby out of oxygen.
Correct.
They lose sleep. They lose employment.
Yes.
They're working, at least in Bangalore, they're all working for some other time zone.
Yes.
So they don't get sleep. They start over medicalizing or ignoring. So I have a baby who had a completely bad set of lungs. And this father would take off the oxygen every now and again, wishful thinking. And the baby would simply, on occasions, just lose weight in the 3 days.
Yes.
Okay. And then I had to do a sleep study at home and convince him that the baby is going towards pulmonary hypertension.
Yes.
So then put the fear of God in them and say that don't lose the baby now.
Yes.
So each situation is different, but I think your classification of technical, medical, emotional, and training kind of covers it all.
Yeah.
Thank you.
These are the precautions. These are the four things which can go wrong. One is injury, air leak, aspiration, discomfort. So among them, what are the in your experience? What are the reasons for which baby has to be rushed back to the hospital?
So I always say, if you're in doubt, you just come back. So I never train the parents to put the NG tube back.
Yes. Okay.
So I say that if you're even in doubt that the tube is not in place, don't feed, you come, get checked. That's a very simple thing. In ER, we can do that and send you back home. So never do that. They usually come because poor feeding and aspiration. Aspiration is the usual late, but we train them a lot. We train them that never force feed the baby, never do all these things. But if you feel that this has happened, you see what you can suction, you increase the oxygen, and immediately come. We provide a lot of emergency backup numbers. So when they call, I train them what to ask for. You ask, because they go around this thing. They start with, we had switched on the TV today evening, say shuru hota hai. I said, you tell me whether you want an ambulance sent, whether you're coming to the hospital or you're just going to ask a question. Don't lose me in the thing. So if you're worried, we will send you an ambulance, you come. If not, this kind of troubleshooting, you come. So aspiration, we have to train them. So first aid, we have to train them. They should always have a working suction. And they should not reattach, redo anything at home. So this is what even the home care nurse, I don't expect them to do, because somebody doesn't come and somebody else is filling as locum who doesn't know anything. So parents will know better than the nurses.
Definitely. When in this situation, we have got a protocol that actually ambulance should go to the house. Don't expect them to come. Now, ambulance goes there, we are secure. A person who can bag the baby, person who can suction the baby, person who can change the tube, person who can manage this one. And then that person calls the NICU about vital signs and all. Then life becomes bigger. Because sometimes there can be underestimation or overestimation from parents. We can't depend on parents' report in that situation.
Rahul, one more question. How much do the parents get trained in the NICU? That is the most important part. If you want to do home care, if you don't get a lot of training doing the NICU,
what we do
impact is
before discharge, at least 7 days. Before discharge, at least 7 days, the mother or father, or preferably both, have to spend at least 4 to 6 hours in being with the baby. Means this one cleaning the interface, suctioning, feeding. They should be completely trained. Then we ship the baby to room. The mother and baby with the machine is living in the room for another 1 week. Then they go home. So it is a very gradual, graded procedure. It is not suddenly ICU to home. First of all, ICU is ICU to family centered sort of ICU. Then is mother and baby together, and then discharge. Once that transition is done, then they won't feel also actually. They are already trained in care of the baby.
Then there are specific things. So for example, trachea. Most of the babies on trachea die by trachea being blocked. So 1% of the babies world over die by tracheostomy tube getting blocked. So they need to know, because they sleep and they may not know. So it's very difficult. So you have to train them, and if the tracheostomy tube falls out, what to do? So we always provide one size less. They put something in and come. So they never lose this thing. Gastrostomy is easy. They have to come within a set up number of hours, otherwise the tract will start getting closed. Home oxygen, as you said, interface cleaning, training, suction. If most often is the machine has stopped working. So if they have an oxygen cylinder spare and they know how to open it, you might have to train simple things, because if you're in a panic mode, you don't know whether clockwise is opening the cylinder or clockwise is closing the cylinder. So I say C and C, or I say imagine you're closing a tap. So what do? So you open the tap, you do anti-clockwise. So everybody would be opening taps on a daily basis, because sometimes they've just closed the oxygen cylinder and come. So these kind of simple things we'll have to teach.
So this teaching is very important, and it should become a routine. If it becomes routine, then the family gets quite confident and competent also. Sometimes competency and competency is inversely proportional. I have seen. Sometimes some people, they pretend to be too much confident. We know everything. Actually, they are not competent. Sometimes they are actually good, but they don't have confidence. So what we do is, rather than depending on us directly, we put some anonymous person, unknown person, to observe them when they are observing this one, and they give a feedback whether it is really safe to send the baby home or not. And that particular person should have veto power. If he says that this baby is not safe, in spite of all those things, we have to cancel the transfer home. Now, these are the challenges and these are mitigations. These are medical, technical, logistical, caregiver, psychological, and financial. So out of that, how will you handle the finances? My main problem, this one will be, now this particular baby is being managed, this one, and this baby, as you said rightly, requires readmission. They develop bronchiolitis, they develop aspiration. Now this baby is not going to come to NICU. This baby is going to go to PICU now. Now PICU charges are higher than NICU. And sometimes they insist that let me go back to NICU. So how do you handle this conflict of interest now?
So I think the billing side, they need to understand which team and which place is more suited. Not only getting a baby who has RSV back to NICU may not be appropriate because there is no warmer which will take the baby in, but it is a risk for other babies. Yes. So sometimes what I've done is I assume shared care with PICU, saying that it is often not billing, it is often not this thing. It's often they're so attached to the NICU nurses and doctors.
Yes.
So and as long as you say that I'm going to have a shared care with this thing, and then I keep coming and seeing. I'm slightly dual trained, so I can look after a little bit of PICU also, unless it becomes too.
So baby can be in PICU, but being taken care by NICU nurses and doctors also.
So I think we can do that.
That's good. So these are the home care provided tasks. These are this one, that particular person should be trained in vital signs, breathing, oxygen saturation, feeding, weight, and recognizing warning signs. These are the checklists we have to confirm, and then only we have to discharge. These are the checklist, quick checklist of home ventilation nurse. This is checklist we use when any nurse comes, suddenly declares that already I know home care, but she's doing home geriatric care, not neonatal care, many times. So these geriatric sisters, they tell honestly that I have not, this is the smallest baby I'm handling. But looking at the body language, we know that they're scared. So in that case, we ask them few questions, and whether they are really suitable or not. If they're not suitable, we have to reject them.
Any AI enthusiasts? No. So I have a tech friend who creates his own GPTs. So recently he tried one on me. So he has created a GPT for elderly home care, where the nurse just describes what she is seeing, and that translates into what is the GCS, what is the the AI can be used like that, where a semi-trained person actually talks in local kind of observational language, but the AI then picks up green flags, red flags, and immediately alerts you. So I think there is scope.
Yes.
People who can design their own GPTs and other things, they might be able to do.
Yes. Yes, sir.
So, question: is there any curriculum for training for home care of?
No, at present there is no. So geriatric is there. Neonatal or infant children at present there is no. So actually, this urgent need to start that.
We need to start. So I think that's something which can be looked after.
Yes.
Yeah. APAM has some guidelines about transitional care, British Association of Perinatal Medicine, but that is very specific for NHS.
Yes.
That is to save the NHS rather than save the babies. So
in our department we earmark few people. Those people who can be good in NSU can be very bad at home. Once they come out of that ecosystem, they can't function. But there are some people who can function in all ecosystems. So we have to select those doctors, PGs or registrars, and those doctors only can go for home visit. So once they go for home visit, these are the things they are supposed to see, and they have to see for that whether the care is going on a right track or any change or any cancellation to be done or not. Now these are the top causes of readmission. One is respiratory infection, apnea, bradycardia, hyperventilation, secretions, airway obstruction, equipment ventilator issues, feeding and aspiration complications, as we discussed in past. So I would like to ask you how you guide them about maintaining asepsis in home.
So the asepsis is something that they would have seen us doing all through. Yeah. So in fact, I empower them to ask us whether I've cleaned my hands. So teach them hand hygiene. Teach them how to clean the surfaces, teach them how to clean the patient and equipment interface, and they will do. It is their baby, they usually do.
Yeah, so at this point we'll end our discussion. So in the future, this particular decision to send the baby on respiratory support or ICU-like situation should not be a frustrating. It should be planned and successful. Then only our home care will complete, and these babies will do very well. Thanks a lot to all the panelists for this one, the quite good interaction. Thank you very much.
Thank you.
Any question from audience? Yeah, GBM time. Okay, thanks a lot. Thank you.
Thank you, sir. It's a wonderful discussion. Now I request Dr. Rahul Anand Yadav, sir, to hand over mementos to our panelists. Our next session will be regional collaboratives for AMR in neonatal sepsis by Dr. Saranya, and Dr. Jyoti Prakash sir will be moderating this session.
Started the timer?
No, wait.
Good evening, everyone. I think everyone is in the mood to get to the GBM, so I'll try to make it as short and as interesting as possible. So in the next 10 minutes, I'm going to try and tell you about why we need to do regional collaboratives for AMR and neonatal sepsis. We're going to concentrate only on NICUs and not on the bigger picture. So is AMR a real challenge? It definitely is, and more so in the NICU. Because what we know is, though most often our cultures come back negative, most of our cultures come back negative, still we tend to continue, and our antibiotic utilization rates are very high in the NICU. And also this is made worse by the challenges made worse by various protocols all over India, and we have variation in prescribing rates also. The most important thing in the NICU, how it differentiates from AMR in other areas, is we have a neonate who's come to us fresh and who does not have an established microbiome and is trying to get the mother's microbiome, the healthy microbiome. But what we have done is we've put the neonate in an artificial environment and instead giving all the pathogenic microbiomes. So this is not just with regards to necrotizing enterocolitis, all of us talk about that, but it is the bigger picture as to how this is going to influence the entire immune ecosystem of the baby himself. And NICUs become constant reservoirs of these MDR organisms. Now, what really jolted us and make us take notice of this was the 2016 Dennis study from 3 major units in Delhi, the Vartman Mahavir, Lady Harding, and AIIMS. When they looked at, I think all of us knew for a long time that we had MDR organisms, but this study kind of put us into the real world and told us that nearly almost 64% of our flora was actually, our pathogenic flora was actually gram negative. Until then, we were more following the Western data, where if you see early onset is more GBS, and late onset is more of cons and Staph aureus because they are central line associated. But for us, there is no big differentiation between early onset and late onset. Almost the pathogenic flora are the same. and a considerable part of it was actually contributed by Acinetobacter, we know Klebsiella and E. coli. That study also told us that the MDR rates were very high as about 82% in Acinetobacter. And even among our gram-positive organisms, the methicillin resistance was very, very high. So this called for kind of an urgent action among not just neonatologists, but even government organizations and professional associations. And we began to see that, even resistance to higher antibiotics like broad spectrum, like carbapenems and third generation cephalosporins was fast emerging. If we want to look at more recent data, this was published by Apollo Hospitals, Navi Mumbai. It is just a descriptive review study, but this is the most recent that we have. This was not just NICUs, it was also looking at PICUs, but 78% of the studies were from NICUs. And they actually saw that the commonest gram-positive was Staph aureus and the commonest gram-negative was Klebsiella pneumonia. And very, very interesting or upsetting to note that Klebsiella pneumonia, 96% are resistant to ampicillin, which is okay, but 75% are resistant to gentamicin, which is our go-to drug most often. And even to cefotaxime, 63% are still resistant. So why do we talk about regional collaboratives? Many things we talk about individual changes in the unit, but why here regional collaboratives? Because infection control or antibiotic policy cannot be siloed out. So when you work in silo, it's not going to be as effective as having units come together and form a collaborative. And it's easy to benchmark yourself when you have universal data or you have unification of data. You can benchmark and say, where am I? And you can also get help from other units. And scaling it up is also easy. So, in case one unit does a few reforms or changes, it's easy for you to adapt from it and make changes in your unit as well. So let us look a little bit at global evidence before we go into the national scenario. So the a very good quality control, quality care collaborative that all of us are aware of is the California Perinatal Quality Care Collaborative. And under that, they had the Optimizing Antibiotic Stewardship in California NICUs, the OASCN. This is almost looked at as the gold standard for collaborative initiatives. So by collaborating between 28 tertiary care NICUs, what they could do was they could bring down their overall antibiotic utilization rate to 15.3%, which was actually over and beyond what they had anticipated when they started the collaborative. The most important thing was there was no increase in early onset sepsis or nosocomial infection rates throughout the period that they did the intervention. The way they did it is by doing a driver diagram. The driver diagram is you look at a primary aim and then you can have a primary driver and some secondary drivers. And what are the changes that you are doing to get to your secondary drivers and thereby to your primary driver? So by having a driver diagram, they could achieve these results. The other thing that I would like to touch upon is the Illinois Perinatal Quality Collaborative. This is again in the state of Illinois, and they had an initiative called the BASIC Initiative, that is Babies Antibiotic Stewardship Improvement Collaborative. They aim to reduce antibiotic exposure by 20% in near-term and term infants and reduce antibiotic exposure by 20% at 36 hours of life. So the strategies that they used was educating the nurses and parents, using risk assessment tools, making sure they drew cultures before starting antibiotics, hard stop at 36 to 48 hours of antibiotics, so on and so forth. And they could also achieve significant results. From their baseline, they went to about 32% reduction, and they had 28% reduction in starting rates of antibiotics. Now, there are various frameworks which are available for regional collaboratives. I don't want to go into details, but like the CDC framework. So there are frameworks that we can adapt for our Indian scenario. The other common thing that we know is the Vermont-Oxford network, which also did a similar antibiotic stewardship in 143 centers. And they could actually reduce the antibiotic utilization rate from 16 to 12%, which was significant because they had tertiary level 3 units from all over the world. Now, coming to the Indian scenario, Our challenge is that our staffing ratios are very low, our NICUs are overcrowded, and then we have a high burden of MDR sepsis. So what is the best model that we can adopt in India? I think it should be the point of care quality improvement. All of us know that this is the WHO CRO AIMS model, and most of our quality initiatives are actually modeled after this. So you form a team and you do an analysis of what you want to change and what is causing that problem, and you get PDSA cycles around the problem that you want to change and look at how you can sustain that intervention that you have done. Is it possible to do it in the Indian scenario? We have had numerous examples of how it's been successfully done. This is from Jaipur. They actually used the POCQI framework, and they could actually bring down total antibiotic usage by 32%. And they increased their 48-hour hard stop of antibiotics from 16 to 54%. So it's important to understand that it's possible in the Indian scenario. We have another example from a southern state, that's Kerala, which has implemented the Kerala, it's called the KARSAP, the Kerala Antimicrobial Resistance Strategic Action Plan. They looked at it at different levels. They strengthened their district hospitals and their district labs, and thereby educated physicians and parents equally. And this has been a very successful program. So now, what are the barriers and what are the solutions that we can look for in the Indian NICUs? One barrier is that, like we already mentioned, very low nurse to patient ratio, and you are dumping on them another initiative that you want to do. So how can you make it easier for the nursing staff and other support staff? Maybe simplify protocols and have a uniform protocol among many units, so they have support from other units as well. If you do not have 24/7 lab to report the 48-hour culture, you can probably do a hard stop at 48 hours by looking at the clinical status of the baby instead of going by just cultures. These are just some examples. And if you do not have automated EMRs, it's not necessary that you have the best of EMRs. Even by paperwork, you can still achieve a good antibiotic stewardship program. So the recommendation for individual neonatologists would be start using some AI tools like sepsis trackers and sepsis calculators. Focus on stopping antibiotics at 48 hours. Join forces, make smaller teams at your individual level, and then collaborate with other hospitals, and be very, very focused on infection and prevention control practices. Now, we've listened to big things, but is it really possible? Is it practical? Is it possible? Can we do it in the Indian scenario? Many of us must be thinking this is just big words like go to McKinsey and it will come up with a 40-page report as to how to do committees. But I think it's really possible. So no talk is complete without giving you a few key, really practical, actionable points. I'm going to end in just 3 minutes. At the NNF level, what can we do? We can probably implement a universal database of at least all the accredited units and the district hospitals in our country. We can have some incentive. It does not have to be a financial incentive. For when that come into collaboration, we can have some technical assistance, some training assistance by which the units will be on board with us. When units enroll for accreditation, maybe we can make the antimicrobial stewardship and tracking AUR mandatory for them. And you can have, we do KMC, we do breastfeeding celebrations during the newborn week. Maybe we can start reporting our own antibiotic usage rates as part of it. So that will bring in some competitiveness and make it easier for units to adopt it. still 60% of the time that organism is sensitive to that particular antibiotic, meaning your in vivo and in vitro sensitivity is very different. So don't just change based just on your susceptibility report, but put a little bit of clinical thought into it as well. If your baby is responding, don't jump the gun and go on to broad spectrum antibiotics. So with small things like this and regional collaborations, I think we can go a long way in bringing antimicrobial stewardship to our country as well. Thank you for the patient listening. Any questions? I'm glad to take. Sorry, so question? Oh.
Did you notice any difference between the preterm and term based on the underlying microorganism?
Yeah, most of the studies report more of AMR, MDR organisms in preterm cultures. Definitely, yes. Most of the studies have actually looked at very low birth weight neonates.
Specific organism, any specific organism in preterms particularly?
Most often in preterms, they have reported more of Acinetobacter rather than Klebsiella, and in terms, it was more of Klebsiella.
Yeah. What precautions you are going to take when you notice any MDR baby resistance? You are doing anything separately or same protocol you are following for all the babies?
Main thing is to isolate. Yes. So isolation, that is the main thing, because you do not want the MDR to spread. And then after it is done, go back and look at your antibiogram. So antibiogram is not just a one-time thing, it's an ongoing thing. So, yearly or every 6 months, you review your antibiogram and see if your, sensitivity has changed. So those are two things that definitely need to be done. And obviously, if there is an outbreak, then do an outbreak analysis. Yeah.
Any questions from audience side?
Yeah. Thank you, ma'am. Now I request Dr. Jyoti Prakash to hand over a moment to Saranya, madam. I request next speaker, Dr. Pankaj Garg, sir. The topic is regarding RSV numbers and do not lie. And, Dr. Jyoti Prakash is going to chair this session.
अभी से टाइम शुरू कर दिया है So, thank you so much, Dr. Saranya, for highlighting a very important issue. By the way, Danish study was not done in Lady Harding, it was MEMC. The other center was MEMC. Not a problem. So I'll be speaking on a topic which is very relevant, and you also saw just a presentation with Dr. Rahul that the babies come back. One of the commonest reasons is RSV. The RSV numbers don't lie. All infant production is the Nirsevimab, which is a RSV monoclonal antibody with extended half-life. See, it's a very famous saying that eyes don't see if the mind doesn't know. We know that if you've not seen a disease, you feel it does not exist. But for that also, if there's a room which is darkened, I know that there are some people here. I can't see them if there's no light. So light is important. That means you need to know about it. Only then your eyes can see what is happening around. So if you want to prevent a disease, first of all, you should know that it happens. Then you should know that whether I can treat it. And then most important is whether you can prevent it, and is the prevention is very scientifically right. So we started seeing this disease in 2018 when we happened to airlift two twin babies from Allahabad. They were 36 weeker, 1.8, 1.9 kg. They shifted to us at 5 weeks with distress. It was being managed with bacterial sepsis requiring ventilation. It was not getting better, so they decided to come to us. You can look at the baby's lungs. It looked like a right upper lobe, some haziness, the other baby having haziness in both the sides. We also expected it to be some infection. We sent all samples, everything was negative. But by that time we also had with us multiplex PCR. We looked at a multiplex PCR and it detected respiratory syncytial virus. You can look at the date 5th March 2018. That means we knew at that time it is RSV which is there in our country, and we started looking at it more holistically. We have now BioFire in our hospital. This is a representative sample from our hospital. Out of 643 samples, the 122 of them grew RSV. This is not only my hospital, all centers which are using
multiplex PCR for respiratory tract infections, especially in younger infants, will have similar figures. That means we know that we were dealing with a viral bronchiolitis. The evidence for the treatment of RSV bronchiolitis is very limited. We only have superficial nasal aspiration possible, oxygen therapy, feeding and hydration. There is no sanctioned antiviral drugs, and we know ribavirin does not help. And what can be done is only supportive management and waiting for babies to come out of ventilator. So that is why prevention holds the key. Now let us look at some of the peculiarities with RSV. RSV is a ubiquitous infection. All of us sitting in this hall have contracted RSV at some point of time. The only problem is the natural infection gives you very short duration protection. That means that you can get recurrent infections with RSV. Adults get only upper respiratory tract infection. But once you get your first infection, and if you get your first infection in first 6 months of age, there are higher chances that it goes to the lower respiratory tract, causing bronchiolitis and bronchial pneumonia. That means a common age group where it strikes is first 6 months of age, and especially in the first 2 to 3 months is the most crucial time. It not only licks the lungs like bronchiolitis and viral pneumonia, but also bites the lung. That is where it's causing more chronic lung disease like changes, like lung damage and bronchitis and asthma. So a disease of higher morbidity, we all see they may require ventilation, and mortality, 2%. Exclusive breastfeeding, which is the commonest in this age group, does not protect you completely. These babies get lesser RSV, but they still get RSV. They get lesser mortality, but they are still mortality in exclusive breastfed babies with RSV infection. Hygiene and use of face masks are other two potential benefits which can prevent RSV, but they are also not foolproof. So can we have something which can really prevent these babies? And that is what I am going to talk about, a long-acting monoclonal antibody, which appears to be a best solution for this as of date. What is this? This is a disease which is common in infants or everybody. How many episodes? 120 lakh episodes of it is happening in the country, globally. 22 lakh admission. That means around 17% of all RSV bronchiolitis will land into hospital, and 66,000 deaths. That means almost case fatality rate of 3%. Definitely it is higher in countries which do not have support system, lower in good centers, but yes, mortalities do happen. And we have lost babies because of this, any one of us. So it is the commonest in first 6 months, 63%. Also, it is not only causing bronchiolitis, it is also causing damage to the lungs, like something like COPD or chronic lung disease. It is already a child of CLD will definitely damage its lungs. These children are more likely to have asthma later on in life also. Also, they are more likely to have secondary bacterial infection, whether it's Streptococcus pneumoniae, staph, and H. influenza, needing more prolonged stay and more antibiotics in the hospital. So I've tried to emphasize upon you that RSV is a disease which can kill, 3% mortality, will be hospitalized, 17% of all RSV infections, and not only that, long-term sequelae also happen like asthma. Now, if you look at mortality alone, RSV is responsible to deaths caused by rotavirus plus Streptococcus pneumoniae together. We have a rotavirus vaccine in the country, we have a Streptococcus pneumonia vaccine in the country, but a disease which is causing deaths, which is equivalent to two of them together, is not yet being used. So why so? Can you look at this mosquito or a lion, which appears to be more dangerous to you? Is it lion or mosquito? So mosquito is more likely to bite you, each one of you. That means mosquito encounters, RSV encounters are so many, that is more dangerous than a lion. That is why we should think that RSV is a significant disease which can really kill infants. We started knowing about RSV long time back, but always we look at an anti-vaccine. First RSV vaccine was launched very early in 1965, but unfortunately this vaccine led to a very non-neutralizing antibody which got stuck into the throat, and non-neutralizing antibody along with RSV led to more significant disease. So that is why this vaccine could not see the day of the light of the day, and after that this vaccine has never been approved. Even the recent mRNA vaccine in infants was not useful because it's causing more disease. So that is why we are looking at other solutions. We have pelvizumab as a solution, which was a shorter acting antibody launched in 1956. 1958, and now we have the antibody which can really solve the problem, which is a long-acting antibody, which is a pre-fusion F conformation mapped antibody, because some changes have been done in the biochemical profile of the antibody, so it is lasting for 5 months plus. So this is nirsevimab, a recombinant antibody, one vaccine per season. It
minimum duration of protection is 5 to 6 months. It has been shown that it can inhibit the entry of the RSV into the cells, so that can prevent damage. The number of studies are there, whether the medley study, which is done in preterm babies 29 to less than 35 weeks, to show it is 70% effective against medically attended LRTI, 78% efficacy against RSV hospitalization. Melody study, which is done in bigger infants, more than 35 weeks, showing that it helps. Similar safety in Nirsevimab and placebo groups has been documented. Now, biggest trial done so far is Harmony. It is done in 8,000 children which are born in France, Germany, and United Kingdom. And at that time, it's shown 83% reduction in hospitalization due to RSV LRTI, and very severe RSV LRTI hospitalization was also reduced to the tune of 75.7%, meaning thereby that it can help. So whether it is only for developed countries, to a lot of developed countries like US, UK, Australia, Canada have already approved it is the first antibody to be given after birth. But countries like Chile also do use it in a pilot mode and show that even in developing countries is shown reduction in RSV hospitalization, admission, and all-cause mortality. So much so in 2023 in Chile, there were 19 deaths in this pilot project of 143 children. And in 24, after this vaccine was launched, there was not a single death which was reported. That means it helps. So whether their recommendation is placed, the recommendations by WHO, which is recommending it to all infants less than 6 months, CDC recommends it to all infants less than 8 months, and beyond 8 months for high-risk infants. So let us look at these antibodies at glance. We have a Palivizumab antibody, which is there only a short-acting antibody only for high-risk population, and a Nirsevimab, which is a long-acting antibody, which is for all infant indication, including preterms, including congenital heart disease, including normal babies, and the dose is different. It is less than 5 kg, 50 milligram, more than 5 kg, 100 milligram. Beyond 8 months also it can be given as 200 milligram. That means 2 shots on either side. Now the key message from my presentation is that RSV bronchiolitis is a disease. You have to open your eyes. You have to look at multiplex PCR for all children less than 6 months who are admitted with you with pneumonia, and you start seeing RSV bronchiolitis. Etiology is possible in today's era. We know treatment is supportive only. There is no definitive therapy. Only oxygen therapy, ventilation, suction can help. Prevention then holds the key. Breastfeeding, hand hygiene, use of face mask for adults, no kissing for infants less than 6 months by older siblings and adults in the family. Palivizumab is being used currently only for high-risk neonates, less than 29 weeks, congenital heart disease, and CLD patients. But Nirsevimab is an option for all infants. Efficacy at proposed dose is 74.5%. It is better than Palivizumab, and because it is better, Palivizumab, at least in US, will not be available after 31st December 25, and I'm sure the same is going to happen to other parts of the world also. And it is a single dose of vaccine, single dose of Nirsevimab at the beginning of the session. So this vaccine we had a number of meetings with NNF also, and today the last meeting happened, and NNF is also issuing a statement, a policy statement of recommending that RSV vaccine to be used for all infants, irrespective of the time of birth, irrespective of the season of the baby. The first antibody should be given at discharge or at birth, whatever is suitable to you. This recommendation will be published it's already recommended by NNF now in the recent meeting just held 2 hours back, and it will be in your circulation very soon. Thank you so much for your patient hearing.
Thank you, sir. Now I request Dr. Jyoti Prakash to hand over memento to Pankaj, sir. Our next session will be nutritional support for moderate to late preterm infants. Is breastfeeding enough? By Dr. Anta Chaganti, and Dr. Rahman sir is going to chair this session. I request Rahman sir to hand over memento to Jyoti Prakash sir. Come on, inko memento.
Jyoti Prakash sir.
Thank you, sir.
Good evening, everyone. Thank you for giving this opportunity to present the topic nutritional support for moderate to late preterm infants. Actually, is breastfeeding enough? Why this matters? Because the incidence of this moderate to late preterm infants is about 74 to 81% of all preterm births. This is the more percentage is more in preterm births. The moderate to late preterm births are more common, and we used to see all these babies in daily practice and how this group of infants are defined. So moderate preterms are like the infants born between 32 to 33 plus 6 weeks is known as moderate preterm infants, and 34 to 36 plus 6 weeks is known as late preterm infants. And these infants usually weigh between 1.8 to 2 to 2.5 kgs, so they are known as great pretenders because they usually their weight wise they are looking good, but when these babies face so many problems in feeding and they have different nutritional needs than full term babies. So last trimester of pregnancy, why these babies are crucial means last trimester of pregnancy, critical time for accumulating stores of energy and nutrition so that the infant needs in the perinatal period will accumulate, and these babies are lack these stores. So early postnatal growth and nutrient accretion can influence long-term growth and neurodevelopment and health of these babies. So suboptimal nutrition in these babies can lead to associated with extrauterine growth retardation, impaired organ development, and potential long-term consequences leads to metabolic and cardiovascular diseases. So the features specific to these moderate and late preterm infants are particularly they have immature sleep-wake patterns, so are asleep for longer periods than term infants, and immature oromotor function. They cannot attach to the breast and drain it effectively. May need other feeding modalities like orogastric feeding or spoon feed sometimes. So and they may have gut immaturity, morely like to experience feed intolerance also. So these need higher nutritional needs, and immature feeding practices are the more common problems they come across. And as we all know that the maturation of the sucking, swallowing, reflexes and breathing coordination, etc. As we all know that less than 28 weeks, no proper sucking efforts, no propulsive gut motility, and sucking bursts develop after 28 weeks to 31 weeks. So we usually have guidelines for all these babies less than 28 weeks and 28 to 31 weeks, but there is no proper guidelines after 32 to 34 weeks baby born. So we what we have to do is after 32 to 34 weeks the baby is born, we have to first try with the latching whether they are taking the feed properly or not. We have to check if the baby is taking breastfeeds well and attaching and at least 10 to 15 minutes baby is sucking well, means okay, we can continue with the breastfeeding. If the baby is not taking well and the weight is not appropriate and the baby has difficulties in latching, then we can give spoon feeds or pallida feeds. So for all babies the best milk is the breast milk, mom's own milk. So why feeding challenges occur in these infants is like poor lack, weak sucks. this may be useful in long-term outcomes. So expect recommendations for preterm infants, especially very low birth weight. Standard practices are there, but for moderate to late preterm babies, the timing, quantity, composition of fortification, all should remain debated, and risk benefit needs to consider feeding tolerance, growth targets, and long-term outcomes. Therefore, individualized, closely monitored nutritional plan should be there, including breastfeed fortified with supplementation may be needed. So practical recommendations promote and support early and frequent expression of mother milk in preterm infants, ideally as soon as possible after birth. Usually within 1 hour of birth, we encourage breastfeeding, and whether to express or direct breastfeeding in all preterm. Use fresh mother milk, or if pasteurized mother milk is the other alternative. Even though some substances will destroyed by the pasteurization, but that is the ideal milk for prevention of NAC. For moderate to late preterm, if growth is suboptimal, consider fortification, appropriate or we can consider appropriate preterm formula also. If the mother milk is not available or pasteurized milk is not there, then we can consider the preterm formula. So multidisciplinary care is needed for moderate to late preterm infants growth. A neonatologist or pediatrician or a dietitian or lactation consultant should be involved in the feeding of these babies. So is breastfeeding alone enough? Means if required, if baby is not gaining weight or not taking difficulty in taking milk, then fortification should be done. In these ideal is human milk fortifier, MMF is there, and other alternative cost effective one is the preterm formula. We can use preterm formula for fortification in some low socioeconomic settings. 1 gram powder should be added to some 25 ml feed for fortification. We can use that one also. It is cost effective. So to be supplemented in these babies should be vitamin D 400 international units per day, iron from 2 weeks of age, and iron 2 to 4 milligram per kg per day starting from 4 weeks, calcium and phosphorus. If we are not giving fortification, then we can use calcium phosphorus supplementation also, and zinc and multivitamins often needed. So takeaway is preterm infants have elevated nutritional needs compared to full-term infants. Breast milk provides vital immunological and developmental benefits, reduces risk of complications. But unfortified human milk may fall short in protein or energy for growth for many infants. Fortification or supplementation is advisable. So close monitoring of growth and nutrition in partnership with neonatology and lactation supports is critical. Otherwise, they will come across with challenges like low weight gain, jaundice, and the dehydration and jaundice are more common in these babies. We usually come across the in OPDs. So thank to all the breastfeeding moms. Thank you.
Thank you, ma'am. I request Dr.
Thank you, sir.
I request Dr. Rahman sir to hand over momentum to Anita madam.
Can I take 1 minute? Just 1 minute. So, friend, good morning, good evening. As per the NNF Constitution, we have to hold this annual general body meeting at 6 o'clock. But since quorum is not complete, so we are going to adjourn meeting for 30 minutes.
Only 10 minutes left, sir. One more talk.
Last one more talk.
One talk.
One talk is enough. 10 minutes is enough, sir. Okay. I request Jyoti Prakash sir to hand over momentum to Rahman sir. Next session is about anemia in preterm infants, preventable or inevitable. Dr. Devdeep Mukherjee sir. Dr. Anita madam is going to chair this session.
Good evening. I guess I am the one holding off GB meeting, so I'll try and be quick and finish off the talk for today. So it's 10 minutes on anemia and prematurity, whether it's inevitable or it's preventable. So briefly, the agenda will be looking into the background and the physiology of neonatal hematology, looking at the causes, the risk factors, and the complications of anemia and of prematurity, looking at the preventive and the management strategies, and a bit of evidence, guidelines, and conclusions. So we all know that anemia of prematurity is actually a multifactorial process, and there's a whole lot of thing going on behind it. So it's partly developmental, partly nutritional, and also a lot of iatrogenic factors that are involved. It's a normocytic, normochromic, hyporegenerative anemia that's seen in preterms, and it's characterized by a low hematocrit and a retic count without any evidence of ongoing hemolysis that happens. And the presentation is usually within the first 4 to 8 weeks of life. So the question remains whether it's inevitable or we can prevent it. So let's look into what are the inevitable factors behind it. We know that the severity of the developmental postnatal decrease in hemoglobin is most pronounced in the babies who are born prematurely. And they are particularly prone to develop cardiorespiratory illnesses. So we need to do lab workup. So there's a lot of blood tests which happen, and as a result, there's a lot of phlebotomy loss. And it is the combination of developmentally regulated physiological processes along with the pathologic and the iatrogenic process that contribute to the anemia in these preterms. So why are they more vulnerable, and why are we discussing about them? So we do know that in the third trimester, there's a lot of fetal iron transfer which happens, and these preterms are born early, so they're devoid of these stores. And there is this truncation by prematurity which also contributes to anemia in these babies. Now, there's a shift in the placenta base to a lung-based oxygen supply, so the oxygen tension rises, and as a result, there's a decline in the erythropoietin concentration, and there's a marked decline in the retic and the nucleated RBCs, which happen after 5 to 7 days of age. And we also know about the shorter fetal and the neonatal RBC survival, so 60 against 120. There is also a reduction in the percentage of the erythroid precursor cells, which declines from 35% to 15% or less. And there's a progressive left shift of the oxygen dissociation curve that happens in these babies. There's also a postnatal increase in 2,3 diphosphoglycerate, which allows a greater release in oxygen from the hemoglobin, along with the cardiovascular mechanisms and the stress, which contributes to the progressive anemia. So looking at this, we can see how the hemoglobin level dips in preterms, and the more preterm they are and more smaller they are, it's more significant dip and can reduce to 6 to 7 grams per deciliter compared to term infants where the dip isn't that profound. Now, looking at the physiology contributing to anemia of prematurity, well, we know the physiological contributors, and we discussed about some of this. And then there are the non-physiological contributors, which are the lab blood loss, there is an inadequate nutrient intake, and there is infection and sepsis. So this was RCT from 2005 published in Pediatrics, and if you look at the weekly phlebotomy losses which was found, it was quite significant in few of these studies, so anything as high as 20 to 21% as well. So that's significant blood loss in preterms who have got a very limited blood volume, and this also contributes significantly to the anemia in these babies. Now, this anemia contributes to compromised oxygen delivery, increases the cardiopulmonary workup, so causes tachycardia, tachypnea in these babies. So there is feed intolerance, poor growth. So there are increased morbidity which arises out of this anemia. And recently, I mean, the focus has been a lot more on neurodevelopment as well. So it can be quite profound if it's not monitored closely in the neonatal unit. So how do we manage it? Or are there ways by which we can prevent it? So transfusion therapy, yes, we'll look into that as well. A bit of erythropoietin use we'll discuss, and a lot of nutritional support is essential. And then look at the preventive strategies, which is the more important focus of present. But overall, it's about a holistic neonatal care to minimize the risks of anemia of prematurity. So therapeutic strategies, yes, blood transfusion is something. We shall look into it shortly, and then there are the preventive strategies which we'll discuss. So this was published last year, and the consensus as of now is on our restrictive transfusion strategy. So a lot of things have to be factored in before we are thinking about transfusion, looking at the hemoglobin levels, the clinical status of the baby, whether the baby is on any form of respiratory support, what is the cardiovascular status of the baby, how is the baby growing, if the growth has been adequate over the course of the last few days, what are the comorbidities that are associated with it, and then also looking at the unit policy of transfusion and definitely partnering with the families in arriving at a decision before we think about transfusing them. Then looking at the erythropoietin stimulating agents, so a lot of research has been happening of late, but there is no consensus as of now about routine erythropoietin usage. So it can be done early, it can be done later. So lots of trials ongoing. So but there is no single consensus whether it should be done routinely in all preterms. But the focus has been a lot more on reducing the phlebotomy loss, so microtainers, microsampling, using the cord blood for grouping, and being very judicious and monitoring them clinically on the unit, and monitoring and regulating the losses, clustering all the tests together rather than doing it multiple times, and the focus recently has been on point of care testing as well. The other bit which the NRP has also focused on is on enhancing the placental transfusion. And we know that one half of the fetal placental blood volume, that's around 110 mils per kilo, remains outside the newborn's infant circulation at 30 weeks of gestation if there is early cord clamping which is done. So the entire focus has been on delayed cord clamping of late, and the 9th edition also recommends delaying it by at least 60 seconds. The 8th edition mentioned 30 to 60 seconds. Umbilical cord milking, not much of role in less than 35 weekers. So if we look at this now, so erythropoietin, no clear-cut consensus yet. Reducing phlebotomy losses, yes. Enhancing placental transfusion by means of delayed cord clamping, yes. Being judicious and cautious while transfusing RBCs. So yes, these are actually the preventable areas where we can look into to minimize anemia of prematurity. So finally, to summarize, enhance placental transfusion by delayed cord clamping, make it mandatory where feasible. So use the cord blood for initial tests if needed. So we can do a cord gas. We can also do the blood grouping from there. Phlebotomy losses should be reduced. Nutrition should be optimized in all preterms, and the individual transfusion guidelines and policies of the unit should be followed. So I've presently shifted to a new unit, so it's around 18 months. So this prematurity day, we had around 18 less than 32 weekers, with the smallest one being 25 weeks. None ended up receiving a transfusion before leaving the unit. So we have tried to be quite judicious with the blood sampling that we do. We go more by clinics rather than by repeated blood tests. So thank you to the NNF branch of Andhra Pradesh. Thank you to Central NNF for giving me this opportunity. This was 2 days back at RK Beach. So thank you very much.
Thank you, sir. Thank you for excellent presentation. That was great that you have not given any transfusion for 25 weeks baby. That is very great actually. We have to give nowadays the extreme preterm babies are more, and we are giving the transfusions more frequently. But you have done good job, sir. Not giving
Thank you so
any
much.
transfusion. Thank you, sir.
After the 2-week stable baby, how frequently will you use routinely for weekly? Do you do weekly exams?
Not exactly. So go log by clinics, how the baby has been behaving. If the baby is otherwise stable on minimal respiratory support, gaining weight quite adequately, we just tend to follow it up. Maybe bi-weekly, or so it's in the initial week that we need frequent tests, but once they are on full feeds, on minimal support or off respiratory support, we don't really need to do much if they are quite stable, isn't it?
Only baby to pay.
Absolutely. Absolutely. No, we don't go by that anymore. Sorry, sir? Yes, yeah, definitely. Yeah, I mean, it's quite individualized at the moment. So the last NHS guidelines is something that we usually tend to follow. So if they're on not on any form of respiratory support and the hemoglobin's more than 10, we would just try and carry forward and monitor them.
Thank you, sir. Such a
Thank you.
wonderful presentation. Now I request Dr. Anita ma'am to hand over moment to Mukherjee, sir.
डॉक्टर देवरून किधर है?
लैपटॉप लैपटॉप कनेक्ट करो।
हाँ, ये चारों टेबल चेयर साथ साथ होनी चाहिए, कोई आपस में बात करनी है। हाँ, chairs have to be kept together. Yes.
लैपटॉप कनेक्ट है ना सर?
ये तो बड़ी है, कौन सी है?
नहीं दिखता ना, नहीं दिखता।
हाँ, नहीं दिख रहा है।
साइड को दे डाले तो चेयर वो टेबल डाले तो दिखता है।
ये कनेक्टेड है? इट्स कनेक्टेड?
उधर रख दो, या इधर रख दो, इधर यहाँ से सीढ़ी
चलो जल्दी।
कौन सी टेबल?
छोटा टेबल।
सर तो कॉफी टेबल
हाँ छोटा।
टाइम लगेगा उसमें ना।
इसको निकाल
टेबल
दो।
चाहिए।
इसको निकाल, इसको साइड में
चेक
पानी पानी के लिए भाई रख दो। हाँ, वाटर बॉटल वगैरह रख दो। वहां लगा दो, ऐसे लगा दो। हेलो,
It is.
Initially thought we should have for a deeper way. Seeing the size, no, then I forgot about it.
शुरू कर दें रवि डॉक्टर रवि डॉक्टर रवि डॉक्टर अमित डॉक्टर उमेश वैद्य और कौन है डॉक्टर सोमशेखर उमेश सर डॉक्टर रवि सचांग अच्छा नहीं उसका तो नहीं है ना अच्छा 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 नहीं तो आ जाओ अच्छे चेयर लेके आ जाओ आ जाओ रवि सचांग आ रहे हैं सर डॉक्टर लल मैं एक बार
डॉक्टर सोमशेखर
डॉक्टर सोमशेखर
फोन कर लो काफी है अब तो गिर जाएंगे लोग नीचे यहाँ रख दो एक इधर
आइए ठीक है मैं बस एक बार वेलकम करके फिर आपको देता हूँ
वेलकम एवरीबॉडी
अमित अमित So, good evening, esteemed member of National Neonatology Forum of India. So, I officially call this general body meeting of NNF 2025 to order. So, before I proceed, can I request a silent prayer for 1 minute for we have lost some of the members. Thank you. I warmly welcome all the office bearer, President 2025, President-elect 2026, Vice President, Treasurer, Secretary, immediate past President, all the EB members, and all the respected members to this journey. Yeah. You just you keep on guiding. Yeah. No. So you have to guide me. Yeah. So I assure you that the quorum has been completed because this meeting was started at 6, but there was incomplete quorum. So we adjourned for 30 minutes and we resumed this. So we all know this annual general body meeting is heart of the our organization that review the past action, deliberate on the present, and shape the future action. So there are certain rules for the general body meetings. I urge everybody to address the chair. Before speaking, introduce yourself. Then stick to the agenda. So may I request our secretary, Dr. Amit, to proceed with the agenda.
Good evening, sir. Thank you for permitting. Thank you for permitting me to present the agenda. After condolence, I would go on to confirmation of minutes of the last AGM. Minutes only. Books. Can we distribute the annual report book here? ATR.
This was already put on the website and sent to the member also, Amit?
Yes.
Huh? Yeah.
I will tell the ATR action taken report as the minutes were placed by 31st of January. They were placed on the website. Pani ji. Ye mic hai. Acha, yes. So confirmation of minutes was done initially. Adoption of annual report was done, and please see the compiled annual report which has the budget as well, and the activity is done over the year. Once you see that, we can approve it unanimously. A major part of AGM last year was changes in constitution or constitutional amendments, as it was called. Those amendments were also circulated, and they have been, after a long time, they have been now registered. The changes have been registered with the Registrar Society, and we have attached the signed copy of the constitution as well, and you have been distributed the new or amended constitution has been circulated. Do you all have received the new constitution? अभी printed वाला भी मिल गया? अभी दे रहे हैं. So we'll be distributing the constitution right now as well.
एक बार ऐसे दिखा बढ़ा दो.
Yes. अब दो तीन लोग डिस्ट्रीब्यूट कर दो. बेटा दो तीन लोग सब डिस्ट्रीब्यूट कर दो.
अभी इसको बढ़ा दो.
Yeah.
Just run कर दीजिए इसको एक बार.
So Dr. Ajay Gambhir case, it is still sub judice. Next hearing is in just
Amit, ये एजेंडा पहले वाला एजेंडा पहले पास कर लेते हैं. Yes.
Okay. So
first agenda was the minutes of the last year AGM. So if you have seen that, can anybody propose, and then we can second it and pass that agenda. Ramesh is proposing.
And Dr.
Dinesh is seconding. So agenda number 1 is passed. Now move to the second. Okay, that was agenda number 2.
Yes. So business arising out of the minutes. Anybody wants to discuss any point? किसमें? नहीं, हमने तो ATR देखी थी अभी. इसके अंदर कुछ there was nothing. हाँ जी सर. So Dr. Ajay Gambhir case, it is still ongoing. Next case is next hearing is on 17th of December. New office renovation partly done, and partly it still remains. The company which made it has not been responding, and so it was reasonably okay now. So we are just withholding any more renovation, and sale of hold office has some bottlenecks. Freehold, they say that our office doesn't have freehold. नहीं है. तो उसको पहले आपको फ्री होल्ड लेना पड़ेगा बिफोर यू कैन सेल इट ऑफ. Taking free hold costs NNF about 20 to 30 lakhs. So probably इसके ऊपर थोड़ा काम करने की आवश्यकता रह सकती है. Listening to that cost, we just held over and we thought we'll take guidance of AGM before we move forward. हाँ, ऑफिस खाली है. It was discussed in the AGM about giving it on rent. Then it was discussed that हम rent कैसे बार बार देखा वो करेंगे. हालांकि it can be given on rent if we don't sell it. We can just if the AGM approves, we can give it on rent as well. So if sale is not feasible, that we can take it like this. If sale is not feasible quickly, then we can try to give it on rent as well. So minimal rental, we probably can't fix now. That will be decided by the market forces, which we can inquire and yes. Yes, sir. ठीक है sir. ठीक है sir. 20 to 30 lakhs. That is what was told to us. We'll make a new committee this year.
So we will make a new committee to look into the matter, whether to sell or whether to give in on rent, seeing the cost around 30 lakhs is required to make it freehold, right? But before selling this property, we need to make it freehold. That is necessary. So anyway, we have to make it freehold as per the.
We'll try again.
Yeah, we will try for
again
making
with new people. Pardon, sir? Cost. It was just the cost. So, yeah.
Sri Silam, can you use the mic? And also.
So sir, I would say
and this is also recordable.
I would say that we had decided to have a new committee, which last year the committee which was made, many people withdrew from it, and so we will make a new committee this year, and we will just apprise you soon again on that.
Withdrew because it was complicated or some issues were there?
Nice. It was complicated, that is why, and some have health issues, some became high office bearers somewhere else, and they said we can't come over. So multiple times field visit was discussed with them, but nobody could come over there.
We have budget,
So-
isn't it? We have that.
The budget is there, but point was that if we spend so much and then we want to sell totally on a white as well, so the costs, the margins for sale are very less. So that is why it was
Amit,
withheld.
one clarification, like once we make it into rent, then does it affect your charitable society status? Because we are going to get profit every this thing. So that part we need to be taking just some insights on that.
We can note that point and ask our legal advice on that as well.
I think that's
You
correct.
can ask Amit. You can ask from the CA regarding that, because there is issue regarding the ATG also, no? So that will affect our.
There's one more thing. If somebody comes on rent and decides not to go or not to give rent, then you have additional troubles which we don't want to
That
get
was
into.
discussed in last AGM as well, or the year before, and after that only it was decided that not to rent it but just to sell it off.
We should not lose our charitable society status
Yes,
because
definitely.
we get profit.
Yes.
The moment you get periodic
I
profit.
agree.
No?
So
Charitable trust can have many incomes.
No, make it, that's fine. If it is legally clear.
But there is a lot of response. If you are giving on rent, then you have to maintain that property. There is a maintenance cost.
Sir, whatever you speak on the mic. Otherwise,
mic, distribute a few mics. आप नीचे कुछ mics.
I think charitable institutions can have.
Sir, could you
multiple
introduce yourself first?
Yeah.
Yeah, that will be better.
Yeah.
So they want a certificate. So that's why repeatedly I have sent a mail also. Just please look at this. So that actually the person who is going, he is not getting any money,
Definitely.
but at least he should get a formal certificate from the central NNF.
So I think Jagdish, this is a very small issue. Certificate.
Dr. Sahu, अगर आप मेरे को एक बार भी कहते, I would have made sure that you receive a certificate.
सर आप देवरन को मेल
ना
दो बार किया है.
मैं किस लिए? अगर इनको 2 बार में नहीं हुआ, I would request anybody कि कोई काम ऑफिस से नहीं हो रहा, you pick up a phone and call me or message me. और तब भी नहीं ऑब्जेक्शन होना चाहिए. सर्टिफिकेट नहीं मिला तो बिल्कुल ऑब्जेक्शन होना चाहिए.
Okay.
Very smooth so that पहले से होना है. कि last time he's busy.
आप कुछ भी रहे सर, मेरी responsibility.
Jagdish, you
I take it as a personal responsibility.
Jagdish, you are part of this thing executive. Yes. Okay. So
yes.
Myself, Dr. Ramesh Chaudhary from Jaipur. Now the matter of certificates arises. I just suggest make a paperless certificates, e-certificate, whenever. I think that could be without an issue when we send the list to the office issues. And
good, very good suggestion,
So,
Dr.
we'll
Ramesh.
save that.
Thank you.
It has to be e-certificate.
Next,
and
move to the next.
You can print it as well. So this is all what we had in this. So can we pass the annual report? If yes, sir.
I'm Alok Bhandari from
Yes, sir.
Delhi. We have to follow some guidelines regarding signatories on our certificates and on our mementos also. Like in today's memento also, there are 5 signatories from the local authorities and 3 from central NNF. This for the faculty, scientific faculty and all. And treasurer of local body and a joint organizing secretary bears his name and signature on the memento, but our national treasurer is not having his name. So we should at least, it is a central NNF Neocon, all the mementos and certificates should have office bearers of NNF over there. If we have to add local organizing,
We will see sir किस तरह से convention चल रहा है और उसको देखते हुए we will follow that.
Sir,
I will
advice well taken.
Sir, could you stick to the agenda?
Sir, I suggest please.
Yeah, we can have that in any other topic with.
We will discuss on that.
We can't have separate agenda coming out of place.
Okay, sir. Thank you.
Thank you, sir.
Sir, I am Dr. Vaidishwaran, Treasurer, Tamil Nadu, NNF. Sir, regarding agenda number 12, regarding NNF life membership, so all are becoming members of national NNF, paying annual membership fee to the NNF, and we are not collecting any money to the state NNF membership. So it is not only a matter of money, but also a binding with the state NNF, because state NNF has its own bylaws to collect the membership fee, official membership fee, to become them official members of state NNF, for them to become eligible for voting in the state election. So we don't have any members. By law, only 30 people are registered with our society who are members after having got a subscription fee. They are eligible to vote. So we just get the members of 700 members odd from the central NNF, and all are voting. So how it is? It is not only a part of money; it's a legal membership status.
So very valid point. We discussed the same issue in the EB also. So we want to discuss on this issue. Any other comments from other respected member regarding this financial distribution of the membership? Any other comments?
Sir, I think opinion regarding the voting, other major or national organized bodies, what they follow. When every year, like our central NNF office does, we have to register the amendments with the Society of Registrars, and the membership also has to be updated regularly. So these 30 that Dr. Vaiti was mentioning was probably the inducted members. You are supposed to update with the Society of Registrars every year with the updated membership list. And I believe the office sends this to all the state office bearers every year. So I think that is just following the procedures. And regarding money, I think we should have amendment in the constitution for whatever you need to discuss regarding money.
Actually, there should be a written thing from the central NNF. So and so members have become members of central NNF.
you make them official members of state. We have collected the, as though we have collected the membership and following whatever that is membership fee fixed for state NNF, whatever amount that is fixed for state NNF, that should be shared from the central NNF, or that has to be collected independently from the state members by ourselves. So anything, whatever that is fixed as per our bylaw.
So अभी कोई fixed by law नहीं है अभी, but we are in the process. It will be done soon. So last time also it was discussed. जहाँ तक कि आपका जब when new registration happens with central NNF, then we are trying to have that email automatically goes to the president and secretary of that state as well.
So we are not receiving any.
So that is deficiency on our behalf at the moment, because the website team which handles our software, that is trying to do, but we have not been able to pursue it. So I admit as a lacuna, and this we are in the process of getting it done. So I think next time in near future we will not have this problem. But if you keep on calling me, sir, it has still not happened, I would be happy, and we will pursue it strongly.
So Amit,
there were two issues. One was
so I'm just coming to the constitution which was amended on 17 on page number 13, 17 item page number 13. The life members of the NNF are allowed to establish city, union territory, state branches within the framework of the memorandum of association of NNF. So as Vishnu said, all the members of the state, if you are having a state NNF branch, should be member of NNF. So they are supposed to be the member of NNF. So when this constitutional amendment happened last year, I think that was the point when this proportional subscription could have been amended. Now another constitution committee would have to be formulated and things would have to be needed, and it cannot be done retrospectively. किसी ने 2000 में membership ली, मान लीजिए 10% भी हम fix कर रहे हैं, तब उसका 200 रुपए बनेगा या करेगा, और अब किसी ने 10,000 में membership ली है, उसका 1000 रुपए लेगा. अब बोले हमारे पास we have 1000 members.
Obviously जो भी चीज होगी prospectively होगी.
Prospectively हो सकते हैं, क्योंकि आप 1000 member का 10% 10,000 के rate से नहीं ले सकते अभी. You cannot ask 10,000. That's fine. So that is
just one at a time. I would like to answer sir's question. The problem which our website person was having in sending automatic reply was, he said that email of secretary and president of a state keep on changing very frequently. So I would request that, like NNF has one email ID, then every state should have one, like we have nnf@nnfi.org.
I would request Dr.
So all states should have one standard, then this will be very easily done.
I have a solution to this, which he's mentioning. Can we have Dr. Lalan a common email for all at the NNF server? So the NNF server will have the email of Tamil Nadu, Karnataka, Gujarat, and it will be remain with the central NNF, and you people have to kind of transfer the email from one president to the other president. So then that will get sorted out.
Password can be changed, and office can make a standardized NNF for each state, and with president and secretary. And then you have it. You can change your password as per you, and every year it can be changed. And so that will be good. So and NNF office takes that as its job. We will do that.
And the second point with respect to money, I think we could have done it last year in Chennai. It was a good time, but now we have to wait for another 3-4 years when the next committee comes.
Sir, ma'am, just a minute. हाँ, और बोलना सर, मैं ये कहना चाह रहा था कि ये करने के लिए do we need a constitutional amendment for sure? अच्छा ठीक है सर.
Yeah, ma'am. Please introduce yourself. Yeah.
Ratna Kumari, Tamil Nadu NNF. I mean NNF Tamil Nadu. This, by becoming a member of NNF itself gives the rights to become the member of the state by default. So that has to be taken into consideration. It's not a separate membership.
Yes. Well taken, ma'am.
Problem, ma'am, ये है कि state का जो member बनता है वो automatically center का नहीं बनता. Reverse is true.
They become central and
So हम सबको request करेंगे कि हर state और city का जो member है वो center का भी बने.
What becomes automatic? Which state?
Please speak to the chair, sir. Please speak to the chair. Yeah.
Yes, sir. This point Dr. Ratna Kumari has told that becoming a member to the central NNF automatically makes a member of the state, which state they become, the state from during which they become member, or they go to another state and settle down, do they become member of that state? See, that question need to be answered.
Sir, for this matter, to whom that particular member belongs, or the address?
Is it national, it's state nationality or the state where they settle? I now reside in Chennai. I became a member from Chennai, Tamil Nadu.
That's
so
fine.
you call me Tamil Nadu member.
Yeah.
Tomorrow I may come to Karnataka and settle. To which membership I still belong?
Exactly, sir. So let me respond. If you are moving from one state to another state, just respond. Just give an email that I have moved from this city to that city. Your email address, your address will be automatically updated into that state.
And address gets updated.
Yeah.
Where will I get my voting right?
Yeah.
With the new address.
With new address.
That you have to spell out. I
That
become
you new
now a
address.
Karnataka
That is
member.
our constitution.
Yeah, that portability, you have to spell it in the constitution. Yeah.
So that.
Yeah, that's like a mobile number portability. You have to have my membership portability to another state.
It is already there.
It's already there, sir.
It said, if you can say, it
Yes,
said
Dr.
it becomes the already automatically becomes the that is state members.
Sir, can I speak? So I was looking
Yes,
at a
sir.
state affairs.
Yes, sir.
The issue is that many state members in the previous old members, they're not yet, they're state member or not central members. And whenever the elections are held in that state, they give them voting right. So we can write a letter to all the states that anybody who is not a member of center will not be given any voting right in the state election.
It is already mentioned. in
No,
the
no,
new
it
constitution.
was used in Karnataka, sir. It was a
Sir,
big,
ये
big
अब
problem.
constitution में
That
है
should
ही
be
already.
clearly mentioned that your state only state membership number will not held valid for election. That is the thing.
ये इस constitution में आ गया है और उसमें ये है कि you can't be president, secretary or treasurer unless you are national member.
That is okay, sir. But people are using, they make 100 members and then they use them for elections. You clearly write to states that if you are not a central member, you will not be allowed of voting out in the state elections also.
Sir, let me please, I would like to refer your constitution, page number 13, 17, 4. 17 clause and 4th point. All the members of the state or union territory state branches must be a member of central NNF. If a state is not having adequate member of NNF life member on its own state branch, the life member residing in the such state can join the state member and joining state with all the privilege and rights of the member of that particular state branch. So that means those who are having the state member, if they are moving again different state, they becomes an automatically state that they can avail all the privilege of that state branch and becomes of course they are the national member of the central NNF. So it is already spelled.
Yeah. I think the discussion started with the question of dividing the membership fee. When a person becomes member central NNF, then certain amount should go to the state. This is the system which IMA uses actually.
Yeah.
But in NNF, this system was not there since beginning. Probably there were 2-3 reasons for that. Number one, that there was central NNF, but state NNF branches were not there in many states. And there were also some district branches.
Mike.
District branch will also say that give something to me also. Then after an amendment a few years back, now we have state branches. They are independent registered bodies in that particular state, and they are affiliated with central NNF. That is the relationship now. Now, a person has to, if a person wants to become a member of a state branch, then he or she has to fill up a form and submit some registration fee there. Because I remember that I paid membership fee for the central NNF and also for the Delhi branch separately. So that's we all have given it.
We all have done.
Yeah. Yes. So I think this is not a simple thing. I think it needs more discussion. There are pros and cons.
Sir,
everything should be thrashed out before taking any decision of distributing the membership fee. Yeah.
Sir, actually, with the Constitution, when the Constitution Amendment Committee sat on this and discussed this, this point number 17, which deals with state, and city branches, and even city, UT, district. We did not go to the district branches because branches were to come under the state unit of the NNF. So it was in fact, the city branches should also come with the state NNF also. So this also tells about affiliation to central NNF. And when we are doing this point, as rightly said by Dr. Somshekar, last year this proportional subscription or coming back, because now you cannot make them members on your own because they need to be member of central NNF. So all the registration fees subscription fee will come to central NNF only. So if that is the case, probably some but we have written that finances, all state branches will be allowed to raise funds by ways of subscription, advertisement, registration fee for program permissible under the ethical code for their activities. So we gave some reasons that they can have some local subscription if they want over and above that. But this is all we have asked. We have asked the committee, Constitution Committee had asked, and this is what you all passed in the last AGM.
Ajay, Dr. Ajay.
From Delhi. I have a request. If any member wants to change his membership from, say, Tamil Nadu to Karnataka or something, a copy of the request should be sent to the original state president as well as to the new state president. Like he wants to shift to Karnataka, a copy should be sent to that president also, so that they can add his name to that register. Otherwise, it just remains with the central NNF.
We should have a meaningful membership drive, right? The membership starts. So we should have a meaningful membership drive is a considered from privilege and all.
So Vendu, yes.
We need to increase the membership. The government has to think what incentives and what privilege and what meaningful some incentives should be given for membership, giving neocons and all.
So already a membership drive is going on, and discounts have been given.
No, NNF has been doing it. During all the zonal conferences, we are doing it.
It was circulated to all states groups just before Neocon.
As of now, even today, the special drive is on. Today, if anyone wants to take the membership, there's only 7500. Otherwise, it's 8500.
10,000. Otherwise, this 10,000.
Yes.
Yeah, it is.
Our request is
yeah, please.
To make it not to time bound. You just say first 1,000 members will be till 7 or make it.
सर देखो, इसको पहले भी कई बार डिस्कस हुआ है, उसको बहुत चीप करने की everybody said that, मतलब इसको इतना कम ना करें, because membership के people should be becoming members, सब bodies के membership fees के around ही है हमारी. So बीच में ड्राइव रखना ही ठीक है, otherwise पूरे फीस पे जो बनता है उसको he feels cheated कि मैंने क्यों दी membership fee.
I have a suggestion. Sorry, please.
Yes, sir.
Can we increase the registration fees to 15,000 rupees? Because I think we because we require money, and I think it's important.
Yeah.
Yeah.
Association of Neonatologists, which was earlier alien. We did not got alien NF logo and alien NF got from the society registration just because of that. NNF is also a body and it's a headquarter in the land. So just because of this disparity, because two bodies cannot have the same name, we asked them to have Delhi chapter, including NNF Delhi chapter. That is also not accepted by the society registration. So my request is that if NNF can give a circular to the ministry, yes, the state chapter can use our name.
This is not possible, sir. This is same for all organizations. Even IAP, you can't be Delhi IAP branch. So logo can be used.
Logo can be used.
So वो तो आपकी जो state laws हैं, मतलब वो state laws हैं. हमने कोई rule नहीं बनाया कि आप ये नहीं कर सकते. We only made it after states had this law. अब आप क्योंकि national नहीं लगा सकते किसी में.
National India.
10 साल से 10 for since 2015 the rates have not changed. In fact, yes sir, same rate. Sir, same.
So,
Rate बढ़ा दो.
okay, sir.
Okay.
We have to move on now. But some
Next.
discussion is also required.
We have to learn many things from IAP. For example, IAP has a mail and they usually send all activities from the central IAP to its office bearers all over the state. We don't receive any NNF email and we are not being updated. For example, starting from the new team, sir, can you just convey to all state bearers to give your new office bearer president email so that you can send 1 year mail throughout so that branches can do activities. We are not aware of this mandate.
Very well. Yeah, yeah. Very.
Second thing is that we are having so many members who have become NNF members, but we have they yet not have got any number of receipt from this.
Very valid suggestion, and our Vice President, Dr. Umesh Vaidya, will be taking care of all the state's affairs. So, sir will be taking care of them. Very valid suggestion. And office will be sending the mail to all the President, Secretary, and Treasurer to update their office bearers' mail and keep on sending the mails. Doctor.
Exactly. So my thing is like we can follow IIT in a certain way. For example, IIT gives a temporary membership for PGs. So we can go like that. During PG period, we can give temporary NNF membership, which will become permanent after graduation, so that it will so that it will be financially helpful for them and it can increase the drive also. And as already mentioned, certain amount has to come to state so that state and district office bearers will show
ये इसका
interest
क्या
to
है?
increase the drive. That is one thing. And one more thing, sir, for everyone, like for PGs and all,
Oh,
for
shit.
general practitioners, it is like NNF is for DMs only, DM neonatology like that. So general practitioners are like they are thinking this is for a city's IAP and for neonatal cities NNF. So there should be more programs, so that everyone thinks that NNF is for everyone. So that is my suggestion.
So I would say that
Okay, point
there is-
noted.
point
and
taken,
we'll-
लेकिन कोई ऐसा प्रोग्राम एनएनएफ का पिछले कुछ साल में नहीं है जो डीएम ओरिएंटेड हो. ऑल प्रोग्राम्स आर एमडी ओरिएंटेड, जिसके लिए जो सुपर स्पेशलिस्ट है उनकी शिकायत आती है कि वील हैव टू मेक अ न्यू बॉडी बिकॉज आपके प्रोग्राम्स आर टू बेसिक. सो इसलिए आई वुड नॉट अग्री टू दैट पॉइंट दैट कि एमडी ओरिएंटेड प्रोग्राम्स नहीं होते. परसेप्शन चेंज.
Dr. Amit, he's right. We have to accept his point that there is a perception. We cannot say कि he's not.
Programs कौन सा है
Perception का problem है.
मनोज सर के
You
कोई
might,
भी program
no,
है?
you might do everything right, but the perception still remains. I think. And, no.
So Rajesh noted your point, and we'll look it into that. जो member
One thing I want to add, at IEP, they have started a student and IEP member, and then it will converted to the full membership after passing the MD exam. So, why we not should start a student membership next category, in which we reduce we have take the half fee at the admission time, and when they get the MD certificate, they will give the full certificate and they will got the full membership. So a new category of the membership will be there. Student NNF member, those who are still studying the MD, and after completion they have the full membership.
Reality is happening. Last 2 years back, in a single day I registered 100 postgraduates.
Can I suggest?
After completing the
Sir, can I suggest to the chair that there are a lot of suggestions regarding membership. So these can be addressed to, all these submissions can be made to, you can make a mail or something, and the chair can make a mail or an address to which all these suggestions can be given, and then based on the suggestions we proceed further. If we keep on, because there are so many issues for which we do not have answer, but the chair should give an assurance to the house that all the suggestions that are given will be looked into, and if found rational, action will be taken, and then subsequently the actions taken can be informed to everyone through email or something, so that we can end this discussion on the membership at this point, if that is okay with others.
So, sir, come with the suggestion. What is your suggestion? So there are that. That is called the associate member.
Associate
that is
members.
associate life member.
It's already there, sir.
For whom that is there? Associate life member is there. You mean that the money should be less?
Which will be looked into, na? You will look at. It's all there.
Sir, okay, point taken, sir. We have to move on as well.
Dr. Lala, President, sir. So with the suggestions which came from Dr. Vedeshwaram, Arasar, other state branches, and Dr. Umesh Vaidya was telling, and since now I'm, as Dr. Divakar told me, that since you are out of the secretary now, I can think otherwise also. Thinking of them, it needs constitutional change to give money back to them for every fees. But for the programs what we are doing, like we are doing Shine program, QRNP program, for which we are asking for subscription or some money. If you're asking for 3,000, that 10% can go to the state. For every program which is being done, every registration done for every program, then you will be earning. If whatever we are, if you are doing 10 programs, you will be adding to some kitty. If there is a 10 programs going on across country, NNF is getting we got 70 lakh for Shine. We collected 70 lakh for Shine in that year. And if we would have distributed 10% to all the branches, it would have made some difference to you. So I think if that is the case, that otherwise it will need constitutional change for till the next constitution to get this proportional money.
Surrender, we are discussing membership.
Yeah.
I'm
doing the
finances
improving the finances of the
we
state.
have to.
Sir, can we just move?
If there is any new point, otherwise we will close this membership discussion.
Yes, sir.
Yeah. Okay. Taken, sir. Just give the suggestion. What do you want? Right now 7,500. What do you want?
No.
For the time being, when they are TG and after they become completed and during this period they can have access to some online free program so that we can actually motivate them.
Associate. Yeah. So suggestion will be considered. Yeah.
The IAP is motivating the PGs more rather than the NNF members. I think all the NNF members to
Kar de
motivate the
5,000.
PGs to attend the NNF conference also, so they can present paper. That's what we should do.
Can you do it the 5,000?
Can we move on, sir? So at this point, I would like to get proposed and seconded for the minutes of the last AGM and for annual report. So Dr. Arasar sir proposes and Dr. Srinivasan sir pass the minute. No problem. Two people. And for annual report of society, if somebody can, Dr. SN Singh sir proposed and Dr. Shantanu Dev second that. Thank you, sir.
Move to the next.
Yes. ये हो गया सर. Updated amended constitution हो गया. क्या चीज सर?
अब इसके अगला वाला
आने दो सर, अगला आने दो अभी इसमें. I propose whatever is next. वो ठीक है सर. एक सेकंड रुक जाओ सर. Audited statement of accounts that has been circulated in the annual report. Please go through that, and that is to be proposed and passed. Proposed by
just hold on.
Yes, I will have yes. Anybody?
Any point on that? That has already been circulated. So, if not,
proposed by Dr. Manazir Ali, sir.
Seconded by
Dr. Braja.
Dr. Braja, second. Are you seconding? Yeah. Okay.
Yes, I got a call from the organizers as well that they are waiting downstairs as well in hall A and B. So, 7 p.m. they had said that they want to begin. So we'll, yeah. Appointment of auditors and fixation of remuneration, that would be done. 10% raise was discussed last year as well, and between 5 and 10% we would do that. Old office has been discussed. Digitalization of office operations and associate challenges. Digitalization is something which we are trying to do, and the challenges are quite a few because the pile of documents which have to be digitalized and scanned is just humongous. And I was wondering if AGM can guide us. What are the essentials which we should digitalize and leave the rest? Yes, sir. Membership numbers and that main issue is, do we need to supporting documents? Are they have to be scanned as well, or just the membership form which is there? And so again, fellowship supporting documents for fellowship have to be, because now it is digitalized already. It's in the app. It's only the old previous ones. And in any case, every 3 years your fellowship this accreditation changes. So I see no point in digitalizing the old accreditation center. Right now we had assigned one of our office members to do it. He was able to do about 500 pages in a day, but they are in lakhs and lakhs. A contract.
Can I speak?
Yes, sir.
I think this was approved, and the procedure, and since I am the in charge since 2019.
Yes, he is in charge of digitalization.
Digitalization, 2019. Every year we were discussing. We have moved somewhat. We have tried to digitize some of the documents. We made a digitization or weeding out policy, which got approved. That weeding out policy that जो 20 साल से पुराना वाला है, जो गवर्नमेंट ऑफ इंडिया का वीड आउट पॉलिसी है, उसके बेसिस पे ही हमने अपना कुछ बनाया कि जो मेजर अकाउंट्स वाले हैं, मेजर फाइनेंसेस वाले हैं, वो हमेशा इन हार्ड फॉर्म में भी रहेंगे, क्योंकि अकाउंट्स वालों को हार्ड फॉर्म में भी चाहिए होते हैं, और उनको अभी हमने डिजिटाइज नहीं किया था. लेटर ऑन विल डिजिटाइज, बट दोज डॉक्यूमेंट्स व्हिच वी वांट टू डू अवे विद, वी विल डिजिटाइज एंड then destroy them. So that can be done, the old ones, and some of the routine कागज वागज जो होते हैं उनको डिजिटाइज करने की कोई जरूरत नहीं है. जो रूटीन कॉरेस्पॉन्डेंस है उनके लिए हमने that weed out policy was made, and I think it is to roll out. I would request Dr. Lalan and Amit कि एक कुछ एक्सटर्नल एजेंसी के लिए you need only, मैंने जो मांगा था कि 25,000 रुपए में अगर 25,000 रुपए का अगर मिल जाता तो एक बंदा अगर 2 महीने 3 महीने में करेगा तो वो कर सकता है. They were ready to do it कि वो सारे के सारे